anatomy like compression of the nerve root on the opposite side, to the patient's relatives also, and to the patient himself after during the preoperative counseling. 3D appreciation definitely helps in reducing the complications related to the depth appreciation. Now, the disadvantages are there is no panoramic vision. Why? As there are two chips which are creating videos and it's a tubular vision. Now, this is a distant use technique. This is the outer tube and the inner tube. And we have a sliding effect in between the two tubes. So the telescoping effect in between the outer tube and the working insert helps us in having the magnification. This zoom effect, by zooming, we can get into the magnified image and have inspection of the operative area. By pulling out the working insert, we can create a working space for instruments and use that space for the surgery. The mobilization of the endoscope in all direction gives panoramic vision with the 3D vision. So you can move around in all direction, cranial, caudal, medial, and lateral, and that gives you the panoramic vision with the 3D. At the same time, like microscope, you don't have to change the focus. This 3D endoscope is always in focus wherever you can move. There is no need to change the focus. So this is something like a mobile microscope. This is suction in the left hand, working instrument in the right hand. You work together. This is the angle. Any depth you can use. So this sliding effect between the outer tube and inner tube helps you in zooming effect and the panoramic vision. So this is how you move around, get the panoramic vision, have the 3D again, depth appreciation with the tubular vision. So patient relatives, in my setup, I usually invite one of the patient relative to make understand the anatomy. After surgery also, patient himself can understand the 3D anatomy, is pathology, disease process, and he can understand the future precautions he has to take. We put the endoscope inside the disc space. So how the disc has ruptured through the annular tear, healing of the annulus, and related rate of the recurrence. So patient education has become quite easy with this endoscope. So single chip to three chip HD image, ultrasonic bone dissectors for safety. So when I was using a single chip, I was very stressful. I thought of using a ultrasonic bone dissector. Nowadays, with the crystal clear anatomy of the 3D, less use of the ultrasonic bone dissector, only in cases of cervical where the corridor is very narrow, I use the ultrasonic bone dissector. And there is a decrease in the steep learning curve. Some different things I have understood also. Synovial cysts, which were not seen on the MRI, 5 to 7% cases I could see because of the depth. I have started using aggressively the nerve root retractor for the disc space inspection. Vascular plexus arterial at the axil of the nerve root is quite commonly seen, which was not seen or appreciable with the 2D. Less use of the UBD in lumbar pathology. Cervical, still I use ultrasonic bone dissector for very narrow corridor. Now, these are the future developments in 3D. Autostereoscopic monitors will help you in avoiding the use of the 3D goggles. Maybe 3D with 4K endoscope is the future. And navigation with the 3D endoscope with something like a artificial intelligence based spine surgeries for exact, adequate, no less or no more bone removal with preservation of the stability. Just like in ophthalmic surgeries, artificial intelligence based technologies. I have used this 3D endoscope for my training module. On the first day, we have a cadaver. Second day, all the delegates come to the OT and have a look at the hand movements and the anatomy and the exposure and the endoscopic picture simultaneously so that they correlate the hand movements with the endoscopic picture. They are in the OT. On the third day, they have a cadaver training with the 3D endoscope for the better understanding of the anatomy. They try off their own with the 2D endoscope on third day. It's workshop only, no lectures. This is what I have presented in 2018 at Hamburg, Saarland University. This is a D1011 intradural tumor and stenosis operated simultaneously. These are the two incisions and patients mobilized, no catheter. And this is after 15 days. So we have to think, are we exploiting the techniques? Maybe a 3D thing is a very expensive thing. Whether for canal decompression with transforaminal approach, fixations, and third port of UB, because in spite of all innovations, spine surgery is still a defamed surgery. Even a medical person initially, at a first glance, does not accept surgical treatment. This is the reality. So, are we failing prey to the industry in search of minimalism in the spine surgery, or are we diverting from the goal? Are we helping the patient in the name of minimalism in spine surgery? Is it helping the patient to understand the exact disease process of the spine degeneration and the pathologies? So reality is a golden standard, 100% result, but our final and unreachable goal is 100% success. You cannot get 100% success, but our reasonable goal or reachable goal is everyday learning, training, and improvement. And this is what we can achieve with persistence of the technique, mastery in the technique, and better visualization with the 3D endoscope. Thank you.
Sir, thank you for a very informative and a wonderful talk. Your demonstration of an intraoperative SOL using 3D technology was amazing. I'm sure all of us panelists here were wondering how you were doing it. And your basic advice to all young endoscopic spine surgeons to dedicate themselves properly to endoscopy, develop the art of endoscopy, is a beacon or a torch bearing kind of instruction to all of us. I thank you very much, sir. Can I request you to stop sharing your screen, please?
1 minute.
So that I can now request Dr. Mohinder Kaushal to start his talk and start sharing his screen. Dr. Kaushal, are you with us, sir?
Dr. Rohidas, yeah, welcome. Hi.
Good afternoon, sir. Good afternoon. Welcome, sir.
Hi, welcome. I hope your show is going on very well. Congratulations.
Thank you, sir.
And I was listening to Rohidas, sir, and so okay, I think my screen is visible, and am I audible now?
Yes, sir. Absolutely, sir. Thank you, sir. Please start.
So I think I got to speak on endoscopic cervical decompression in spondylotic myelopathy, and it's my early experience, the technique which I'm using from last about 2 or 3 years. And just a minute. Okay. So, greetings from Chandigarh, city beautiful. And in the background, I like to say that currently endoscopic techniques have been successfully utilized for approaching pathology in the cervical, thoracic, and lumbar spine. Literature support confirms the efficacy of these procedures with respect to less morbidity, The development of retractor system by Destendu and Foley in the late 90s heralded a new era of minimally invasive techniques utilizing an interlaminar window. So most of the work which I do in clinical practice is through interlaminar window, and I use a tube system. I only go later to parts where I have to address a pathology in the foramina, especially as far as lumbar spine is concerned, I am talking about. And the principles of cervical canal decompression are same as in they apply in lumbar spine. The added advantage of improved visualization and more targeted placement due to the maneuverability of the endoscope and the ability to manipulate the field of view with the optical rotation of the endoscope is the added advantage when you are using endoscope in your armamentarium. And again, the mobile tubular endospine and arthrospine. I use in my clinical practice endospine, the Stendu endospine, and arthrospine view UV system, which is innovated by me. It is an Indian system, you can say. This allows excellent off-angle visualization and the ability to tilt endoscope out into the lateral recess. These principles can be applied for generous decompression of the cord and nerve root when performing a posterior endoscopic cervical canal decompression. Although there is a learning curve associated with these procedures, endoscopic techniques offer a more powerful and a less morbid approach to spinal pathology that ultimately elevates the standard of care when treating our patients. So currently the spinal endoscopic system which are in practice, various colleagues are using the Destendu, EasyGo, arthrospine system, arthrospine UV system, which I started using in 2019. Then UV, which is very popular in Korea, and Dr. Son is a pioneer in UV. And I see more and more youngsters are now following this technique. UV, I think after Korea, maybe it is India, where more and more orthopedic spine and neurosurgeons are showing interest in this technique. Then we have full endoscopic, true endoscopic PSLD techniques, which are there in the choose from. And let me tell you that endoscopy is now established modality of treatment of various spinal disorders. And these techniques are evolving at a very, very fast pace. So we are trying to deliver best so what we can do to adequate job inside, but to a smaller possible skin incision. So the system which I am using in my clinical practices, I call it as the arthrospine view system. It is a patented system by Indian patents. And the advancement of this system over Destendu system is it is a miniature Destendu tube where the instruments can go far beyond the mouth of the tube. And at this stage, surgeon has to switch over to a saline mode if he wants to work beyond the tube, or if you want to go beyond the tube, you want to be very close to the surgical target, then he has to switch over to the saline mode. This is a system where surgeon can work in a dry mode also, saline mode also, and if need be, he can make an additional port and convert the whole procedure to a UVE mode also. So these are the advantages of arthrospine system. And the indications, the applications of this system is, it can be used in prolapse disc, whether it is in the cervical, thoracic, or lumbar region, all kinds of spinal canal stenosis, endoscopic assisted MIS fusions I routinely do now with the combined with the arthrospine and UV technique, and some other indications are there which you can which are there on the screen. And my endoscopic spine surgery journey started in 2002 when I learned endospine technique from Dr. Destendu. Then I somehow innovated system in 2010. And now finally the system which I am using is the arthrospine, it's the second generation arthrospine system. And this is the instrumentation, very simple, same instrumentation what we use in open spine surgery, but same instruments are a little more fine-tuned. Their working tips are not more than say 6 or 5 millimeter, and they are miniature, you can see, open spine surgery instruments. So now coming back to my topic, the surgical options today available with the surgeon as far as decompression in cervical spondylotic myelopathy is concerned is laminectomy, anterior cervical decompression and fusion, or laminoplasty. But of late, we have been talking about endoscopic spinoplasty, a viable option, which I will be sharing my experience in my this presentation. And as we all know, the disadvantages of laminectomy is subsequent kyphosis. It can make spine unstable, and there could be some kind of a laminectomy membrane. And the disadvantage of an anterior cervical discectomy and fusion is lengthy and complicated, immobilization segments, high mechanical demands on the adjacent segment, and clinical and radiological deterioration during follow-up. So, as far as expensive laminoplasty, which is another good procedure for cervical canal decompression, a good technique, very quick and efficacious, and very durable, maintains cervical mobility, prevents kyphosis. Long-term results surpass that of anterior procedures, but it again requires a extensive dissection. So I think, in my view, the way forward will be the best alternative would be endoscopic assisted limited laminectomy and bilateral decompression by unilateral approach, ensuring adequate decompression, thus preserving integrity of contralateral musculature and posterior ligament complex. So my journey started in from 2000 to 2007. I have been doing laminectomies and laminoplasties, open laminectomies and laminoplasty. I started doing endoscopic bilateral hemilaminectomies in I think somewhere in around 2000, maybe 10 or 11, and endoscopic spinoplasty I started doing in 2017. Very, I mean, about say about 4 years back. So the motivation to incorporate this technique into cervical spine came from one of the papers which was published by no less than Professor S.M. Tulli, who is a doyen of as far as spinal tuberculosis is concerned. He's authority in that in India. So this was an article where it is they operated by open method and they reposed back the posterior ligament complex to preserve the stability of the spine. So this is spinoplasty following lumbar laminectomy for multi-level lumbar spine stenosis to prevent iatrogenic instability. And they had a very good follow-up of 3 to 10 years, where none of the patients had neurological deterioration or pain or catch while movement, and walking distance improved by 5 to 10 times, with marked relief of neurological claudication up to 70 to 90%, and pre-operative stooping posture with improvement in sensation and motor power. So there was no significant difference in the sagittal alignment as well as anterior translation. So this was the procedure which motivated me to apply same principles in cervical spine. In fact, Son also does same kind of a procedure. I saw a couple of his videos. So the indications remain where there is a OPLL continuous or mixed, multi-segmental cervical stenosis, or ligamentum flavum hypertrophy, even at single level. And contraindications are focal anterior compression, established absolute kyphosis, isolated radiculopathy, spinal instability, tumor, trauma, infection, where this procedure should not be attempted. Or now this is a demo case where there is a significant stenosis from C2, 3 up to the 4 level. You can see there is a OPLL. And this patient, these are here axial cuts. You can appreciate how the cord is badly pinched. And this patient was brought to hospital on a wheelchair. He was so much spastic that he was not able to stand and walk. So this is the patient positioning as you're seeing here. And I'll just share a small video also if it plays. Hopefully it should play. Yeah. So first step is at spinolaminar junction, you expose in the same way as you do in the lumbar spine. So this is a cervical exposure of the interlaminar window. This is a dry endoscopy. You can appreciate that. So then we start make an entry at the spinolaminar junction to do a sort of a hemilaminectomy. And you can see as you take more and more bites, you can have a glimpse of the dura there. You can use burr also. Burr makes your job very comfortable, and it adds to the comfort, and also cut down on the OT time also. Now over the top, I am working on opposite side to decompress the opposite side of the dura. Here I usually use 2 mm or a 1 mm Carrison punch because the area is very narrow and tight. So you can probe that, and finally I switch over to a saline mode. You can appreciate here, I have switched over to a saline mode. This is a contralateral decompression. And then you see ipsilateral decompression. You must be sure that you have done an adequate canal decompression. And to control bleeding in fluid medium, you have to use these special coagulation blades or RF probe, you can call. So that is the extent of decompression. You can appreciate that. And this is the post of MRI of a patient. You can appreciate how the canal is now significantly decompressed. This is the sagittal view, and these are the axial cuts. You can appreciate how canal has become capacious now. And here you can see the lateral view where the spinous process of L3 and 4 is floating now. So we do undercutting of the spinous process. We try to osteotomize the spinous process where the posterior ligament complex is preserved. And over the top, we go to the opposite side and do a decompression. So posterior ligament complex is preserved here in this technique, as I am calling it that's why I am calling it as a spinoplasty. And very small incision, maybe about 10 to 15 millimeter incision. Through this incision, you can comfortably address 3 levels in cervical spine. And our results we evaluated by as per Murex grade. You can see that this is the Murex grade. According to this, we had most of the patients, they improved. 4 patients had a poor outcome because there were poor chord changes in these patients. And I had one patient which was very unfortunate and sad, where patient came walking to me and she became quadriplegic after canal decompression. So that was the one very serious complication which I came across in my these patients of cervical canal decompression. And my journey in endoscopic spine surgery started in 2002, and I have done close to around 5,000 procedures. And I have not kept limited myself to discectomies and canal decompressions. I have gone beyond the horizon. I have used endoscope as a modality of treatment in endoscopic decompression and fixation in spinal fractures. I have been using regularly to take spinal biopsies, and especially abscess drainage and decompressions, and endoscopic assisted MI fusions. Also, I have been using these novel techniques. Okay, and in 2002, when I was with Dr. Destendu, I think it was his dream that the techniques, these endoscopic techniques, one day should become a established methods of treatment. And I think 18 years down the line, if I look back and see now, I think the endoscopic fever is at peak now. I think every hospital today where there is a spine surgeon, especially young and budding surgeons, so one of them is surely doing these spinal endoscopic techniques. So I think his dream has come true, and he has been truly a teacher and guide. And I'm sure he must be very happy when he must be watching the progress of these spinal endoscopic techniques. And just to share how we can make learning easy, because endoscopic techniques are difficult to master. Learning is also difficult, but surgeon must take their time. They must learn to adequately decompress first, keep going to as many MIS courses as their practice allows. And my philosophy of teaching youngsters is, I always encourage them to you come and visit the procedure first, and then you decide whether you want to take up this technique or not. Then I tell them, you must attend hands-on cadavers. Once they are through with the cadaver workshop, then I tell them, now you go back to your theater and try your first case, and always be in touch with us if there's any problem. we are always there to extend help. And to summarize, endoscopic spinoplasty retains median structures, contralateral musculature with least disturbance of kinematics, mobility, stability, and lordosis of the cervical spine. And need of implants is virtually eliminated. You don't have to put little mass plates or other implants to stabilize the spine. But still, I feel it's too early to say we need a well-designed clinical trials to show the effectiveness and long-term outcome of these surgical procedures is required. And final thoughts, as technological innovations continues to facilitate reproducible surgical technique and expand the indication for the use, we believe that endoscopic spinal surgical techniques will provide surgeons with a more powerful and less morbid approach to cervical spine pathology that ultimately elevates the standard of care when treating our patients. Thank you very much.
Facebook, WhatsApp. Dr. Mohinder Kaushal, a wonderful, crisp, and aggressive presentation as you usually give. It is very nice of you to share a very honest experience on cervical endoscopy, including the fact that you had a patient who subsequently developed quadriplegia. It takes courage to be honest, and it takes courage to teach. And you are truly a teacher, and I think this conference owes you a debt of honor. Thank you, sir. Thank you for a wonderful talk.
Thank you, Malcolm, for the honor. Thank you very much.
Thank you, sir. Is Dr. Ihab Hosni with us? Dr. Ihab, are you there with us, sir? I think if Dr. Ihab is not there, we will proceed with our next speaker. Dr. Noor. Dr. Noor, are you there with us? Dr. Noor.
Yes, sir.
Dr. Noor, can you please start your presentation? We will get Ihab on your time later on. So, Dr.
Okay.
Noor, can you please start with your screen share?
Yes. Mulai.
Please share your screen, sir.
Okay.
Welcome. We can hear you loud and clear. Please start your presentation, sir.
Is it come?
No, we are seeing your desktop. Yeah. We're now able to see you and we are able to hear you. Please start.
Okay. Wait a minute.
Yeah, please be systematic. Take your time.
Can you see?
Yeah, please start, sir.
Okay. Thank you very much for the chairman. Today I will share my experience about using endoscopic spine procedure. My topic is percutaneous endoscopic cervical discectomy, technical procedure in cases. This is my center, Lamina Pain and Spine Center. Lamina is the largest spine endoscopic neurosurgery center in Indonesia, established since 2015 and located in Jakarta. Jakarta is the capital city of Indonesia. We have 4 branches now, and the concept is one-stop services, including spine, pain, and physical rehabilitation. There are 9 specialist doctors work in this center, including neurosurgeons, anesthesiology, physical medicine, and also rehabilitation physician. This is my experience since 2015. We have 1,200 cases, including cervical, thoracic, and lumbar. And today, according to my cervical experience, 99 cases PE-CD surgery, anterior and posterior approach, start from November 2018 and until September 2021. As we know that recent gold standard for cervical dissection are ACDF, anterior cervical discectomy fusion, and also posterior approach, we call it laminotomy. Of course, we know that these 2 techniques have some limitation, like long surgical incision, extensive soft tissue stripping, pseudoarthrosis, degeneration of adjacent segment. Sometimes patient complain with difficulty in swallowing, focal cord palsy, and foreign body sensation. And the other side, PCD have some advantage like less tissue dissection, less muscle trauma, and also less damage to epidural blood supply, reduce hospital stay, of course, and no need interbody fusion and many else. As indication and contraindication of the anterior procedure, indications are contained or non-contained and central or paracentral disc herniation, which is not responding to conservative treatment of appropriate duration with correlative MRI and CT image. And another indication like annular tear with concordant pain and provocative discography. As a contraindication, calcified disc, migrated disc herniation, collapsed disc which is less than millimeter wide, and it is become a contraindication if we found instability infection and also past history of anterior cervical surgery. And posterior approach also have indication and contraindication, and indications are foramen disc herniation, predominantly unilateral arm pain, and also single or multi-level foramen stenosis, and persistent symptoms despite previous anterior cervical discectomy and fusion, and also cranial collar disc migration, and concurrent foraminal stenosis, and failed conservative therapy for at least 6 weeks. As contraindications are axial neck pain, instability, presence of cervical kyphosis, cervical myelopathy, or intercranial stenosis, and many else. This is the instrument that we need to do this procedure. It's very simple, also very small, like endoscope. We need working cannula and also endoscopic drilling, Harrison punch for some size, and of course continuous irrigation saline solution, radiofrequency probe, and C-arm. And as a preparation before this procedure, we need to prepare some radiologic imaging like spinal X-ray, and also the gold standard is C-spine MRI. Sometimes we need C-spine CT scan for some detailing cases. Now, this is anterior approach PECD. This is a very, I know this is a very rare procedure done by doctor at this time. The key point are a target-oriented percutaneous anterior approach, and the second one is adequate annular release before the removal of the herniated fragment, and also precise determination of endpoint of surgery. For our consideration from anterior approach, we must consider with carotid artery, pretracheal fascia, larynx, trachea, thyroid, and esophagus. This anterior procedure usually used with general anesthesia, and position of the patient is a supine position. The neck is slightly extended, head stabilization, neck shoulder padding, and the shoulder are pulled down, and the arm are fixed to the side of the table. And the step is making a marking the level, and the midline are marked using a fluoroscope. Continue with the anterior cervical skin is prepared and draped. We can inject 1% lignocaine, infiltrate into the skin and subcutaneous tissue at the entry point. And the very important is carotid pulse is palpate. Yeah, and the tracheoesophageal complex is gently passed away and displace the tracheoesophageal complex medially and carotid sheath laterally. And continue with needle placement, insert to the target of the disc, continue with the discography, and after discography, we can make a guide wire placement, insertion to the disc, and continue with the skin incision. After skin incision, we inserting some dilators and working portal establishment is very important. And insertion at the last, we make insertion of the endoscope. After endoscope come into the target area, the first we make a soft tissue clearance and locate the herniated fragment. Of course, we do this procedure by using a fluoroscopy as a guidance, and we remove the herniated fragment, also bleeding, control using irrigation and confirm the adequacy of the compression, and finally skin closure. And now this posterior approach procedure. This is some cases. These are some cases. Case number 1, male, 42 years old, come with radiating pain right arm since years ago, and no improvement with many treatment modality. The first step, if we plan skin incision is related to the V point. V point is bounded by the inferior margin of the cephalic lamina and medial junction of the facet joint and superior margin of the caudal lamina. And the skin incision make 1 centimeter away from midline of the cervical spine and less than 1 centimeter need. Usually I make incision only 7 millimeter wide. And next, the obturator, working channel, and endoscope are introduced sequentially. This is a picture how we plan, make marking at the patient's skins. Of course, we use C-arm and continue with the skin incision. After skin incision 7 millimeter, we put in the needle and serial dilator, finish with the cannula, and endoscope come into the target area. The next step, after endoscopy coming into the target area, we have to make a preparation of V point. V point, as we know, muscle attached around the V point, and clear out with the forceps. We can clear out with the forceps and coagulator. And also we have to see the ligamentum flavum. We have to find where is the inferior margin of the cranial lamina and where is the superior margin of the cranial lamina, and starting point of the facet joint are visualized. V point is very important to this procedure. This is how should we clear the muscle using cautery and probe. Cautery should be used very carefully, and we must avoid damage to the ligamentum flavum. And cautery will make a evaporation the muscle until we find the margin of the lamina bone cranially, and also lamina bone caudally, and also in this process we can find the V shape. After we get the V shape, we identify the ligamentum flavum by palpate with the dissector and check the position of the bone and also soft tissue. And the next step is make foraminectomy by using drilling bore. We need 3 millimeter diamond bore, and extent of bone drilling is dependent on the size and location of the herniated disc material. And it is usually we need 3 to 4 millimeter radius on the V-shaped head. And the sequence of the drilling is cranial lamina, continue with caudal lamina, and the last one is a facet joint. This is how we drill lamina cranially and caudally, and then to the facet. And after drilling, we make a preparation of epidural space. We make a flavectomy using Harrison punch, 1 millimeter or 3 millimeter or 5 millimeter. The disc space is exposed and cleared with the coagulator and forceps, and carefully we can make identification of the lateral edge of dura and branching of the nerve root. This is a pictures how we can make flavectomy using Harrison punch. And the last and the important one is make a discectomy. Before discectomy, we should make coagulation of venous plexus and continue with the identification of lateral margin of dura and dissected from the disc and posterior margin of the vertebral body. Remove ruptured disc using endoscopy and forceps carefully, and close with suture with using nylon, and sometimes you can put drain if needed. The second case, male, 44 years old, come with neck pain and radiculting pain to right hand, and no metal weakness and no significant improvement after conservative treatment. This is the MRI. We can see that the problem come from the disc at the level of C cervical number 5, 6. This is the axial view. We can see the fragment come into the foramen at the right side. This is the preparation surgical area. After marking the skin, we start with 7 millimeter incision, introducing serial dilator, and continue with control the level using fluoroscopy, and step by step until we insert the canal and scope. At this video, we start with preparation of V-point using cautery to vaporize debris and muscle, and finding the border of lamina and facet joint. And we continue with keyhole foraminotomy using 3 millimeter diamond bore, sequence from lamina cranially and lamina caudally, and after that we move to the facet. And the next, we make a flavectomy using 1 millimeter Harrison punch and also forceps. And after that, after we see the dura mater, we can palpate all surrounding structure with nerve hub. Of course, we should very carefully and avoid bleeding from this process, and avoid make a trauma to the malum. And the next is discography. We can use endocarmine and discography if you need. And the next step is discectomy. Discectomy is the main step from this posterior procedure. As we can see, this fragment is blue color, and we can take it carefully using forceps. The final one, we should identify the cause of decompression, because the adequate decompression is very related to the clinical results for a patient. The last one, this is the third case, female, 50 years old, come with neck pain radiculating to arm, no motor weakness. This is the MRI. We can see from sagittal and axial the problem comes multi-level, three level from the cervical. Start the operation. The first is clearance, make a clearance and find the fee point using cautery and forceps. And we can see the position of lamina cranially and caudally and facet joint. We use dissector or nerve hook for this step. Continue with the foraminectomy using drill diamond bore, 3 mm. Start from cranial lamina and next to the caudally lamina and move to the facet joint. And the next step is macroflavectomy. We can remove ligamentum flavum using 1 mm or 3 mm Carrierson punch gently. And in this step, we must avoid the dural tear. Dural tear is one of some complication that we can find if we make mistakes. And by using all these instruments, gently we can avoid dural tear. And sometimes, if bleeding comes from the microvascular, we can use cautery to stop the bleeding. And also we can adjust water pressure to stop the bleeding. And next, we have to, before finish, we have to palpate all structures to find where is the stenosis area. And sometimes we can find calcified structure or compress the nerve far from the area. Okay, I think this typical complication of the endoscopic procedure are dural tear, and sometimes we can make a neural tissue damage, and also airway edema, postoperative dysplasia, hematoma, infection, and really significant vessel injury. Proper patient selection and mastery of endoscopic technique reduce this complication, of course. And as our conclusion, percutaneous endoscopic cervical discectomy is safe, effective, and minimally invasive procedures for cervical radiculopathy or even part of abdominopathy. Thank you very much.
Very nice presentation, Dr. Mahdi and Noor, and beautiful cases you have presented. Now I would like to invite Dr. Ihab Hosni from Egypt to start his screen sharing and start his presentation. Dr. Ihab.
Hello.
Yes, we can hear you.
Okay, great. It's great to be with you all. It's not allowing me to share the screen.
Dr. Noor, could you please stop sharing your screen?
Okay.
Yeah, thank you. Dr. Ihab, now you can start sharing your screen.
Hello, everybody. It's a great pleasure to give you this presentation on percutaneous transforaminal endoscopy in obese patients. Percutaneous transforaminal endoscopy has not just changed the size of the incision, but also the type of anesthesia to local anesthesia. The aim of our surgery is to target the pain generators, which are all in the forearm. This is how we do our markings. We mark the disc, we mark the midline, then the disc level in the EP, and then in the lateral. and then we take the depth using our marker and we mark our entry point. Then we give our local anesthesia and introduce our needle to the disc. It should be in the AP in the midline and in the lateral view in the posterior quadrant. Then we insert our guide wire, then the dilator, which should be also in the midline in the AP and in the posterior quadrant in the lateral after entering the disc. This is our sheath and the scope is in. Why did we choose obese patients to give them special concern? This is a paper we published in the Cairo University Medical Journal last June. Obesity was defined as a body mass index of 30 kilograms per meter square or higher. And these are the patients we chose for our case. And we compared them with normal patients of body mass index ranging between 18.5 to 22.9 who are considered as normal patients. We had, why did we choose obese patients? Because they pose a special problem, because they have many comorbidities. In our series, we had patients up to more than a third, up to a third of the patients had general problems like diabetes, hypertension, cardiomyopathy, fatty liver, and those posed a problem to surgeons and to anesthetists. And we, in our series, we treated all these patients without any life-threatening conditions. They also pose a problem to the wound itself and to the surgery itself, because if you are going to do an open surgery in an obese patient, you will have to increase the size of the incision to allow you to reach your target. This will, with the comorbidities like diabetes, will increase the risk of infection, wound dehiscence, and you'll have a large incision. In our studies, we had no problems because our incision is only about 0.8 millimeters. So there were no local problems with the incision or with the approach. This is our patients group. We had 83 patients, 32 obese patients, and 35 control or normal patients. The males in the obese patients were less than the females, and in the control group, they were more. Sorry. The ages were ranged around the 40s, and the body mass index was 33.5 in the obese groups and 21 in the control group. We had different, most of the levels were L4-5 and L5-S1, and we had 2 cases of L3-4 in the obese patients. We assessed our outcomes using the visual analog score with 0 as no pain and 10 as maximum pain. And we used the Odestive Disability Index to assess the return to work status. We followed all the patients for a year. It was done at 2 weeks, 1 month, 2 months, 6 months, and 12 months post-operative. And in our comparison between the 2 groups, it was very comparable. The obese patients had very good results, the same as the control group, except that we had the number of reherniations were more in the obese patients by 1 patient. And the hospital stay increased in the obese patients because we had to control the comorbidities with the disc herniation. And the operative time was also increased because you have some difficulties in positioning the patient and with the C-arm, and to reach your target with all the fat, it takes a little bit more time. It was not that much time. This is a female patient. You see, she was 120 kilograms and she was not that tall. The problem is the C-arm was not able to go through the fat, so we had to plaster the fat down, like you see in the picture, to allow us to see and visualize the disc levels. This is her herniation. This is the post-op, and to my amazement, especially this patient, she had a very, very good recovery. No problems at all. She was pain-free almost immediately. At 2 weeks, she had no pain at all. She was walking. She was very happy with this procedure. And thank you.
Thank you, Ihab. That was a very crisp presentation, and we did like your idea of plastering the fat in a prone position to make it more visible in C-arm. Thank you very much.
Thank you.
Now, I would like to invite Dr. Sean Venter from South Africa to start his presentation. Ihab, could you please stop your screen sharings? Yes, thank you so much. Dr. Sean, you can share your screen and start your presentation.
Thank you, Dr. Kavi. And I think that it's wonderful to be able to attend a Congress where I can say good morning and good evening and good afternoon, as it's a true World Congress. I am greeting you from South Africa, and this is the Cape of Storms, as it was dubbed by Bartholomew Dias in the 1460s. And in about 100 years later, it was changed to the Cape of Good Hope to entice people to travel to South Africa, but also because it was a hope that Europe could travel to India. Now, one of the things in South Africa is that we have challenges with the body habitus of our patients. And this is Sarah Bartman. And she was born in the Eastern Cape, but she was displayed and showcased in Europe for her extreme or very interesting anatomy. And this forms very much part of our challenges that we find in endoscopic surgery. And Dr. Hosnia's presentation was lovely, as it gave actually a very nice introduction as to what challenges we face here in South Africa. Now, this is a very nice example of the almost two extremes of patients that we find when it comes to endoscopic surgery. It's the same bed, but you can see that the patient fills the bed very nicely in the second picture here. And we use a flexed position on a spinal table, which does help with the fat layer at the buttock area. And this is just to present or to show the size that it differs in a patient that's a little bit normal BMI compared to a patient that's got an extreme BMI. And the problem is that your width of your patient becomes a challenge with your endoscopic surgery. Now, when we have a look at a thin patient like this compared to a obese patient, we find that the angle of approach to your pathology has it makes your distance that your telescope has to travel quite a bit further. Now, while the patient's being prepared by the anesthetist and we set the patient up, I go through a ritual where I apply the Pythagoras theorem. So this is constantly up on my board, and I measure the length of the patient's height from the spine or from the pathology to the skin. And we can see here in the thin patient, it's 7 centimeters. And I know then that my B level will be 14.8 centimeters at a 65-degree angle, and I'll be able to reach the pathology. However, in the second patient, the problem becomes that when we've got an 11.5 centimeter distance from skin to pathology, the distance that my scope needs to be placed is 27 centimeters, which is impossible for me to reach. So how do I then address this problem? One solution is to start looking at longer instruments, and this is the Stort's extended scope, which is 250 millimeters, compared to the more traditional 180 millimeter scope. We can see that the instruments are extended. However, that does also pose a problem, as you can see that the instrument's tip doesn't extend all the way through as it would in a normal scope. So getting to the pathology is one thing, but then addressing the pathology and being able to use your instruments through that scope becomes a challenge. So what was my next solution? I realized that if I keep that angle, my distance to the pathology will then need to be addressed by the scope. However, by changing my angle slightly, so angle of approach of 67 degrees would cause me to be 27 meters from the pathology. By changing it to 57 degrees, it becomes 18 centimeters, which then makes the working portal a manageable distance. Now, here we can see by changing the angle to 18 centimeters with a 57-degree angle, I then burr the SAP and I dock directly onto the pathology. This allows me then to have a targeted discectomy with the same effect as I would in a less obese patient or a normal BMI patient. Here we can see, in conclusion, the difference between the port, where it's at its maximum, at the extreme, it's indenting the patient's body, but I am able to reach the pathology, compared to the port when it's in a normal BMI patient. And this is basically the Cape of Good Hope, when we can still arrive at the pathology with the endoscopic surgery just by changing your angle slightly and doing an SAP facetectomy. Thank you very much.
Thank you, Dr. Sean. Yes, very nice presentation about modifying your trajectory. And yes, we do come across such obese patients here in our country as well. And it is very challenging because we do not have such long instruments. So definitely your technique is wonderful. Thank you for your presentation. Now I would invite Dr. Pang Hung Wu from Singapore to start his presentation. Dr. Wu.
Greetings, everyone. So I would like to share my screen. Can you see my screen?
Yes, we can.
Thank you for inviting me. This topic is uniportal full endoscopic pseudoarthrosis release of L5S1 Bertolotti syndrome under intraoperative computer tomographic guidance in an ambulatory setting. I practice in Jurong Health Campus, Ng Teng Fong General Hospital, part of National University Health System. I take care of about 12% of Singapore population in the spine, and majority of them have a residence of age more than 65 years of age. There's about 7% of our Singapore population in our area. I have an increasing practice in both uniportal and biportal endoscopic spine surgery. In 2021, about 80% of my cases are endoscopic spine surgery, of which 70% are uniportal and 30% are biportal, varying from various types of conditions. This is my disclosure. I learned my uniportal from Prof. Yu-Song Kim, and my biportal from Prof. Hao Dong Hua and Professor DJ Choi. Bertolotti syndrome was first described by Mario Bertolotti in 1917 as an enlarged lower lumbar transverse processes which articulate with the sacrum or ilium. It is characterized by a total or partial unilateral or bilateral fusion of the transverse process of the lower lumbar vertebral to the sacrum. This syndrome affects about 4 to 8% of the population and 5.4% of them have refractory back pain. This is particularly common and found in the second decade of life, and they're particularly young people. Castelfi classified Bertolotti syndrome into 4 types. For easy memory, A stands for asymmetrical, B stands for bilateral. So in our endoscopic approach, as well as decompression, we typically look at type 2A, type 3A, and type 4, where there's asymmetry. In type 2A, there's incomplete lumbarization and sacralization with dysplastic unilateral large transverse process of more than 19 mm wide and pseudoarthrosis with the sacral ala. I encounter this group most of the time that has in patients who have symptoms. The pathophysiology of this group of patients is that the anatomical aberration in the form of lumbosacral transitional vertebral alters the biomechanics of the axial spine, resulting in its typical symptoms. The reduction of movement between the transitional vertebral and the sacrum can lead to the pain and stress in the facet joint, exacerbated by this degeneration. Symptoms can originate from the pseudoarthrosis itself or the contralateral facet joint when it's unilateral, instability or early degeneration of the level cephalic to the transitional vertebrae. I've also seen patients who have prolapsed intervertebral disc, the level above, which is one of the important differential diagnoses from Bertolotti syndrome. Of course, nerve root compression due to the hypertrophy of the transverse process. They may present as back pain, and they are multifactorial causes of the back pain. Many of the patients may present with scoliosis, which in itself may not be the cause of back pain. However, the abnormal mechanical stress leads to the facet hypertrophy or the iliopsoas and quadratus lumborum strain. Nerve root compression due to the narrowing of the intervertebral foramina can lead to the neurogenic claudication, or in more severe cases, radiculopathy. There's an increased prevalence of this protrusion, extrusion in the disc above. However, at the level of the disc and that of the below, they tend to be less commonly causing a prolapse in the vertebral disc. This is my patient, which have a left-sided Bertolotti syndrome. Bertolotti syndrome, we need to do a diagnostic workup to rule out the other causes of pain, such as discogenic pain, facet original pain, facet joint origin pain, sacral iliactis, or prolapse intervertebral disc. Pain on rotation tend to be more facet joint, or maybe at the point, if it is particularly at the point of the pseudoarthrosis, can be a symptom of Bertolotti syndrome. They also can present with non-radicular or back pain and buttock pain. So as you can see from here, these are the areas of pain that we have to rule out. From the midpoint of discogenic pain, facet pain, sacral iliac joint pain, as well as radicular pain in purple. And finally, we after all that is ruled out, we focus on the Bertolotti syndrome. So typically in the MRI, you will see that there's an asymmetrical pseudoarthrosis. The left L5 nerve root in this case is deviated medially by the pseudoarthrosis. However, fortunately for this patient, there's no significant compression. We typically perform CT scan and 3D reconstruction if surgery is planned. So the proposed diagnostic algorithm involve, of course, a detailed clinical history examination, eliminate other causes of back pain, treat them conservatively, of course, with this, and then do diagnostic and therapeutic interventions such as discogram, facet block, nerve root block, or even sometimes blocking the pseudoarthrosis region. The detailed proposed algorithm can be inferred from this paper. Despite its common prevalence, there is no agreed treatment on Bartholdi syndrome. To date, there's no agreement to the best method of treatment, and the management of these patients remains uncertain, despite being an economic and potentially high social impact, lower cause of a lower back pain in young people. The importance of including Bartholdi syndrome in the differential diagnosis when examining young people with lower back pain must be at the back of our mind. We need to have a dynamic approach to the pain management. And in the past, when Bartholdi syndrome is poorly understood, sometimes they may end up seeing multiple pain specialists and even psychological counseling to help, as can be seen in this suggestion of how to treat Bartholdi syndrome in this paper. The surgical options, if you search on PubMed, is very diverse. It can be excision of the pseudoarthrosis from the anterior versus posterior approach, or posterior lateral fusion of the transitional segment. We have to understand the anatomy of pseudoarthrosis by understanding the anatomy of the L5 nerve root as it exists through the L5S1 foramen. It exists through the L5S1 foramen below the L5 pedicle with a ventral caudal course. We divide it into medial third, middle third, and lateral third. In the medial third, it is closely associated with the disc, the L5S1 disc. In the middle third, it runs across the sacral ala, ventral to the intertransverse ligament between L5 transverse process and the sacral ala. This is the part where the pseudoarthrosis commonly cause impingement of the nerve. And in the lateral third, it joins the L4 nerve root in the upper portion of the sacral ala to form the lumbosacral trunk. Excision of pseudoarthrosis has the aim of both decreasing the future facet degeneration and disc degeneration, as well as in some cases, decompression of the L5 nerve root as well. It can be achieved either by traditional open surgical methods or minimally invasive techniques. In the group that published the extraforaminal L5 decompression by using a ventral method, a very extensive approach, and with vascular colleagues' help to actually just release the pseudoarthrosis. It can be quite morbid to young patients, especially in young male. There's a potential of leading to retrograde ejaculation. So we should try our best to use more minimally invasive method to resolve this problem, maybe perhaps from the back. And it was described earlier that we can use tubular decompression for pseudoarthrosis, as highlighted in this paper. And prior to the use of endoscopy, tubular decompression has been a very attractive option for this group of patients. Others describe treatment like posterior lateral fusion in such a young patient for pseudoarthrosis. In my mind, can be a quite extensive treatment and should be guarded against if possible. Or using an open paramedian approach with decompression, which is efficient, however, causes a lot of perioperative comorbidities. Professor Hu Sung Kim use of a transforaminal scope and described the technique with 3 cases in the paper published in 2017. The advantage is that it's least invasive and able to reach out deep structure. The disadvantage is that, in my mind, that there's a limited size of the drill and radio frequency ablator using a transforaminal scope. And there's an inability to convincingly check the decompression. Bear in mind that pseudoarthrosis is truly, in the Bartholdi syndrome, a 3D malformation of a pseudoarthrosis between the L5 transverse process and sacral ala. So we published these results. We use a combination of both a stenosis scope, keep in view using a transforaminal scope, as well as having a post-operative O-arm spin or intraoperative computer tomographic guidance to ensure that we have completed the job. This is an example, a 24-year-old dancer. She has low back pain, atraumatic for 2 years, especially on turning when she's doing her ballet dance movement. She has quite significant pain on pain score of 6 when she do ballet. And it's localized at the area right at the pseudoarthrosis junction. Her straight leg raise was negative and other neurological examination was normal. Trial of conservative treatment and facet injection was offered. Trial of conservative treatment failed and she preferred an endoscopic approach rather than the facet injection to release the pseudoarthrosis, as she was preparing to be a professional ballet dancer. So we marked the skin overlying the pseudoarthrosis, and the patient was positioned prone on a Wilson frame with a radiolucent table, done under general anesthesia. We typically put a needle over the center of the pseudoarthrosis if the pelvis sacroala is wide enough, and there's no in a narrow pelvis. Sometimes we have to start our incision typically a bit of the medial third of the pseudoarthrosis. I use a stenosis scope, reason being that we need to create, in my mind, about a 9 mm to 10 mm gap between the transverse process and the sacroala. So using a 4.5 millimeter or 5 millimeter drill would be more efficient in the decompression. Of course, we use a normal saline endoscopic under pressure of 30 mm Hg. So in this case, we drew with a 4.5 mm diameter diamond burr. We identify the most ventral lateral margin of the pseudoarthrosis articulating with the highest part of the sacroala. I name it as the pH point in my paper. This point is bounded laterally by the bony ileum. Ventrally is soft tissue actually. And you have to be very careful. If you continue drilling on the soft tissue, you may end up in the peritoneum. And it's adjacent to the L5 nerve root, medially by the fibrous tissue of the pseudoarthrosis and the dysplastic transverse process. This point is both verified under endoscopic vision as well as the fluoroscopy. And you can see that deep to this point is actually soft in nature by palpation, and lateral to this point is the sacroala. We drill from this pH point to the MS point. MS point is basically adjacent to the superior articular process and is the medial inferior margin of the pseudoarthrosis, adjacent to the superior articular process. After identifying these 2 points, we complete a 9 mm drilling between the two groups, between the 2 points. On completion of the decompression, we check the fluoroscopy, and we can have a full exposure of the extraforaminal cross of the L5 nerve. Verify with O-arm. Excuse me, can someone please mute the person speaking? So we use the intraoperative O-arm to verify that it has complete decompression using 3 view: axial, coronal, and sagittal view. We immediately mobilize the patient on the very same day in order to prevent the reformation of pseudoarthrosis. It's just a short video of showing how we can do that under fluoroscopy. So we can see that there's a left L5S1 pseudoarthrosis, and identify the entry point, dock at the midpoint of the area of the pseudoarthrosis. We identify and drill from the midpoint of the pseudoarthrosis towards the lateral ventral aspect, which is identified as the pH point. Along the way, using a stenosis scope, the main disadvantage is that you are hovering above the soft tissue. Sometimes that you have quite a significant amount of bleeding. It may be difficult to control, but with due care and using radio frequency ablation, a larger caliber radio frequency ablation, we call it arthro under the Delphi system, or bones have the similar system as well. We can actually control the bleeding. We go drilling laterally to the pH point. We can actually palpate the sacral ala. Eventually, it will be soft as we continue drilling. You can see that this is most ventrolateral aspect, and we call it the pH point. After this exposure is quite clear and checked with fluoroscopy, we can safely drill it from this position, create a 9 mm gap between the transverse process and the ala towards the superior articular process, drilling layer by layer in this case. As we drill and the pseudoarthrosis gets thin, L5 nerve root will be in view. We have to be careful in managing the L5 nerve root to prevent dysesthesia or injury. Of course, the radicular artery also is close to the L5 nerve root as well, which can cause significant bleeding. So we try to lift the last layer of the periosteum while completing the decompression. As we drill across, we have exposure of the superior articular process and the most medial inferior aspect, and we call this the MS point. As you can see here, in this surgery, there's a lot of time spent on endoscopic drilling, and very little time is actually used using Carrison Ronger or other methods of endoscopic technique. So to be familiar with doing this procedure, I encourage our colleague to be familiar with endoscopic drilling for majority of the procedure. Sometimes we have to drill literally 30 minutes with intermittent stoppage by hemostasis. So this is about the completion of the release of pseudoarthrosis, and it's confirmed by the O-arm. And that's the skin that is closed, and the patient has no more back pain. As you can see here freely, she is now a professional dancer in a teaching ballet. In the male pelvis, just to highlight briefly, also around this age group is an army officer in the guards unit. You need to do a lot of sit-up, and he has a lot of pain when he does that. The male, he has a scoliosis, as you can see, driven by the pseudoarthrosis. The MRI shows no significant nerve root compression. And then you can see again the left L5 S1 pseudoarthrosis. In this case, because the young male, the male pelvis is narrow, so you can only dock on the medial third, if not the most medial part of the pseudoarthrosis, which if you use the stenosis scope, sometimes can be challenging to reach the lateral aspect, the pH point. So in this case, I have to switch to the transforaminal scope as well to reach to the pH point. Other than that, the surgery is pretty similar. As you can see here, in a narrow pelvis, you tend to be a bit further away from your target of the pH point, which is the most lateral aspect, ventrolateral aspect of the pseudoarthrosis. Hence, sometimes the bleeding may obscure your view, as you can see from here. It's not as clear as the lady who has a wider pelvis. I think this can be circumvented by using a transforaminal scope. However, I still use a stenosis scope because I think the efficiency of the drilling can save some time. So the process is similar, except that at a certain point, after we breach the inner layer, I find that using the stenosis scope, there is significant bleeding, which can be difficult to control because we are hovering way above the area. As we drill towards the pH point, the last bit, you can see from here. Then that's when the bleeding occurs. As I mentioned, beyond the pH point, it is soft tissue with potential bleeding. So I switched to a transforaminal scope and complete the drilling. Once you have the transforaminal scope, you can use the RF easily to stop the bleeding. So it needs some planning because using the stenosis scope, we tend to use a shorter RF than the transforaminal scope. Of course, we can use an interlaminar scope as well, which can be essentially the same length but shorter but smaller in diameter. Essentially, the rest of the method is the same. A lot of endoscopic drilling. Be careful with the L5 nerve root. Using the probe to check the medial, the superior articular process medial inferior point, which we call MS point, for purpose of the publication. In this case, I used the Kerrison ronger for the last layer, just above the nerve root, and it's fully decompressed. I suppose if we do not have O-arm intraoperatively, we can perform using C-arm to confirm that it is fully decompressed. As O-arm is readily available in my facility, I use the O-arm to double confirm that it's fully decompressed. This O-arm picture, and this is the wound. The patient is discharged typically within 24 hours. Overall, in discussion, we need to create enough space of an IMM gap. We have to be clear in identification of the most lateral margin and the medial margin. This anatomical point is important to prevent complication like significant bleeding because of drilling way beyond the pH point, or drilling too medially beyond the MS point and leading to the violation of the superior articular process due to the fact that we are disoriented. I think we should create a 9 mm gap in between the two processes to prevent reoccurrence of this condition. We want to prevent overzealous SAP drilling, as I've mentioned. And this is a complex 3D abnormality. I suggest if we have O-arm intraoperatively, we can confirm the decompression by doing an O-arm spin post-op. We can also deal with the raw surfaces by putting bone wax. And more importantly, I feel, is that aggressive physiotherapy starts as soon as the patient is awakened and able to mobilize. I ask them to do active sit-ups and rotation of the trunks as soon as post-op day 1. These points can be highlighted in my paper. You can find that on the PubMed. So advantages of uniportal pseudoarthrosis release, I think, as we can see among the techniques that I've demonstrated before the endoscopy get popular, the open surgeries can be quite aggressive. I think endoscopic procedure is simple and nice in ambulatory surgery, can be considered in the treatment of patients who have pseudoarthrosis. And we have to be careful in identification of the L5 nerve root to prevent injury. We should be confident and familiar with handling of endoscopic drill while doing this procedure, because most of the part of the procedure is done using endoscopic drill. I welcome any questions. Thank you for listening. I hope you'll have a pleasant day ahead.
Thank you, Dr. Wu. That was a very descriptive and very interesting presentation to treat Bertolotti's syndrome. I have one question about the male case which you demonstrated. What was the operative surgical time for that? Because you changed the scopes to transforaminal as well.
Okay, I spent about, I think 60 minutes. It takes about 30 minutes with the stenosis scope, and then I changed to the transforaminal scope, which takes another 30 minutes. But okay, then when we completed, then we do an O-arm spin. As you know, O-arm is a bulky item. It takes another 15-20 minutes. Yeah.
Okay, even then it was quite fast and with wonderful results. So thank you very much for your presentation. Now I would call upon Dr. Lutfi Gatam from from Indonesia to start his presentation. Dr. Lutfi, you are here with us.
Hello.
Hi. Hello. Yes, Dr. Lutfi, you can start your presentation.
All right, thank you, thank you. Can I share my screen?
Yes, yes, please go ahead.
First of all, I would like to thank to the organizing committee who already invited me to this meeting. So I would like to share my screens. Okay. So my title today is how we approach the degenerative lumbar canal stenosis using the endoscopic procedures. So as we know that if you look at this picture, this picture, female 62 years old with the multiple stenosis. And the question is there any place to do the endoscopic procedures in this case? Because there is a multiple stenosis. This is not just a central stenosis, but also there is a foraminal stenosis. This is not that easy. So endoscopic procedures, yes. If you look here, the endoscopic procedures can do the decompressions perfectly, but the problem is the time of surgery, the complications because of the water pressures also make a role of the outcome of the patient. So we have to be careful. So if you look at the other picture, we can see that the problem is not just a central stenosis, but the problem also on the foramen that we have to keep in our mind. So endoscopic spine procedures has been practiced in the world more over 30 years. And if you look at the acceptance of this procedures is quite high. It is not really low acceptance. So the history of these procedures is early 20. Open discectomy was first introduced, and 1975, Jakarta introduced closed percutaneous splenectomy. And if you look at the full endoscopic, is introduced by Witten on 2005 and 2006. They do the interlaminar transformer procedures. And now we are in era of full endoscopic procedures. Yes. So if you look here from open and to the closed procedures. So if we're talking about the full endoscopic lumbar spine surgery, we have basically we have the approach, interlaminar approach, from where we enter from the windows between the lamina, and transforaminal approach from the foramen, or extraforaminal approach, or lateral access, and the transforaminal approach, posterolateral access. So talking about the interlaminar approach, because we are now want to talk about the role of the endoscopic in spinal stenosis or lumbar canal stenosis. So we have to talk about the interlaminar approach or posterior access. Then we have to see the interlaminar windows. So as long as the interlaminar windows is quite perfect for doing the interlaminar approach, then the problem is not very high because we don't do bony procedures. So if you look at the interlaminar approach, the advantages is using that approach, you can bring all the working channel from perpendicular of the interlaminar windows, then through the 45-degree angle. So you can see the opposite side of the that level. So we not only decompresses on the ipsilateral, but we can decompresses on the contralateral. So if you look at the type of interlaminar endoscopy right now that we have uniportal and we have biportal. And if you look at the uniportal, there is a 4.7 millimeter diameter scope for some, mostly for the lumbar disseminations. And we also have a 6 millimeter diameter scope, usually this for the stenosis. And if you look here, the scope can so the evolution of the interlaminar procedures, actually, we can see here. We can do it for the discectomy, we can do for the lateral recess decompressions, we can do for the laminectomy, bilateral decompressions, we can do for the foraminectomy as well. On indications of the interlaminar approach is wider than transforaminal approach. We can do the disherniations on every level from L2 down to S1. L5, S1 without bony procedures. And the other level probably need bony procedures. And migrated disherniations is very easy doing the interlaminar approach. Calcified disherniations, cervical foraminal. And the spinal stenosis also is very easy by doing the endoscopic procedures without significant unstable. We can do medial facet resections, flavectomy, and even by using the interlaminar approach, we can do a PLIF or PLIF using these procedures. So if you look here, yeah, there is a big herniations, then we can do from the interlaminar approach. So the advantages of interlaminar, because we are surgeons, usually we open the backbone, our spine, then we are really familiar with this anatomy. Yeah. It can solve multiple pathologies directly at one time, and it is allowed to do a fusion technique in these processes. So the disadvantages using the interlaminar or procedures, steep learning curve, very difficult to identify muscle, facet, ligament, and endoscopic visualizations. Dural tear tend to occur, intraspinal hematoma, bleeding, need to good radiofrequency adapter, water pump for very important. So the complications, back pain, very rare, is due to the discectomy, only for appendectomy is needed, so that's during procedures, but usually this is temporary. Hence, nerve fluid injury, compression from walking channel, too high water pressures, edema, temporary conditions, dural tear, sometimes not identified during the procedures, and usually cause all patients feeling headache, and rarely cause wound dehiscence. And we later we can develop the dural repair instrument. So if you look in this picture, then we can see if you have a dural tear, then you can see easily as long as the root is not coming out from that hole, that is still safe. So you don't have to repair it. Just putting like Duragen over the hole, then it's solved actually. So how about the central stenosis using endoscopic procedures? Usually we call this the PSLD or percutaneous stenoscopic longitudinal decompressions. Indications, radiculopathy or claudications, neurological origins. And if you look at PSL for central stenosis, that means the problem is on the flavum, facet hypertrophy or facet OA, and usually the compression on the lateral recess. So the stenosis, usually we just do the decompressions and knowing identify the facet joint and open the facet joint, and later on you can see the flavum, and you may open the flavum by doing several procedures. And if you look here, you can use rongers, you can use bone cutters, and you can see the root is free from the mechanical compressions. So the how about the foraminal stenosis? Using these procedures, PSL, we can do also the decompression for the foraminal stenosis. As we know that it is not just osteophyte from the other body, but also the osteophyte from the facet joint that make the nerve compress. So then we have to open from the lateral side. So the instrument, they are inserted through the lateral boundary of the structure called the isthmus, also called pars articularis. See that we enter from the pars articularis, then we just blur and we see the facet joint, SAP, and we remove the facet joint and also remove the flavum from that side. And we remove all the soft tissue here, and we can see the root free from the mechanical compressions. So how about the biportal endoscopic discectomy? So biportal endoscopic discectomy, one of the problem in our procedures, because it is very helpful procedures, Then comparing with the uniportal, if you look here, the imaging is better than the PSLD, but it is really depend on the equipment that you use. So if you look here, there is a calcified disc here. Then the calcified disc is can be removed from the by using an endoscopic biportal. Okay. There is also the cyst axis, the cyst here. Then we can remove the cyst by using the biportal endoscopic procedures. See that? You can see the cyst is removed, and this is the cyst, and this is the post-op of the surgery. So how about the endoscopic visions by using a biportal? It is possible because if you look here, spondylolisthesis of L5S1, then using the endoscopic procedures, we can put actually the gates on the disc from the endoscopic procedures, biportal one. So here, see that we put the graph, we put the gates, insert the gates. Once the gates is in the disc, then here, then gates is in the disc, and that's it actually. And this is post-op surgery, and this is the result after surgery. So this is the result after surgery. Look, the thecal sac is free, and the nerve also is free. So the revision surgery, if you look here, before patient has the compressions by using the open procedures, then we do the fusion of L4, 5, L5S1 by using a biportal endoscopic delivery. So here is the surgery. And after insertion the gates, then we put the we insert the medical screw. As a conclusions, endoscopic procedures in rectal stenosis is both really possible and has a good outcome. The result of endoscopic is more superior compared to open surgery, especially in soft tissue preservations. And endoscopic could replace open surgery or even microscope for the compression process. At this moment, we could almost say goodbye to open surgery. Thank you very much for your kind attention.
Thank you, sir.
Dr. Gautam, thank you so much
Thank you, Malcolm.
for a very wonderful talk. The world has progressed from disc and fragmentectomy to stenosis. You have very comprehensively covered the entire talk. I'm really grateful to you. Dr. Mahadipta, please start your screen share and please start your talk. We await to hear you, sir.
Thank you. Thank you. First of all, I would like to congratulate for the organizing committee, Dr. Malcolm, Dr. Anand, and all for organizing this wonderful event, World Congress Endoscopic Symposium. And allow me to introduce myself. My name is Harman from Indonesia. I work with Dr. Lutfi Gautam. He is a well-known leading spine surgery surgeon in our country. And recently, this year, we established an orthopedic and spine institute named upon him, Gautam Institute. So because of the time, I already pre-record my presentation, and please enjoy.
Can you increase the volume of your presentation, please?
It sound okay. I don't hear anything. Just
Dr. Harmantia, we are not able to hear you, sir. If you could just talk along with your slides.
Pardon me? Sorry?
We are not able to hear you.
no,
You cannot hear me?
there is
No, no sounds.
there is no sound.
Oh, there's no sound. So I hear it from, wait a moment. So is there any sound here?
No.
Now? There's no sound? Oh, no sound. Okay, so I will just stop. So wait, I will share another screen. Sorry for the technical
No problems, no problem.
disturbance.
Please take your time.
Can you hear me now?
We can hear you, but not your talk.
Okay. So my topic today is about uniportal versus biportal approach for posterior endoscopic cervical foraminotomy. So as we all know, the posterior cervical foraminotomy is already well established, and a lot of literature compare the ACDF versus the PCF, and the result is just quite just as effective as the ACDF. So the option for the keyhole cervical foraminotomy include the open surgery, the microscope, tubular, and recently the endoscope. And as we all know, the endoscope comes with the uniportal or the biportal approach, but which one is better? So a lot of literature published about the uniportal, and there is also a result with the comparing the foraminal size after the endoscopic decompression of the foraminal cervical spine. And also a lot of articles published with the biportal approach. And technically, the biportal came to technique first with the ipsilateral side with the ipsilateral symptoms. And the second, recently published with Professor Song from Korea, he used a contralateral side to address the contralateral symptoms. But if we search on the PubMed, the comparison between uniportal versus biportal, which one is better, I don't find any literature yet. So I make a small study design, age 20 until 50 years old, only unilateral symptoms, only on the left side, because I want to decrease the bias from the right and left side. And I only tackle the foraminal soft disc herniation confirmed by CT scan and a contained disc herniation. So I only perform indirect decompression by keyhole endoscopic foraminotomy, and I compare 20 of my cases with uniportal and versus the biportal approach. And the measurement, I measure the time from skin incision to beginning of the bony work, the time from bony work to complete the procedure, and the post-obtained score. So before we want to do a posterior cervical endoscopic foraminotomy, we have to know the location of the dorsal root ganglia. The dorsal root ganglia is protected by the SAP here, as shown above. So in order to get to release the dorsal root ganglia, so you have to cut the IAP and also the SAP, right? And usually the foraminal disc herniation is located anterior to the DRG. So if you do a indirect decompression of the IAP and the SLP, it will be sufficient enough to release the symptoms of the patient. So this is the X-ray on the patient. So if you want to do the foraminotomy, your aim is on like this side. This is the left side. Patient is prone position. On uniportal axis, you can just target the incision here, but on the biportal axis, you have to make a incision quite lateral side. So to insert the viewing portal and the working portal, and afterwards you have to triangulate your working and viewing portal inside into the targeted area here. So this is if you want to imagine our targeting point is what we call the V point, right? The V point is a location between the lamina and the lateral mass. So this is your targeted point, and this is the IAP. And after you identify the V point, you can go to the boning work. You can drill the IAP and you can drill the SAP until you see a DRG. And you have to note that the flaphum ligament in the cervical spine and the lumbar spine is quite different. If you see here, this is a nice published from Rahmani. If you see here on the lumbar spine, the flaphum ligament extend to the neuroforaminal in the foraminal area. But on the cervical spine, it stops. It stops just lateral to the dura, and it doesn't cover the foraminal. So posterior to the DRG, there's no ligament of flaphum. So your work is on the lateral side of the flaphum ligament here. If you see a flaphum ligament, your work is go to the lateral side of the flaphum ligament. So this is the DRG has already been decompressed. And I always do a spin 3D post-op to see my work, and you can see the nicely decompressed of the foramen, IAP and SAP. And this is look like for the 3D CT scan. So this is a nicely decompressed foramen. So how about the time from skin incision to the beginning of the bony work? So in my opinion, the time is much faster for uniportal, because when you do a biportal technique, you have to struggle to triangulate your viewing portal and the working portal to see where's the V point. Meanwhile, on the uniportal, you target it directly to the V point area, and you can just make a little time to clean the soft tissue, and you can see nicely the V point. But on the biportal, sometimes you have to struggle to release the soft tissue and make your own way to connect, and you have to ensure the good irrigation first before your work. So it takes a time to before you can do your procedure. So my average is 1 minute and 36 seconds for uniportal, and for biportal 4 minutes and 27 seconds to begin the bony procedure. So as I mentioned before, the why the biportal has a longer time, because first you have to make a time for triangulation, and second you have to ensure the irrigation is quite flowing enough before you do the procedure. So how about the time from bony work to complete the procedure? So it doesn't give much insignificant difference, because once you get the nice view of the V point, you can easily direct your burr to the IAP and easily burr your SAP, and there's a ganglia. But one of the advantage of using uniportal, you can see more laterally, because if you use a biportal technique, it is quite difficult if you do the surgery on the ipsilateral side of the symptoms. It is quite difficult to see lateral side of the dorsal root ganglia. That's why I think the recent published with Professor Song, he do a contralateral approach for the symptoms. It's easiest to with biportal approach. It's easy to see the foraminal from the contralateral side using biportal, but it's not an issue with the uniportal. You can easily shift your angle towards medial to see the lateral side of the foramen. And the mean operation time for the uniportal is a bit longer, 15 minutes and 18 seconds, while the biportal is 13 minutes and 47 seconds, but without a significant difference. And there's no difference in post-op pain score. I always do the foraminal decompression daycare surgery. And one of my case of the biportal is I break my burr tip. So I experienced difficulty in retracting the burr tip because because if you once you pull the tip using the working portal, sometimes the tip is stuck into the muscles, and it's difficult to see the scope. It's difficult to see the tip with the scope because they have a different working and viewing portal. It's not an issue if you break a tip with the uniportal approach. The tip is always on inside the working channel, and you can take it easily out. But it's an issue if you break the tip with the biportal approach. So this is one of my case. I break the tip, and it takes a longer surgery. So in conclusion, my preference for posterior cervical foraminectomy is uniportal, because like I said before, the uniportal approach is much direct placement to the V-point area, and you can make your way easier to that. And second, because the wider angle of movement of the viewing of the camera. Thank you, and I can say goodbye to open surgery.
Dr. Harmantya, that is a fantastic presentation. Your comparison between uniportal and biportal was very interesting. Surgical time from bone to disc, bone to root was basically the same. So that is a very positive feature about your talk. Agreed, dissection with uniportal and dissection with biportal is a little different. Maybe in biportal we have a little more space, a little more room once we created that room. So that is again an individual preference, but it was a wonderful talk all in all. I now take the privilege of inviting Dr. Risky. If you're live, please do join us and share your screen, sir.
Hello, good afternoon. Thank you, Dr. Malcolm. So, share my screen.
Yes, please.
Yes, can you see my screen?
Yes, I can, and we can hear you also.
Okay, so thank you, Dr. Malcolm. So my topic is quite the same with Dr. Harman. I am Asrafi Rizky Gatam. I'm orthopedic spine surgeon from Jakarta, Indonesia. So my topic would be full endoscopic posterior cervical foraminectomy for management of herniation and foraminal stenosis. So in this I mostly use biportal endoscopy to do my my work here. So in my opinion, I guess I'm more comfortable using the biportal endoscopy for doing the decompression. So as we all know that the radiculopathy is very common for aminopathology, and the gold standard at the moment is ACDF. But the problem with ACDF is risk of sideroarthrosis, adjacent segment disease, and also there's lots of approach-related complication that could happen. And as for the anterior surgery, sometimes there are surgeons doing the anterior non-fusion foraminectomy, but I guess this is a very technically demanding procedure, since it is very small holes made on the anterior vertebral body, and then we have to go all the way into the posterior part. So I have never done that in my practice, but I think it is very technically demanding. So as for posterior surgery, this is actually preserving the motion and stability, and we can do that with minimal invasive surgery using the full endoscopic technique, which is very good whether using the uniportal or biportal, and we can directly evaluate and mobilize the nerve root. But the problem is bleeding, and there is also a risk of nerve injury and facet violation. So the evidence for foraminal stenosis management, as according to NAS, they still recommend ACDF. Even they do the research between the ACDF and posterior laminar foraminectomy. The result is still the same, but the recommendation is still doing the ACDF for one level cervical radiculopathy. So, but if we look from the other paper here, comparing the posterior foraminectomy compare with ACDF, even though the posterior foraminectomy is a very good procedure, but there's still a bit more revisions compared with the ACDF in the foraminectomy group. And this is one of the very good paper from Sebastian Rutten that still foraminectomy still have disadvantages. So basically, we have a very limited possibility to expand the operation. So in the event of something going on happen, so I think ACDF or even posterior open surgery is still one of the great choices for doing the procedure when there is something to happen, even if we have to convert from endoscopy to open surgeries. So as the indication, we already know that for foraminectomy should be radiculopathy without the myelopathy, with lateral disc herniation and sign of foraminal stenosis with due to the degenerative facet or osteoligamentous hypertrophy. So this is the contraindication. So basically, for my point of view, I've never do laminoforaminectomy for myeloradiculopathy symptoms, but I know that some of the endoscopic surgeon also doing the laminectomy using for managing the myelopathy. I also never do with a significant deformity with loss of cervical lordosis, loss of disc height, and also with central disc herniation and central osteophyte, also fractures, tumor, and OPL. So when we want to do the foraminectomy, there are several things that we have to consider. First is the clinical anatomy of the foramen of the nerve root. So as I've seen, as I've observed during my operation, the nerve root location is actually very inconsistent within the foramen. So basically, sometimes location of nerve roots is close to the upper pedicle, sometimes very close to the lower pedicle. So it is very important because sometimes when we want to do the discectomy, we have to mobilize the nerve, or sometimes we have to do the partial pediculectomy to access the intervertebral disc. And also the distance is very variable. So it will cause the space available for discectomy is very variable also. And sometimes we have to address also the osteophyte and medial disc herniation. So this is one of the very good article showing the anatomy of the nerve root for posterior foraminectomy. They evaluate that the distance from the medial lateral border of the dura mater into the nerve root is actually increasing from the upper cervical to the lower cervical. But in my observation, that is not the case. Sometimes we have lots of cells on the cranial part compared to the caudal part of the nerve root. So the next thing that we've considered is the next position. So I always try to straighten the cervical lordosis as it is. It will increase the foraminal space and also increase the space for discectomy. So I always try to make this to last the cervical lordosis during the procedure. And the other thing is the epidural bleeding. So we have to meticulously control the epidural vein because the size of the epidural vein and the amount of epidural vein is actually different between the cervical and the lumbar spine. In the cervical spine, I think the amount of the epidural vein is quite abundant. So this is sometimes could cause a problem during the procedure. So the techniques is first, since I do the biportal endoscopy, so it is very important to make the portal. So first on the AP view, the portal is actually between the pedicle. But sometimes when we want to do two level directly using the single portal, we can put the viewing portal or even the working portal on the upper part, so maybe around this pedicle, so we can do this foraminectomy and also this level foraminectomy. So and then we do the triangulation, finding the V point as already mentioned by Dr. Harman before. So this is the endoscopic view of the V point. So we did we have to do a medial IAP medial resection using the burr, and then SAP medial erection and partial superior pedicolectomy if it is needed. Okay. And then doing the valvectomy and then mobilize the root and also discectomy. So this is one of my patient. So this is a male 40 years old with left arm pain with normal neurology. So we can see that there's a foraminal soft disc herniation here. So what I did is biportal endoscopy in this case. So first we evaluate the V points. So I actually like to do the biportal better because doing the soft tissue dissection using the ablator is very, very powerful. So we can remove the IAP first and then removing the SAP. And then as you can see here, there is this is the ligamentum flavum, and this is lots of venous plexus here that we have to control before proceeding into removing the ligamentum flavum. It is very important because sometimes when there is a bleeding, it is very hard to control. And this is the nerve root. So in this case, so as you can see here, this is C67, but the location of nerve root is very, very close to the lower pedicle here. And there is also no space on the medial part here between the dura mater and the nerve root. So I have to remove a little bit of the medial wall of the pedicle so I can get into this herniation. So you can see that the nerve root is very, very clear and very, very free. So this is another example of female 47 years old with left arm pain with foraminal stenosis here. This is a 2-level foraminal stenosis. So I also did using the biportal endoscopy. So in this case, we can clearly see the 2-level of the facet joint using only one viewing and one working portal. So we can see this is the upper facet joints and this is the lower facet joints. We can see directly both, and then you can work as the usual way of doing the foraminotomy, resection of the IAP, and then removing also the IAP. Maybe I can fast forward the video here. Removing the ligamentum flavum, and then evaluating the nerve root. So this is the C67 level. As you can see, the space on the inferior part is very, very narrow. So we have quite a lot of space on the upper part of the nerve root. So we can go directly into the upper facet joints to do directly the foraminotomy on the upper level. So with only one working and viewing portal here. So I will continue. So this is will be done in the same fashion as the previous slides and also on the previous level. So we can see here on this level, we have lots of space on the caudal part. So this is just differences in one level, but actually the space that is available is very, very different. So we can see here, we can do 2 levels directly with one portal. So that's why I showed you earlier that it's very important to evaluate the location of the nerve root within the foramen, since the location is very, very inconsistent. So this is the result. I can do 2-level foraminotomy using single portal. So this is the result. I've done quite around 70 cases of cervical foraminotomy using biportal endoscopy with quite good result with decreasing of arm pain. So also there's also no neck pain after the surgeries. So I had 2 patients with incomplete decompression. Actually, this has happened during my early days of doing the endoscopy. So I could not, I resect too little of facet joints. So I I cannot open up the foramen. So I had no complication regarding the deterioration of motoric function, but I had 3 patients with numbness. So in conclusion, the evolution of optics and instruments enable us to perform posterior procedure safely. And I think evaluation of the nerve root is better in posterior approach compared with the anterior ECDF procedure. And this is one of the options for management of foraminotomy, especially in the patient with good intervertebral distate. We don't want to do the ACDF for just a soft disc foraminal herniation. So I think that's all that the thing that I want to share. So thank you. Back to you, Dr. Malcolm.
Thank you so much, Dr. Rizky. That was a very wonderful talk. What I appreciated very much was your analysis about the distance of the myelin and the nerve root from the lateral border, where it enters the facet joint. You have also explained beautifully how the cutting of the IAP and SAP is well needed after the identification of the V point. And personally speaking, whenever I do a cervical foraminotomy, I have realized that I have a weakness of trying to undercut. If I'm working on the left side, I have a weakness of undercutting on the axillary side. And whenever I'm having a right-sided patient, I have a weakness of working on the shoulder side. We always tend to little undercut or cut less of the IAP. Somehow, I don't know why. Maybe it's because of our inclinatory angles of working. But your talk was wonderful. I really appreciated this talk of yours. And I do vote for UB as a personal choice. As a personal choice, yes. I do vote for UB. Thank you.
Yeah.
Thank you so much, Dr. Rizky.
Yes, thank you.
We will now go ahead with the talk by Dr. Sarfuddin Hussain, popularly known as ICAP. My dear friend, ICAP, where are you?
Yeah, I'm here, sir. Can you hear me?
Yes, I can hear you. Welcome. Please start your talk.
Yeah, thank you. Thank you, Dr. Malcolm.
Thank you, sir. Share your screen, please.
Yeah, please. Can you
please start your screen share?
Okay. Can you see my screen now?
Yes, we can see your screen, but you need to start your screen share, and you need to start your talk. You're not selected your talk yet. Yes. You'll have to double click on it to open it up.
Okay. Can you see now?
We can see your screen, Dr. Ikap, but I cannot see your talk. You have to expand your talk. Yeah, your presentation. Your presentation is not opened. Please open your presentation. You have to double click on it.
I need
share your screen and then double click on your presentation. Yes, now you started. Perfect. Perfect, sir.
Okay.
Perfect.
So thank you very much, Dr. Professor Malcolm, for inviting us for this great talk. My name is Sarfuddin, or well known as my friend call me Ichab or Ikab. We work together under with Dr. Lutfi Gatam as the chief in the Gatam Institute in Jakarta. Today, I would like to bring up the endoscopic decompression of degenerative thoracic stenosis. As we know that the myelopathic of the thoracic region is low prevalent, only affected a small number of patients. There are degenerative changes. Is this relatively uncommon? And we know there's a thoracic spine supported by the rib cage, and the compression of the myelin could be from the in front, the OPLL, or from the back, or ossification of labrum ligament of the can caused by this herniation. And this condition commonly misdiagnosis in the lumbar or cervical region. The open surgery for this kind of condition already well known for a long time. There are some options that like the total laminectomy with the resection of the ossified blavum, total laminectomy with the we leave it the floating ossified blavum, or the end block laminectomy with the dural excision. However, it affects the posterior tension band mechanism of the thoracic region and the risk of the lead kyphosis. And then the one we affect are the future deterioration of the neurologic status. So in order to overcome this condition, we try to search the evidence of the endoscopic thoracic decompression in the PubMed. Less than a 40 journal that state the decompression of using endoscope. And the issue is is it adequate decompression for endoscopic surgery? There's one author coming up with the comparison study of the to compare the endoscopic decompression and then versus the open decompression. He found that the blood loss is significantly in the open decompression is much higher, and the duration of the surgery also as well as very significant different, and the most importantly the hospital stay is significantly different. They compare the open and endoscopic and this compression of the thoracic spinal stenosis. Then he stated not recommend for the beginner for the endoscopic surgery. And then another journal state about there are some factors that we need to consider before doing this kind of surgery, like the T2, the high intermedullary signals that we consider as the edema of the myelum, or the big type of the OFL on the low ratio of the cross-sectional area of the myelum and anterior posterior diameter of the spinal canal. The early surgery saw better result. There are a few steps that you need to consider before doing this kind of surgery. The first step, you need to identify the lower margin of the lamina and the facet joint, and then you need to consider to cut from the medial side to the lateral, and you do the burr hole from medial to the lateral, and the third step is to remove the superficial flavum ligament, and the fourth step to remove the deep layer of the flavum and or the calcified flavum, and then lastly to remove the medial facet bilaterally, right and left side. There is a thing that you need to consider before doing the surgery is one is identify the epidural fat between the calcified flavum and the dural. If there is no sign of the sign of hyperintense in the water between the OFL and the dural, you need to consider it's very thick or the calcified very tight. And then the left side and the right side, if you do the CT scan, you can see the left side is a nice thing to do on the endoscopic, but you need to consider doing it open in the very massive OFL. And then the other thing is that there's a few things like the coma sign that there's a pointing in the yellow arrow. There's a high signal that ossified the mass. Is considered more than 2/3 of the dura mater compressed already, or the second is the tram track sign that is low signal between two parallel high signal. The preparation of the portal, usually we do the UBE, same portal, standard portal, and then after inserting the portal, you need to do the triangulation to reach the two instruments that working or reaching each other. And the second thing that you need to consider is that you want to have a good flow of the fluid that makes sure that during the surgery you can see the clear vision, because you don't want a lot of debris and the hematoma inside the view. And there's some example of this. This is a male 44 years old with a wide base gate with coming with the stenosis of the thoracal 11 and 12. As we can see in the sagittal view, there is some cord edema and very tight of the spinal canal. And here, there's a burr and the decompression of the from the interlaminar area from the medial side until you reach from the margin of the the lamina up to until the insertion of the platform ligament until you see, and then using the Carrison ronger, you need to remove all the bone and calcify the platform ligament. And you need to be careful when you do the decompression, because this is already compressed myelin, so you don't want to make any injury during this kind of procedure. So the other thing that you need to be have a very good fluid of water, so you want to see everything so clear, so you don't want to injure the already compressed nerve. And using the radio frequency is very powerful tool to control the bleeding. And this is the result of the surgery. And the second example is the female 57 years old with the lower extremity weakness with the OFL of thoracic 10 and 11. As you can see here, and CT scan very decompressed. Using same approach and using the UVE from the medial to up to cranial, and then subsequently you do the decompress from the craniomedial going to the lateral until you reach the facet. But you need to consider and you need to expose until you want to see the insertion of the platform ligament. And then after everything thin out using the burr, lastly you want to do the decompression using the Carrison ronger. So you need to be very careful doing this because all the platform already calcified. So you don't want to put the very big Carrison that can cause the already compressed nerve become injured. Using the UBE, there is a good advantage of the UBE because the very high flow of water you can see is very clear and very good view of the compressed nerve. And then the second thing about the UBE, you have very good have a space that you can walk in on, and then you can control all the bleeding and you can find where's the bleeding coming from using that. And this is the result after decompress. And how about the uniportal and biportal endoscopy? You can see, and the left side is uniportal and the right side is the biportal. You can see there is in biportal, you can see you have a lot of space to play on, and you can slide on all your instrument up and down, medial to lateral, and because of that thing, you can have a mobility of instrument, and the endoscopic view is very clear if you compare the two endoscopic, and the very clarity of the clear of the endoscopic view is very amazing in the endoscopic UBE. And the other thing is that easy to control the bleeding using the UBE. And the second, lastly, the instrument investment is very cheap using the UBE. This is the series that are ossification of platform ligament. So far, already done 13 cases, and then all the cases were good. And better GOA score. And the most common complication is incomplete decompression, usually caused by inability to identify the surgical anatomy because of too much calcified already, making your orientation a bit confusing. And the other thing is that the very thick ossified platform making it confusing as well. And you need to have a very good instrument to do this kind of surgery. And here, there is a ossified ligament that still left there. And the other complication could happen in this kind of surgery is the dura tear. Usually due to adhesion of the platform to dura, can be prevented by lifting up the platform without inserting any keresan. Then neurologic deficit is another kind of complication could happen as well. It's common after surgery, so you need to be careful. And then how to minimize this kind of complication is you need to be more precise using your instrument whenever you do manipulation on this thoracic area. In conclusion, the full endoscopic thoracic decompression is possible for management thoracic stenosis, and the choice of uniportal and biportal is surgeon preference. Thank you very much, sir.
Dear ECUP, fantastic presentation. Management of ossification of thoracic flavum ligament hypertrophy is not a very easy topic to talk on or easy topic to even operate. It requires great skill, a lot of complications there, I accept. Chances of having a tear is much higher, but I hope you all can hear me. Can I be heard?
Yes, Professor.
Yeah. I'm really sorry. We have a power outage here, so I'm a little dark for the time being. I'll be back on. Thank you very much. It's a beautiful topic, and you have explained it very beautifully how you do it. I will now invite our next speaker, Dr. Saishav Shah, because I think Dr. Adam is taking some time to join us. So, Dr. Saishav, are you there? Can you please share your screen?
Sure.
Welcome, Dr. Saishav. It's a privilege to have you with us today.
Same here. Thank you. Is my screen on?
Yeah, your screen is on. Yes, you talk softly. Yes, Aisha, you're on.
Yes. Good afternoon, sir. Thank you. Good afternoon, everyone. Thank you for this opportunity for giving this lecture. So I am Dr. Shaishav Shah, a consultant spine surgeon in the western part of India, Vairog Hospital. I'll be talking about tips and tricks of UB lumbar discectomy and its applied anatomy. I have no disclosures. So what we will be talking about in this lecture today is the applied anatomy for discectomy. Different types of disc herniations will take one by one, and approaching those disc herniations and the difficulties in conducting those discectomies, and eventually the complications that those are avoidable. So basically, how to reach a disc? It is just like climbing up the hill, getting up to the success. Till now, we were bleeding a lot, but that success was also not easy. But doing it with less bleeding needs more efforts and more pre-operative planning. More planning down the hill leads to less bleeding through the hill and a good success. So, what are the must before performing a discectomy? What are the must-do steps to start a formal discectomy before inserting the disc forceps? So, a pre-operative planning, adjusting the portals. In biportal endoscopy, it is almost similar to the uniportal thing, wherein you need to adjust your portal, cranial, caudal, medial, lateral. Also, a good bony work. I personally believe a good bony work before doing a flavectomy, which is a savior for us before reaching the neural tissue. A good bony work before doing that can help us do less bony work after doing a flavectomy, which is a bit risky in my personal belief. And eventually controlling bleeding in every step. Now going more into endoscopic surgeries, we've got to know more of microanatomy of the lumbar spine. We know more of the small bleeders which we can preemptively coagulate. So first we will talk about the bleeders, the superficial bleeders. These are the arterial bleeders in more towards the 7th, 6th, and 5 o'clock positions in the endoscopic view. So you can see over here the vessels, periarticular vessels, superior articular and inferior articular vessels, which are the branches of the segmental lumbar artery. These need to be preemptively coagulated. Bleeders, I think bleeding is the most problematic part. The most irritable part for an endoscopic spine surgeon. When we talk about the deep bleeders, these are mostly the venous bleeders, which are beneath the thecal sac. Generally, at the disc level, we need to consider these bleeders, and while inserting cages, I think we need to coagulate this one. So, for an endoscopic surgery, what are our directions? How can we approach? How much can we approach? And what is our scope for an endoscope? So if we can see, we can almost address the whole of the this thing, possible pathological part. We've been discussing since morning about the UBE portal sign. I think we are well versed. Just to brief it out, the medial radicular line, the incisions must be on these ones when we are thinking of decompression and discectomy, docking on spinal laminar junction. The checkpoints to avoid dural tears. I generally see these 3 points. Even while after completing my procedure, I usually check these points and then I do the closure. It is the midline, the lateral, ipsilateral, and the contralateral nerve root sleeves, and the inferior lamina upper edge. Now taking one by one, the disc herniation. The central large disc herniations. This is a 34-year-old young guy having L4, L5 large central disc herniation. You can see, luckily he did not have gallbladder in his symptoms, but he did have neurodeficits. So addressing these disc herniations, I think we need to go more lateral in order to injure more of the nerve tissues by iatrogenic damage and increase the deficit. We should go more. I mean, previously we used to, many would agree that we used to do a wide laminectomy fixation things for such huge disc herniations. So for such disc herniations, I generally go more lateral preemptively. If you can see in this video, there is a good amount of space even lateral to the lateral edge of the dura. So just retracting little bit of this thing. In endoscopic thing, we preserve midline contralateral facet. So ipsilateral facet, little bit of I think it's justified in contrast to having a deficit. So you can just see. I mean, we can blur out the ipsilateral facet and little bit of the superior facet, and we can be there. Yeah. So a central disc herniation, I mean, as I said, little bit of more burring is required. The portals, I think, in my personal view, I think more a little bit of towards the lateral aspect, not more medial, because especially the working portal, you can have the scopic portal medially, but the working portal has to be little bit lateral. So that you can approach it, the central disc herniation, you can catch hold of the edge of the herniation fragment and take it out, rather than having a medial this thing. You need to you need to retract it a lot. This is one more video of a central disc herniation. I mean, this is show us the whole procedure. This is also a young male having alpha S1 large central disc herniation with more towards the left side and more towards the left side. I'll just continue with the video. So this is the cranial aspect. This is the caudal thing, medial and lateral. Now clearing the soft tissue over the lamina. Docking, we all know the docking over the spinal laminar junction using the RF. Start the burring once you're done with the soft tissue thing. I personally believe in doing less of the soft tissue dissection and starting immediately as I see the edge. Sorry. Yeah, and burring down the spinous process until the contralateral facet. I generally shift from small burr to the bigger one. I think the bigger burrs are very helpful to increase the space, interlaminar space for our scope as well, for our eye. Splitting the midline, removing the superficial part. I don't know why the videos are not working fully. And then the dissecting. Videos are not working fully. So migrated disc herniations are a real challenge for a spine surgeon. These account for almost 30 to 70% of the disc herniations. Migrated disc herniations can be up and down, in up, high and low, and in down, high and low. So the challenges that we face can be overcome with proper knowledge of the technique of the anatomy and perseverance. So we'll take the upper lumbar spine. The upper lumbar spine has narrow lamina as compared to the lower spine. It has vertical facets, so iatrogenic injury, iatrogenic instability is more common with upper lumbar spine. And the distance between the disc space and the interlaminar space. As you can see in the alpha S1, there is not much distance between the interlaminar space and the disc. Not much of the bone is required to be removed. Same is in L4, L5. But as we go higher, we need to take down more bone to reach the disc level. So, so a translaminar contralateral approach. I mean, in ipsilateral approach, as we can see, if we go through here, there are high chances we can injure the pars for a disc herniation that is migrated in this way. Whereas a contralateral translaminar approach can help us reach the disc herniation without much damage. In this, we need to take out the flavum, whereas in this, we reach directly over the thecal sac and we can remove the disc herniation. Even the ligamentum flavum is spared over here. So contralateral approach helps preserve much more of the bone, much more of the facet as compared to the ipsilateral approach, wherever possible, because in alpha S1, one can see if we need to remove this disc in alpha S1, we need to retract a lot. Whereas in upper lumbar, and there is not much of the retraction that is required for a posterocentral disc herniation. This is a young 45-year-old male having up migrated L3-4 disc herniation. So we can see removing this disc herniation would be a challenge as we can go from when we go from here. We can injure the pars over here, whereas if contralateral translaminar approach is much easier. This is a small video. I hope this video works fully. So just clearing the soft tissue there. The base of the spinous process and the contralateral lamina. We directly go to the contralateral side. We need not work on the ipsilateral side. As you can see, if we work more on the ipsilateral side, we need to take out quite a bit of bone, and we can destabilize the spine. Burring, making more space, taking out the flavum. In contralateral approach, it is also more advantageous, as we can see both the exiting and the traversing nerve roots, making more space with the matchstick burr. Ligamentum flavum is removed, and then we do a discectomy over there. This is the contralateral traversing nerve root. Then we go on to remove the disc, which is over here beneath the exiting nerve. Generally, these disc herniations are in the axilla of the root. Now, down migrated disc herniations. So in upper lumbar, the same thing. I mean, down migrated disc herniations, we can go contralateral translaminar. Now in lower lumbar, I mean, it's my personal this thing. I mean, we can go through quite a few things. I mean, we can have a Zhang's third portal as well. In a down migrated disc herniation, if we take routine portals, we need to take down bone more over here. To avoid that, we can shift our portals a little higher, or else you can take a Zhang's portal as shown in the morning, and we can reach over here more easily without taking out that bone. I mean, you can take out that bone whenever you need, but taking out less bone and reaching that space is much easier just by shifting a little bit proximal. Now, I'm a right-handed surgeon, so I prefer more on the left side. Now, how to deal about with the right side disc herniations? People do switch the sides, but but for me, I stay on the same side, keep my portals the same, and I'm much more comfortable in doing this approach standing from the left side. Just the angulation and the orientation that changes a little bit. Talking about the extraforaminal disc herniations, there are many ways to reach success, but we can definitely treat these disc herniations transforaminally. I'll just show the way of paraspinal UBE approach. So the incisions will be like this. I mean, the proximal endoscopic incision is over the transverse process of the upper body, and the lower one is on the transverse process of the lower one. From the middle to the lateral pedicular line, you can start from there. So dock your portals over the SAP. Take down our first target of removing bone is SAP tip. Identify the lower transverse process and then start removing the SAP. So this is the safe zone. You can burn down till here. Remove the SAP, and the disc herniation would be there, ready for you to be grabbed. As the root would be as the disc herniation would be mostly in the axilla of the exiting root. This is a right-sided foraminal disc herniation. One more case. You can see clearly here the root is compressed, is the foraminal disc herniation. So approaching this case, L4, L5, right-sided foraminal disc herniation. One can stand on the left side, taking two portals and targeting this SAP tip, and then the disc herniation would be there, as I showed the steps. So this is the endoscopic view. This is the SAP tip here. This is the transverse process. There will be a ligament, for a foraminal ligament there in this approach, which needs to be taken down to reach the exiting root, and below that would be the disc. UB is also very grateful for recurrent disc herniations. I mean, the view. I mean, believe me, the views in recurrent disc herniation was so beautiful. I mean, there was yes, there was fibrosis, but that can be tackled very easily with endoscopic view, with magnification and fluid management. Not much of the bleeding. So this is a L4, L5 recurrent disc herniation, left-sided. For this, as I said, I had to make the portals more proximal to reach this disc. I used that technique to reach this disc herniation. You can see the disc over here, and after removal of the disc, the root is free over. Thank you everyone for your time. Thank you to my mentors. Thank you.
Thank you so much, dear Seshav. A wonderful talk. If I may summarize, you spoke wonderfully on vascular anatomy. Can you hear me?
Yes, sir. Thank you, sir.
And what I really appreciated about your talk was the way you explained how to go for an up migrated and a down migrated disc, especially the sublaminar decompression from the contralateral side, preserving the pars and preserving a lot of the lamina itself. Especially also in down migrated discs, how you chose to shift your portals a little up so that you get the angulation downwards. You can do a little bit of undercutting of the inferior lamina and reach your migrated fragment. Excellent presentation all the way around. I think you stuck to the basics, but you explained the basics so wonderfully. I think your lecture should be a guideline for all upcoming UP surgeons. Fantastic. Thank you once again.
Thank you so much, sir.
We will now go back to our old friend, Dr. Adam, who was not able to give his talk. Dr. Adam, are you with us now?
Yes, sir.
Please start your screen sharing and let's hear your handling of your own complications.
Okay. First of all, thank you for.
Can be closer to the mic a little bit.
Thank you for attending me. Check. Can you hear me, sir?
Yes.
Check.
Thank you.
Thank you for inviting me at the Congress. Thank you for the organizing. Thank you for organizing the meeting. My name is Adam. I am the student of Dr. Malcolm, and I did a spine fellowship in India under MGM University 2019 and 2020. This is my presentation, how I tackle my own failed back endoscopic surgery. Because I am a newbie here, I just want to share my experience doing my first 100 of endoscopic spine. There is no easy way, or the learning curve is very steep. I failed, and I meet the patient who is unhappy with my result also, at first of my 10th surgery. Instead of learning from other people's success, learn from their mistake. I like watching people mistake, surgeon mistake, how they do a mistake in endoscopic surgery. Most of presentation here telling us about their success, but actually I want to learn from their mistake. How can they achieve success? How is their mistake? I want to learn because I make so many mistakes. Here is my video that inspired me. That is a 83 years old male with residual sciatica following partially successful translaminar decompression for multi-level stenosis, and there is a FBSS lateral stenosis, common residual because translaminar approach may not reach lateral recess. You can check from video of the Dr. Anthony Young. Even in America, in US, they have Dr. Anthony Young was referred by spine surgeon Beatons for endoscopic transforaminal decompression under foraminoplasty and rhizotomy. And from this video, I put the link here and the YouTube. You can search it YouTube here. Dr. Anthony Young post FBSS, failed back spine surgery. And then I also met this kind of surgery from my friends also, and my colleagues. They send me about this kind of patient, so I have to do it to redo the surgery. Where is the residual stenosis? As you can see here, the previous surgeon decompressed the posterior very nicely, and it may be look very nice also under endoscopic. But what happened for the MRI post-op? We still can see a MRI residual lateral stenosis. If there is a dilemma, if I were the surgeon, I will decompress more the facet. I will burn more the facet, go to the laterally, but it will cause the instability of the patient, and I have to insert the pedicle screw and also the cage. But not all the patient want to do fusion surgery. So for this kind of patient, very old patient, what can we do for this kind of patient? I will share my experience about this as a young spine endoscopic surgeon. Before I try to tell my story, I want to give you a reference, a good book, Who Moved My Cheese by Dr. Spencer Johnson. It's a bestseller. And every time I see a lumbar spine, MRI spine, I always feel that I'm watching a Mickey Mouse movie. So it gives me a happiness, and also I feel so happy when I watch, because I remember my childhood. So I will send you the video. It will break our stress for the meeting. I hope this will make you enjoy this meeting.
Long ago, in a land far away, there were 4 little characters that lived in a maze.
2 were mice named Snip and Scurry.
And 2 were little people, the size of mice. Their names were Hem and Haw. In their own way, all 4 characters discovered what they were looking for. Eventually, each one arrived at Cheese Station C and discovered their own special cheese.
Snip and Scurry woke early every day and ran the same route through the maze to Cheese Station C.
However, Hem and Haw woke later each day and strolled slowly over to Cheese Station C. After all, they knew where the cheese was and how to get there, and they assumed it would always be there.
Who moved my cheese? It's not fair.
What'll happen if the cheese isn't here tomorrow? All my plans are based on the cheese being here.
Hem's and Haw's behavior was not very attractive and kept them from succeeding, but it was understandable. Finding cheese wasn't easy, and it meant a great deal more to them than just having enough of it to eat every day.
While Snip and Scurry had changed, Hem and Haw continued to, well, Hem and Haw.
You know, if we just try harder, maybe we'll discover the cheese is still here.
So Hem and Haw worked longer hours, but still they did not find their cheese. Haw was beginning to realize how hard they were working without secrets.
Then Ha lived up to his name.
Look at us. What are you laughing at? They moved our cheese and you think this is funny?
Oh, Ham, we keep doing the same things over and over again, and we wonder why things don't get better. Now that's funny.
Who moved my cheese? Who moved my cheese?
Ham, it's time for us to find something better.
You're not really going out into the maze again, are you? Why don't we just wait here until they put the cheese back?
They're never going to put the cheese back. That was yesterday's cheese. It's time for us to find some new cheese. It's time for new cheese.
Then Ha jogged into the unknown. He soon realized the unexpected can happen.
Oh, that's gonna leave a mark.
Ha picked himself up and got back on course.
Being back in the maze isn't nearly as bad as I feared.
He had changed his own beliefs. He knew that change wasn't always good or necessary. Ha used to believe that his cheese should never be moved and that sudden change wasn't right. Now he realized that most change didn't happen all of a sudden and that it could lead to something better. He now knew it was good to go into the maze to find new cheese.
He was pursuing his sensible vision, seeing himself finding new cheese. And then one day it happened.
Piled high everywhere was the largest and most delicious looking supply of new cheese Ha had ever imagined.
Wow, new cheese. Is it real or just my imagination? Hey, it is real. New cheese was out here all the time, just waiting for somebody to find it. I wonder if Ham will ever read the handwriting on the wall. Will he ever change and win?
Ha knew it would be easy for him to slip back to his old ways if he got too comfortable. So each day he inspected Cheese Station N to check the condition of his cheese. He went out into the maze and explored new areas. He knew it was smarter to be aware of what was going on around him rather than to isolate himself in his comfort zone.
Move to the new cheese and enjoy it.
Okay, this is the video that inspired me why I changed from my open surgeon, spine surgeon to endoscopic spine surgeon. And after doing endoscopic spine surgeon, for a posterior midline, I do not want to live in a comfort zone doing only posterior endoscopic, but I also learn other approach because some way the same technique will not work in the same patient. So I want to talk about what is failed back surgery, spine surgery. What does FBSS matter? FBSS causes. What should we do? Percutaneous transforaminal endoscopic decompression and also case presentation. You can check this out. Failed back surgery is a persistent or recurrent pain after at least one previous lumbar surgery, culminating in repeated operation. North et al. 1991. As a young spine surgeon, realize or not, we sometimes do this kind of surgery. We did sometimes one failed surgery, but we never report it in a meeting because this is our mistake that only us know. But in this particular meeting, I want to share you about my mistake. Non-specific term that implies that final outcome of surgery did not meet the expectation of both patient and surgeon that were established before surgery. And lumbar spine pain of unknown origin are persisting despite surgical intervention or appearing after surgical intervention for spinal pain originally in the same topographical location. The various definition used. One of my teacher, Dr. Satish Chandra Kure, FBSS Adam is not a wrong surgery, but wrong diagnosis. When you have FBSS, you have to rethink, have you done anything wrong to this patient? You have to learn the factor from you first before you appoint the other factor. So I learned from this teaching, various definition used, important point. paid at the same topographical distribution, previous surgery, little non-pain mechanism, and unmet expectation. Some surgeon has done a posterior open spine and then decompress with endoscopic and then decompress the surgery, the patient still pain. So why don't we check another way like the hem and like the story I proposed you before. Exact incident is unknown. FBSS incident estimation, lumbar laminectomy and fusion 10 to 40%. I told you all my audience the FBSS incident is still high and the burden is still high. And FBSS patient is compared to other chronic pain. And the patient have a greater level of pain, lower quality of life, greater disability, and the financial burden in US is very high. And etiology, we have to learn to exclude or to overcome this kind of problem. We have to learn the patient pre-operatively, intraoperatively, and post-operatively. Most of the meeting of endoscopic only expose how we did the surgery, but we are not looking forward about the pre-operative condition of the patient and post-operative follow-up for this patient. Does the patient have a benefit for endoscopic surgery for 1 month, 2 months, 3 months, 1 year, or it is a long-term surgery, or the patient after 1 year has to go for fusion surgery? We have to be honest about this kind of method. And pre-operatively, is patient-related, psychological, social, smoking, surgery-related, and so on. And intraoperative poor technique due to the young surgeon like me. I'm a young spine surgeon endoscopic with only 100 or 200 cases. Maybe I do more poor technique. That's why I need this meeting to learn about to experience to improve my technique. Incorrect lever surgery, unrecognized pathology, and inability to achieve the aim of surgery. And post-operative also the progressive disease, epidural fibrosis, altered biomechanics causing new instability. I'm doing for a PSLD and I were 2 lateral, so I destroy all the facet and I broke the fascias articularis and I create a new instability. So I have to fuse the patient 2 months after the endoscopic surgery. There's also my complication of doing surgery. Surgery complication, myofascial pain. So what should we do? Prevention is the key. Consider surgery only if necessary. Option for more conservative surgery. Be honest with patient about the possible result. Evaluate for any psychological and social stressor. If FBSS occur, detailed evaluation. So there is the protocol from Chan et al. If there is red flags, yes, we earlier surgical referral. Is no surgical correctable factor and refer to spine surgeon. Yellow flag, more intense psychological and social support and interdisciplinary. We have to know the predominantly axial pain, and if there is a predominantly axial pain, we have to check is it facet joint. We cannot go straight to the MRI and there is a compression and we just do the decompression endoscopy. No, we have to evaluate the patient as a young surgeon. So we have to be wise to take it to go surgery or no. If there is a still pain, we can do lumbar medial branch block first. We can do selective nerve root blockage first to make sure that the pathology is there and caused in the lateral stenosis. And if fail, we still have a possibility to SI joint, percutaneous epidural epidosis, and so on. How about percutaneous transforaminal endoscopic decompression for failed back surgery syndrome? This old journal from Schoverman said that over 90% of VSS diagnoses have structural cause. With the advanced technology of endoscopic, we can see now very clearly to the nerve, and the foraminal stenosis is 25 to 29% of FVSS. It can be treated by endoscopic, but painful disc to 20 to 22% fusion endoscopic. Pseudoarthrosis, fusion endoscopic. Neuropathic pain, gabapentin. Recurrent disherniation, we have to check with MRI and we redo. Iatrogenic instability, as I did before, we should need fusion endoscopic. Facet pain, medial branch block, dorsal rhizotomy, and fusion. Sacroiliac joint, SIJ pain, 2% injection, and SI fusion. So there is a good paper from Anthony Young and also Kathleen. It told about endoscopic foraminal decompression for failed back surgery syndrome under local anesthesia. Why I propose this under local anesthesia? Because for to treat the patient with failed back surgery who has experience of a previous lumbar surgery, when we do it under local, we can check directly live with the patient patient response. I mean, doctor, I still have a radiating pain. So when we when we do the surgery, we will check, is the patient the pain gone, the complaint gone. We cannot do it is under we cannot do under GA, and as we decompress everything, we fused everything, and the patient wake up and the patient, doctor, I still have pain. So we are not helping the patient. We're just maybe we were fulfilling our ego or our educational purpose, but did we help our patient? This is the problem. So there are 30 cases of recurrent dissemination of foraminal previously diagnosed and treated by epidural gram with BINFAST 6.2 and ODI 43%. Fast improvement was 4.4 ODI improvement. There is a paper also. There's a Gray and Kumar. There's a patient with this is a patient with treated by motor vehicle accident and so on. Maybe the patient after we decompress, the patient is happy, but when the patient getting pain, he is not come back to our clinic. He's going back. He's going to other doctor. He's going to other doctor. He's going to other clinic. Maybe the patient has not relief with the condition. So how about my experience? This is my own experience. The male 55 years old with a back pain fast score 5 to 10, 5 from 10, left leg pain fast score 9 from 10. In the distribution of L5 dermatome, back pain radiating to the buttock, posterior of calf until the sole of the foot, no psychological or social stressor. I will always ask this. Most of my patients with a worse result have a problem with a family problem or financial problem. Even we decompress everything, the patient will still pain. From this flexion extension, we see that the back is still stable. From the MRI reading, we can see that there is a stenosis and modic degeneration here also at the level L4-5 and L5-S1, and the severe stenosis at the L5-S1 and moderate stenosis, and also lateral recess stenosis at the L4-5, the left side, and also bilateral lateral recess stenosis. Because this is stable and the patient doesn't want to go fusion, he want to have endoscopic. For the rhizoma, I already told the moderate this and the BMI this, patient refused to have fusion. And because I don't have a PSLD instrument for this pandemic, I use my old method, micro endoscopic. This is a dry mode with 1.6 centimeter. I decompress everything, laminotomy, flavectomy, and also I decompress and I drill half of the facet, and I make sure that there is no instability here. And as you can see here, it's already finished. I decompress the nerve. I can see the exiting root and the traversing root. This is the dura and clear at all pulsatile. It is the left side. I perform also partial facetectomy and total flavectomy, and I was sure at the time the patient will have pain free. But what happened one day after? The patient have an insignificant reduction of left leg pain from 9 to 10 to 8 point per 10. Maybe the patient feel sorry with me, so he reduced the leg pain, but I'm sure the patient has still pain. So I make this checklist. Is it foraminal stenosis or painful disc or osteoarthritis and everything? So I go to the first step, the foraminal stenosis. So I do transforaminal steroid injection at the L5-S1 level. And the patient has said that, doctor, my leg pain reduced dramatically. So I remember my previous video as people that the mouse that learning that I have to try the other method other than posterior approach. I check this journal that this is a positive predictive value that PPV 0.38%, pre-op lidocaine transforaminal epidural steroid injection related successful clinical outcome for transforaminal decompression. So I did the patient transforaminal at the left side. I clearance the axillary side. As you can see, I use hook here and I test there is a small fragment hiding in the axilla. I try to test it under local anesthesia and I ask the patient, how is the leg pincer still there? How is the leg pincer still there? And I try to clear the lateral recess and also the axillar, the foraminal region. As you can see, I struggle using this teaser, this hook. This is a Dr. Gore hook from Karl Storz. And sorry for the picture because too many lights here. After I successfully take out and clear this lateral recess and also the axillar, where the patient said, doctor, my leg pain is gone. So first I will do foraminoplasty also, but I think it will create more instability because I already destroyed 50% of his facet. If I do foraminoplasty 25%, I will make a 75% destruction of his facet. So post transforaminal, the fast and the back pain is gone. The patient can walk freely. No ICU, no fusion. Okay. The personal. So I want to tell you, are we a hem the stabilizer who's slower pace, or we carry the producer, or we have the unifier, or sniff the innovator? It's up to you. You are the orthopedic surgeon. You can be the stabilizer or the innovator. Thank you so much.
Thank you, Adam. That was a wonderful talk. You have given us a rain check, all of us. You have covered the gap between reality and unmet expectations. I agree with you that there is a lot about endoscopic spine surgery that is yet to be streamlined, and FBSS is going to be a part of our life. We need to assess it carefully and work hard on it. Wonderful topic and wonderful presentation. Thank you very much. I now invite our next speaker, Dr. Dennis from Russia. If you're there with us, please, can you please share your screen, Dr. Dennis? Dr. Yuzakov Dennis, are you there with us? Dr. Ibrahim Maiden, can I request you to start with your talk? Can you please share your screen? Hello. Dr. Ibrahim, your mic is muted. Please put on your...
Yes, I'm here.
Please start your presentation, sir. Thank you so much.
Good afternoon. My name is Ibrahim Abdullah. I'm glad and honored to participate in this webinar. I would like to tell you about the modern ways of surgery of neural compression syndrome caused by intervertebral hernia. Actually, 75% of people aged 90 to 65 suffer from the back pain.
Hello, Dr. Can you please share your screen properly? Please share your screen properly. Please enlarge your screen and be a little closer to the mic. Can you enlarge your screen, sir? We can see your presentation, but if you can play it properly.
Okay. You hear me? Good afternoon.
Go ahead, please. Go ahead.
Good afternoon.
Dr. Maiden, you are again mute. You are mute. You muted yourself. Unmute yourself, please.
Okay. Good afternoon.
Yes, please go ahead.
Okay. My name is Ibrahim Abdullah. I am glad and honored to participate in this webinar. I would like to tell you about the modern ways of surgery of neural compression syndrome caused by intervertebral hernia. Actually, 75 of people aged 18 to 65 suffer from the back pain. 84 to 90% of the population during their lifetime has got lumbago. 69% of the population has got lumbago exacerbation within 5 years. Small back pain frequency is increasing due to the aging of the population. Historical aspect, the surgery 1977 and Casper and Williams 1987. Microdiscectomy principles done by interoperative microscope, minimize the skin incision and normalization of soft tissue, bone structure, bone resect, removal of ligamental flavin, and epidural pins do not coagulate. Discectomy medical indication, absolutely and relative or not effective of epidural steroid injection. According to the Ministry of Health of Ukraine, approximately 19,865 discectomies were done at neurosurgery department in 2018. After discectomy, 70% of patients have good pain in lumbar, sacrum, section 4 a long time. 9% of patients after discectomy are in need of additional stabilization for a pain relief. Lower end plate perforation, directly adhesions process in epidural space, intervertebral disc height reduced. All of this could occur properly. Professor Thomas Hoagland was the first to create the percutaneous transforaminal endoscopic discectomy road and triangle campaign. Clinical case. You can see video, clinical case. Disadvantage of percutaneous transforaminal endoscopy, relapse rate increasing up to 15%, radiation of mixed staff, unilateral biportal endoscopy. This is a modified interlaminar transforaminal interforaminal epidural spinal surgery. Historical aspect, Dr. Abdul Jafar, 2001, and Dr. Soon, 2013. Required equipment, endoscopic system, 0 degree, endoscopic 4 millimeter, probe drill with sheath 4.2 millimeter, radio frequency system, spine probe, irrigating system, spacing UV instrument, general spine instrument. Technical aspect of UVA, 2 cuts are done, width of 6 millimeter, each with 3 centimeter. Distance in between and are used for 2-quarter insulation, one of visualization, one is working port, what are used in the mind of spine process, in a way that side projection of crossing. Mine are matched with upper and plate. The upper part of solid food, the picture what neurosurgeon sees during unilateral biportal endoscopy. Advantages of endoscopic discectomy, minimalizing cosmetic defect, general hospitalization, operation in performing under local or epidural anesthesia, rapid hospitalization and rehabilitation, minimalization of soft tissue, trauma, perfect visualization, no blood loss, minimal risk of infection, complication. This is also one observation in our clinic. Length of cut when different method of discectomy. Open surgery 10 centimeters, but under microscope 2 centimeters, and endoscopic microdiscectomy 8 millimeters.
Dr. Ibrahim,
yes.
Could you please get closer to mic because we don't hear well. Thank you.
At the end of my presentation, I would like to show my hope that not only microdiscectomy offered 40 years ago, but the endoscopy methods of intervertebral hernia will be more popular, providing better results, minimal cosmetic defect, rapid recovery. Thank you for your attention. Have a great day. And I want to see. You see videos in my experience.
Dr. Ibrahim, thank you.
You can see videos. My experience. You can see videos.
No.
Internal approach. Now.
Yes, Dr. Ibrahim, we seen your presentation. We thank you very much. It was a wonderful presentation.
Video.
I will now request Dr. Denis Yazukov from Russia. Are you there with us, sir? Dr. Denis? Dr. Yuzakov. Dr. Yuzakov. Are you there with us, sir? Dr. Denis, are you there with us? If you're not there with us, I think we will go ahead with Dr. Somanshur. Dr. Somanshur, are you there with us?
Yes, Dr. Pistonji, I'm here. Can
Please
hear
start
you well.
sharing your screen and please start your presentation. Welcome.
Okay, thank you. Thank you, Dr. Pestonji, for the inviting me to this great event. It is my pleasure to meet you, all my teachers and friends, colleagues. I would like to thank you for sharing this endoscopic knowledge to all around the world. So I would like to speak about the thoracic spine, percutaneous endoscopic decompression of the thoracic spine. It is very rare to speak about it. Before the presentation, let me little bit introduce the information about Uzbekistan, where I am currently working for. It is our country is in the center of in the Central Asia. It's a very beautiful country with a great history. It has very famous for its cuisine and delicious fruits. So please visit our country for the tourism. So I work in the private hospital in Tashkent, in the capital of Uzbekistan. I am the student of the Dr. Kantay Klim. He visited our hospital since 2017 several times for the workshop. And I took the fellowship in his Tenten hospital in South Korea. And from 2019, I have started doing the PSLD on my own. So let's get back to the thoracic spine. symptomatic thoracic spine stenosis or disc herniation account only for the 0.15 or 1.8 of the all intervertebral disc pathologies which treated surgically. So which means the most unusual case is usually for the surgeon is thoracic spine cases. So presenting symptoms in the thoracic spine are usually pain in 92%, reduced sensation or numbness in 59%, and motor weakness or deficit in 37% of the cases. So thoracic spinal stenosis is a relatively common disorder for causing the paraplegia. So usually when patients have the thoracic disc problem, so 95 to 98% of the cases, usually they treat non-surgical treatment by physical therapy, the exercises, or the pain medication like non-steroids or steroid injections. And from this patient, approximately 2% cases will get surgery done by will be treated in the surgical way. So open cases for the thoracic spine is usually very aggressive. Simple disc bulges usually require thoracotomy, or if it's a stenosis, it should be done posterior decompression. And most of the time it requires the fusion for prevent the future instability. So now we can offer for the patient is a full endoscopic decompression for the thoracic spine. So with the endoscopic surgery, patient usually get very lot of benefits. It is decreasing the muscle crash, usually in open surgeries due to the prolonged retraction, muscles get very severe crashes. So avoiding the significant soft tissue stripping, minimizing bony resection, which can prevent iatrogenic instability, decreasing the post-operative pain, and also very important is total control of the direct pressure on the neural structures. This is very big difference with open surgery, because in many cases in open surgery, it's from the side of the surgeon, it is really hard to get under the ligamentum flavium and remove some soft tissue without making pressure on the direct pressure on the neural elements. So the endoscopic surgery will help to control the pressure on the neural structures. So I would like to share my case. This is a patient, 32 years old male, with complaints to the bilateral leg weakness for more than a year and the radicular pain. He has been treated by neurologist with all types of the medicines, physical therapy, and physical exercises. But his symptoms have worsened, so he have decided to do the surgeries. So he have chose to do the endoscopic surgery. So his this MRI is from the 1 month before the surgery, which means on the 9th of August this year. So 5th of August of this year, this MRI was done. So if you can see on T11, T12, there's a small bulge of the disc, and due to his small epidural space, this is his anatomical structure of this patient. It's unique. So it's this small bulge is making some compression to the spinal cord, and you can notice the changes on the MRI. So the main problem was this disc bulge. So the comparing to the other disc diseases, especially on the lumbar part, this is not a big extruded disc, but still it's making the very great problem for the patient. So I have decided to do the PSLD to this thoracic level, to do the posterior decompression with the uniportal endoscope with the interlaminar approach. So from this video, you can see in the beginning, I just put the endoscope directly with the aiming with the C-arm to this level. In the beginning steps, I have removed some of the soft tissues and coagulate the bleeding vessels. Oh, I'm sorry. So after the removing soft tissue from the upper posterior part of the lamina, I go for the removing the bony parts of this segment, the lamina. So first, with the thick part of the bone, it's very easy, especially in the thoracic level, to remove the lamina after you find the interlaminar space. And when we come for the more bold part of the lamina, I usually use the diamond burr to remove the cortical part of the bone. So this is a diamond burr. It's very helpful to remove the bone without any bleeding. So after removing the cortical part of the bone, the inner part I usually remove with the Kerrison rongers. I don't use the burr very deep inside the epidural space. So I usually remove the bony parts of the lamina up to the ligamentum flavum attachment. Sorry, I forgot to say that this left side, 3 o'clock, is the cranial part, and I'm sorry, the 9 o'clock is the cranial part, the 3 o'clock is the caudal part, and this is the medial, this is the lateral part. So after I find the attachment of the ligamentum flavum, I start, also I confirm with the C-arm how much up I have gone with the resecting the bone structures of the lamina. So after I find the attachment of the ligamentum flavum, I will start to remove the flavum ligament. And when the flavioectomy is done, I have checked all parts of also the contralateral part of this segment is if it is decompressed very well. And after that, I go for the ventral part of the dura and open the disc. My goal wasn't to remove the nucleus pulposus of the disc. Before the surgery, due to the small bulge, I have decided to just ablate the disc. So I open with the radio frequency machine the parallel and go inside the disc to do the nucleoplasty, to ablate the nucleus of the disc. So now you can see I use the RF and to stop bleeding and go inside the disc. Just a moment. Yes, and I do the calculation, the nucleus pulposus for the shrinking. So now the ventral part of the dura is also decompressed due to the shrinking of the disc. So results of this patient was very satisfactory. The patient have started walking the same day of the surgery at night after the anesthesia was gone. The surgery was done under the epidural anesthesia. So significant decrease of the pain after surgery, but pain still was persist after surgery. Around patient, from the words of patient, 35% of the pain still was there. So the patient has improved in gait. He was able to walking normally, and I have discharged the patient from next day of the surgery. So during today, it was 1 month after the surgery. So during this month, the result is improved very well. So no signs of pain. During 1 month, pain step by step is gone, and no any symptoms of instability. So for the conclusion, I can say that full endoscopic surgery can give the best benefits for the patients in early stages of the thoracic disc pathology. And also with the endoscopic surgery, we can achieve the fast recovery from the surgery, no need for surgeon. And the most important thing is the good endoscopic visualization and handling will prevent the iatrogenic trauma of the spinal cord. So this is it. Thank you for your attention.
So Mansoor, wonderful.
Yes, sir.
Wonderful presentation by you. I still remember meeting you way back in, I think, 2018
in Mumbai. Yes. Yes, I was there. So let me just
and wonderful
share
presentation on monoportal technique. And hats off to your mentor, Dr. Kanteklim. We all await him tomorrow to listen to him. And very wonderfully and very simply, you have explained step by step how to do a good PSLD surgery. Excellent presentation. Thank you. I think.
Thank you, sir. Thank you, sir.
A gem. And the world awaits you, son. God bless you.
Okay, thank you very much.
We'll go ahead with our next speaker. May I please call upon Dr. Ketan Deshpande, my friend and colleague. Ketan, welcome.
Hi, sir.
He's the director in our Endoscopic Spine Foundation India. I forgot to even mention about Dr. Saishav Shah. He's also a director with us. And God bless you, Ketan. Thank you. Welcome. Let's start our talk. Screen is all yours.
Thank you so much for the invitation, sir. Okay, so myself, Dr. Ketan Deshpande. I am an orthopedic spine consultant at Sai Shri Hospital, Pune. And the topic for my presentation today is UB posterior cervical foraminotomy. So basically, So basically, what we are trying to achieve by doing UB posterior foraminotomy is it's an endoscopic assisted laminoforaminotomy, wherein we just don't do the foraminal part. We remove some part of the upper lamina, some part of the lower lamina, some undercut the facet joint. We expose the lateral aspect of the thecal sac and the root itself. The indications for this type of procedure are a paracentral to foraminal disc or a case where there is foraminal stenosis resulting in unilateral radicular symptoms. As the name indicates, it's unilateral biportal. So there are two incisions and they are on the same side of the midline. So it's called unilateral biportal procedure. One thing I would really like to stress here is the medium of surgery that we do, that we use in these kinds of procedures, wherein it's not an air medium surgery, but a fluid medium surgery. So unlike other open microtubular endoscopic assisted thoracotomies or distendo, the surgeries that are mentioned on the right side, PELD, PEID, SCLD, and UB, they are done under continuous flow of irrigation. So what we have here is a continuous flow of irrigation which is going in from one port, accumulating over the surgical space, and it is coming out from the other port. So it has definite many advantages. There are of course certain disadvantages wherein we cannot go inside the dura because the irrigation fluid will just create increase the intradural pressure. But apart from that, there are definite benefits of using this pressure. So this video, you can see that the blue line is the midline. So there are two ports which are on the same side of the midline. The fluid is going in from the right-sided port, which is the scopic port. It's getting accumulated over the space and it's freely flowing out without the use of any irrigation pump or anything like that. So the operative preparations for this particular procedure include general anesthesia. The positioning is prone position with neck flexed as much as possible to obliterate the cervical lordosis and to reduce the overlapping of the cervical lamina and to create more space. We use a special drape which has a fluid collection bag, and we make sure that the C-arm should be freely mobile across the surgical site in both AP and lateral position. This is the position that I learned very recently. This is a picture from Dr. Malcolm's surgery when we were doing a 2-level cervical UB. I used to position my patient flat, but when I saw him positioning the patient like this, where the neck is absolutely flat, the neck is the head is raised, so it just gives you a fantastic area of exposure, very less bleeding as the head is on the upper side. Plus we make sure that the patient stays mobile, the shoulders are pulled down so that lateral view C-arm becomes clearer. There is some amount of flexion at the hip as well as the knee joint, so there are no stretch on the lumbosacral plexuses. So from my next case onwards, definitely I'm going to follow this. This is how we drape the patient, head side view, and when we look at from the front side, and the top view looks something like this. So the central part of the skin is draped where where our incisors are going to come. And there's this plastic bag which has got two attachments for the fluid outflow so that the fluid doesn't go and flush all of your operative room. And this is how you can see that the tube is attached to the opposite side and the fluid is collected very nicely and you get a very clear and clean surgical field. So the steps are very simple. We start with skin marking, then the ports, then triangulation, and then decompression. So let's jump into it. So this red line that you see in the center is the tip of the spinous processes. We check the C-arm like this, and we put some radiolucent, some radio opaque structure, any probe that you have across the tip of the spinous processes, we mark the midline. After we do that, we mark this line. That's the scopic portal, which comes for a right-handed surgeon, which will come from the cranial aspect, and the working portal that will come from the caudal aspect. So, and this is the point where those two lines are supposed to meet. So for example, this was a C5-6 left-sided disc herniation causing radicular symptoms in the left upper limb. So the scopic portal is coming in from the cranial side, the working portal is coming from the caudal side, and the meeting point is the laminospinal junction of the C5, that's the cranial vertebra. So we make sure that we check it in the AP and the lateral view, both the scopic and the working portals are checked like this. On the picture on the left hand side, you can see that the probe that is coming in from the upper side is going to be our scopic portal. So that's in line with the disc. It just bang on, it just goes directly onto the disc. Whereas the working portal, it comes slightly at an angle, which should resemble the angle of the lamina, so that it becomes very easy to undercut the lamina rather than banging directly landing onto the lamina and then ending up removing most of it. So just undercutting of the lamina becomes feasible. So you have to have a mental picture that when you're putting your probes like this on the left hand side, that they are going to come and meet at a point, and that point needs to be the upper laminospinal junction. So you can see that on the picture on the right hand side, when we have actually entered inside, the meeting point is the upper laminospinal junction or the C5 level. Initially, after this triangulation, what we do is we start using the radio frequency probe, and let's see what happens inside. So we do the soft tissue clearance. The scopic portal is coming in from the head side and the working portal from the caudal side. this radio frequency probe or these kinds of tissue disc forceps or alligator forceps are used to clear the soft tissue. As far as the orientation is concerned, the left hand side lamina is the cranial lamina of C5, right hand side is the caudal C6 lamina, upper part 12 o'clock is medial and 6 o'clock is lateral. So once you have that and you have confirmed this on C-arm as AP as well as lateral view, you start working on the upper lamina, which is the overlapping portion, which is covering the facet joint as well as overlapping with that of the lower lamina. And you use these kinds of burr under direct visualization. You can see that it's even though it's not a diamond cutting, but there is very less bleeding there from the bone itself. Gradually you start exposing the facet joint. Our target is the lateral 1/3 of the lamina and more of the facet joint itself. So you see there exposing the facet joint. So once we go to the inner part where we have to start working very finely, we shifted over from an oval burr to a round burr tip. And when I put this instrument inside beneath that that thin film of bone which is remaining, you can actually see that that thin film is translucent. You can see the tip of the curette beneath that. So it's just a eggshell thin lateral aspect of the bone which is remaining. At that point, you start using your Carrison punches, 1 mm, 2 mm. And our next target is to expose that part of the ligamentum flavum which is deficit on the lateral aspect, just underneath the facet joint there. So you go on cutting the bone and you need to expose that part of the flava which is deficit there. Once you identify that point, as you can see that now, that the lateral most at 7 o'clock position, you can see that the flava is deficit. So you can just enter the epidural space like that with a blunt tip or a angled this thing curette, and you start opening up the epidural space. Once the epidural space is opened out, we are quite far lateral. So what we are going to see is the root directly coming towards us. So we can very safely go on, remove those bits of ligamentum flavum which are overlapping the root there. So we lift the ligamentum flavum. We need to remove some portion of the lower lamina as well. So we do some bone cutting there. And we try and expose the axillary portion of the nerve root there. So if your case is just a foraminal stenosis without a disc prolapse, this is all you need to do. In this case particularly, there was a large disc fragment which was lying in the axilla of the nerve root. So I used a hook, a sharp hook, to engage into that disc fragment and just pull it pull it at the center part of the screen and just take it out with the help of a disc forceps. So without retracting any of the medial part, the lateral border of the dura, just grabbing that fragment and taking out large fragments of disc is very easy. You can do that at the shoulder region also if the disc is located at the shoulder region. Of course, there are loose fragments of disc which will keep on coming. So now you have to use a blunt tip forceps to remove all the bits of tissue, and that's the midline ligamentum flavum. We haven't even removed the whole of the ligamentum flavum on the ipsilateral side. Forget about the contralateral. So just isolated, and you can clearly see the axillary portion of the nerve root and the nerve root being completely free now. And that's the skin incision through which this particular procedure was done. So it's a very straightforward and a very what you can say, a very familiar thing to do. Anybody who has been doing open or a microscopic or a tubular laminoforaminotomy can very easily go ahead and do this particular procedure. So I've just made this chart to highlight the differences when you're doing a lumbar UBE and a cervical UBE. In my 2 to 3 cases, I was very skeptical about the depth of cervical. I always thought that the cervical lamina would be very closer to the skin. But on an average, I found out in an Indian patient, I found out that it's almost 6 to 7 centimeter deep. And unlike lumbar vertebra, where the planes of separation are very distinct, from skin, you go to fascia, then you go directly onto the bone. they are not there in cervical. So it becomes slightly difficult. So for those who are starting with this procedure, I would recommend you to take a bold facial cut by checking into your lateral view CM, so that you don't cause too much of facial openings and then irrigation fluid becomes a problem. Secondly, the anatomical landmarks, they are quite different from that of the lumbar vertebrae. So in lumbar vertebrae, you have lamina which are widely separated apart, whereas in cervical, they are overlapping. So you have a clear interlaminar window in lumbar, whereas it's not there. So the positioning picture that that I have shown you initially, wherein the neck is flexed so that the lumbar lordosis is obliterated and the lamina, they are pulled apart so as to create maximum interlaminar space. Also, when we do initial working track dilation, we put 2 to 3 dilators in lumbar, and I start from the medial part, the junction of lamina and the spinous process, and I go laterally up to the raised part of the medial, the inferior facet. That is also not there in cervical, because if you go on laterally, those facets, they become flat, and at one point of time, you'll just slip off the facet and it would cause too much of bleeding. So I prefer, when we're doing a cervical UB, just dock on where you want to dock at the laminospinal junction, do triangulation and do the lateral part exposure directly under vision. It becomes much more easier, and just confirm your position repeatedly. Frequent check of CM is all that is needed. So what we are trying to achieve here is the versatility of a tubular or a microscopic decompression, and combining it with the advantages of uniportal endoscopy in the form of irrigation medium surgery and a good vision, a clear vision with the camera, the eye being inside the body of the patient, and using it in the form of unilateral biportal endoscopy. Of course, the advantages are, it's a fluid medium surgery, it has a familiar anatomy and ease of approach. It's not a different approach like a transforaminal or a CLD surgery, wherein you have to learn that particular approach. You have to get acclimatized to that particular way of looking at things. Here, you know already that the structures, the identification of structures is quite clear. The visualization is of course good, and because of fluid pressure, there is good bleeding control as well. And it's a direct access to the pathology. So I would definitely recommend all of you to be a part of this team. Come to Dr. Malcolm sir, be a part of our ESFI team, learn with the best that life surgery, that maybe a life surgery, that may be hands-on workshop with pig cadavers, or the lectures, the interactive sessions that he does. And I again thank him for this excellent opportunity. Thank you, sir.
Ketan, thank you so much. You are my pillar of strength. There is no two words for you. Excellent explanation on laminoforaminotomy, cervical, how you do it and how you plan it and how you execute it. That was a very crisp presentation and very clearly put it. I will now go ahead and invite our next presenter, Dr. Mukul Kaushal. Mukul, are you there with us?
Yeah, I'm there, sir.
Yeah, Mukul, can you please start your screen share? Thank you.
Yes, sir. I hope, sir, I'm audible and my screen is visible, sir.
Absolutely perfect. Go ahead. You're spot on.
Okay. Thank you, sir. Thank you, World Congress Spine Endoscopy and Malcolm, sir, for giving me this opportunity to present this little modification of a technique where from uniportal to biportal, this technique will help us simplify the conversion and help overcome the learning curve of triangulation. So in the conventional method of docking in unilateral biportal endoscopy, usually we take a AP shoot of the affected level, the true AP of the affected disc level. We put our incisions based on the medial pedicular line, and we try to triangulate on the base of the spinous process at the junction of the spinolaminar level. So for this, actually, there is a lot of shooting involved, and this is how it looks on the lateral view. We try to dock ourselves on the spinolaminar junction. So probably the biggest drawback would be a lot of radiation exposure to the operating team and the primarily operating surgeon. So what we try to do was modify this triangulation with an attempt to minimize the radiation shoots, simplify the triangulation, and only we use the lateral view for this technique. The first one is to check the level with the spinal needle, and the second one is to check the tube docking on the right level. So for this modified triangulation, especially on the left side, this pictorial model, if we imagine that this is the skin and the facial incision, and this is the patient lying down prone, and this is the lateral view, that we can see that there is a needle which is going in the L4-5 direction in line with the L5 pedicle. So we give an incision through the skin, through the fascia. You can put in a tube. It could be either a distendu tube, it could be either a microscopic tube. Once the tube is docked on the interlaminar level, another incision is made just proximal to that tube dock, and through that a stab incision is given through the skin and the fascia, and a simple blunt rod is introduced through that skin and facial incision. It hits the tube, and then the tube acts as a guide to take that blunt rod onto the lamina of the cranial vertebra. And once over that blunt rod, you can introduce your camera and you can start the UBE procedure. So this is a little video demonstrating that technique. This is a patient we are approaching from the left side. This is a serial dilation. We pass the tube. Now this tube is resting over the interlaminar area. Now this is the outside picture, and we are seeing through the endoscope also, and we are putting in a neurosurgical patty. And this is how it looks inside. This is the vision inside the tube. That is the patty which goes inside. We can appreciate the 9 o'clock is the lamina, the 3 o'clock is the interlaminar window. Now the tube is kept there on the interlaminar window. A little stab knife is stab incision given through the skin and the fascia incision through the skin and the fascia. A blunt rod is passed through the skin and facial incision, which hits the tube, and that tube guides it to the lamina of the cranial vertebra. Then we try to manipulate and create some working space over the lamina, and over this blunt tube we pass over a arthroscopic sheath. And then through the sheath we connect our camera and start the fluid inflow, and we start the procedure. And this is how it looks inside. We can appreciate that patty also which I had put in, that is also acts as a second guide that I am on the right level. Similarly, if you want to do it from the right side, the portals usually change. The tube goes in through the cranial incision, and the working portal is created through the distal incision. The blunt rod is introduced through the distal incision, and the tube is used as sound to dock on the interlaminar window. And this is how it looks on the right side. We are putting in that's the outside picture. This is the lamina is now on the 3 o'clock side. Interlaminar window is on the 9 o'clock side. That is the patty going inside. Now again a simple incision through the skin and the fascia. We hit the tube and then use that tube as a guide to land on the interlaminar window. Connect our camera, start the fluid inflow, and that is how it looks. That is my patty lying on the cranial lamina. That is the picture inside. And now you're converted to UV simply without much radiation shoots. So the advantages which we felt of this modification was that this is a tube assisted visualization of anatomy, less need of C-arm, so less need of radiation shoots, and it simplifies or eases the conversion to UBE. So thank you very much.
Thank you. Mukul, very innovative, really great, given a lot of great thought to this whole thing.
Thank you, sir.
I'm really amazed by how you simplified triangulation, and definitely this is going to bring about a severe drop in the amount of exposure that a person undertakes. Normally, even I take about 5-6 shoots. So I really appreciate what you've spoken, and I will definitely be trying to implement this idea of yours. The use of a needle is a very innovative idea and an innovative thought. And you combine the best of two techniques, the Standu and UB. That itself is very amazing. So, God bless you. Thank you.
Şimdi konuşmam başlıyor benim. Yok yok şu an başlayacak. Sen git. Yok hiçbir şey.
You're welcome. We await you. Please start your presentation. It's nice to see you, brother.
Hi. How are you?
Absolutely fine.
Nice to meet you again.
Yes.
I have a very short and simple presentation about the choice of target choice of endoscopic approach for L5S1 level. Because we start all with transforaminal surgery, as you know, and we've seen the development of stenoscope, interlaminar approach later, and now UBA. And as you know, I'm neurosurgeon, and like neurosurgeon, the posterior approach is very easy, very familiar for us. Orthopedic surgeons, they have more ability to arthroscopy, and we have more ability to microscope. So now I see many friends, especially for L5S1 level, they prefer directly posterior approach. So I would like to evaluate and to say you how I decide what I do for only disc herniations, not stenosis of this level. Okay.
Please start your presentation, sir.
Yeah. I will. Just moment. Just moment. Very small problem.
Take your time.
I'm sharing my screen. You see?
No, you're not yet sharing it, sir. Please share it. You click on the green tab below. Open up Zoom.
Yes, yes, I do it. I do it. Very sorry, very sorry. Why I cannot share it? Excellent organization. Congratulations to you. He asked me. So sorry, I don't understand.
There must be a green button that is written share screen. Please press.
Yes, I do it, and he asked, he guide me, open system preference.
Allow. That's not allow. System. Just speak to my IT guy. He will help you out, please.
So the system will ask you for permission. So you have to allow Zoom, then it will let you share your screen.
Yes, I touched to the green share screen, and he guide me.
Then you have to allow Zoom.
You have to go in system preferences and allow Zoom for screen sharing.
Okay, I do all. Please, you continue with another speaker, and I will try to arrange it.
No problem. We'll get back to you, sir. You take your time and you sort this out. Can I invite Marisa Perez, please, from Argentina? Madam, are you there with us? Hello.
Hello.
Hi, madam. How are you?
Okay.
Please start your presentation. Can you share your screen, please, ma'am?
Yes, doctor. In a minute.
Hey, good morning. It's early morning here in Argentina. Can you all see the presentation?
No, I cannot see.
Okay.
Just a minute, please.
Yes, please take your time, ma'am.
Yes. Are you in?
Can you see it now?
No, ma'am, we are not able to see your screen. We can hear you. You have to share your screen, ma'am. The camera is off.
Okay.
You have to put on your camera, ma'am.
Okay. Sí.
Yes, ma'am, we can see you now. Please share your screen, ma'am.
Yes. And now? I don't know.
Yes.
Okay.
Thank you.
Okay.
Okay. Sorry for this time.
No problem, ma'am. Please go ahead.
Okay, well, thank you for the invitation, Dr. Hassan, Dr. Platonchi, and Endovision. Thank you very much for us. This is our endoscopic center. This is our School of Medicine in Argentina, Buenos Aires, Argentina. We will talk about the transsacral epiduroscopic laser decompression of discs. We use this approach for the management of lumbar extrusions through transsacral approach. I'm Dr. Andrea Sinara. I'm here with Dr. Marisa Perez. We are both neurosurgeons. Well, we all know endoscopy has become a successful tool in the management of disc herniations. We propose the use of the endoscopic approach, the transsacral epiduroscopy, to treat lumbar extrusions. Percutaneous epidural neuroplasty is a therapy for spinal diseases for a long time. It was originally developed to treat adhesions, but it can also have been used for targeted drug delivery and neural decompression. Additionally, we now use it for the treatment of lumbar disc herniations. But one of the disadvantages of epiduroscopy was that it could not decompress the not extruded herniated disc. So actually we use a combination of transforaminal discectomy and epiduroscopy to treat those cases of extruded ameliorated discs. In 2001, we founded the Endoscopic Anatomy Center in the University of Buenos Aires. So we've been working hard since then. We presented many papers, especially one in 2001, where we showed the endoscopic anatomy of lumbar epidural space. Here you can see the images of the nerve root. But that time we concluded that epiduroscopy allowed direct visualization of pedicles and nerve root exit, identification of lesions, fibrosis, tumors, and causes of radicular pain. It was not only to see, but also to treat. And also it allowed transpedicular fixation. But at that time, it was not used for this. In epiduroscopy, we use a laser energy to deliver it to the extruded disc through a thin optical fiber. We're gonna see now this now. The absorption of this energy vaporizes the water content of the nucleus. You can see the operating room here, a light fiber. These are some images of the spinal space, a balloon, which you will see now, and how we can see the nerve root here. All our patients had leg pain that was refractory to conservative management for more than 6 weeks. Actually, we only wait 3 months to see if the patient can improve the conservative therapy. Each patient also had a single level herniation that was checked by MRI. Well, the exclusion criteria was infection, instability, especially some traumatic injuries. The objective of our work was to prove that endoscopic transsacral approach is a safe, minimal invasive approach that can be performed on an ambulatory basis with minimal complications. This is a big advantage for us over interlaminar approach because it is done with sedation and the patient can leave the clinic after 2 hours, which is very important for the patient. 557 patients were operated on from August 2010 to December 2020. 60% were men, 39% were women. We have a wide range of ages from 32 to 78 years old. This is a very good procedure for old people because of comorbidities and cannot use general anesthesia. Patients were evaluated by visual analogical scale, pre and post-op. We use a flexible endoscope with a field of 180 grades and fiber optical illumination. You will see all the things now. You can see material here, the endoscope, which is very thin, trocars, balloons. So materials are epiduroscopy set, 2E needle, laser and fire improved, and radioscope. I'm going to show you the steps now. First, the identification of the sacral hiatus, the infiltration with silocaine. Then we introduce a 20 gauge needle under fluoroscopic guidance. Here you can see the needle, and in radioscope, the situation of the needle in the hiatus. Through a small incision, we puncture the sacrococcygeal ligament. Here you can see how we insert the trocar, and then the endoscope, infusing saline solution. We insert the cannula through the sacral hiatus, and then we're ready for epiduroscopy with laser and camera equipped. Here we can see how the catheter is entering the paracentral area of the disc under fluoroscopy, and here you can see it reaching the midline and moving from one side to the other so that we can treat any of the two sides. Some other videos here to show you how the endoscopic catheter is situated in the ventral area of the epidural space. You can see it there, going up, ascending. There is no need to use abundant irrigation to obtain high quality images. This is important because we do not overpressure the space. The recommended duration of the procedure is around 60 minutes. Here we can see how we are entering the spinal canal, one of the first images. You have to rotate the endoscope. You can see it the fibrosis here, the lesions. Here we are sure that we are in the spinal canal because of the negative pressure. You can see the bowels going inside. These are some images of the pyroscopy of bulging disc, adhesions, dura. This is the annulus. Here you can see how the catheter is ascended and moved from one side to the other. Well, this is already the operating room, the endoscope. We are working here. We use a balloon. You can see how the balloon is inflating here and deflating. You see it clearly. Just to open adhesions and to separate them from the nerve root. This is the balloon inflating. Some more pictures of the operating room and the laser, our laser. Here you can see this case was a lumbar facet cyst that was causing radiculopathy. You can see it there. And this is how we are opening it with a laser. This is the laser fiber there, working on the cyst to open it and to diminish the pressure on the nerve root. This is quite often you find lumbar facet cysts causing pain. Here was the MRI image of the cyst. You can see it here. Well, this is a succession of images of how we find the extrusion and how we work with a laser on it. You can see it here. Till the channel is open and the root decompressed. You can see the final image here of the decompressed root without extrusion. Usually we also used a grasping tool. You can see it there. We have used a balloon first, and then there's a free fragment of disc which is taken through grasping tools. Here are some images, successive images, and how the fragment is out and the root is decompressed. Another picture of the balloon working on the nerve root. That is the nerve root. How we separate it from adhesions till it's free. You can see it here, how the root is freed from adhesions and from the disc fragment. And here you can see, this is a nice view of the root, of the freed root and the spinal canal. Our patients are evaluated by visual analogical scale, pre and post-op. There is an improvement of 80% of the previous pain status with complete remission of symptoms at 6 months follow-up. As we were saying, we usually use this pyroscopic approach to assist the transforaminal discectomy, especially when there are migrated discs. Here we can see both approaches in AP and lateral view with both marks. So we conclude that the pyroscopy assisting transforaminal discectomy is a good alternative for difficult discectomies when there's a high-grade disc migration and chances of missing the fragments are high. Patient can be discharged the same day from the hospital. This is a great advantage for us, that you can do the whole procedure through in ambulatory basis with sedation in opposition to general anesthesia needed for interlaminar approaches, which are proposed for extrusions. Well, these are some funny pictures of our team. We are working here with anesthetists. As a result, we don't see any serious complications related to this procedure. There are some complications in literature, like retinal hemorrhages and even paresis, but we really haven't seen any serious complications in this procedure. It is performed on the OR, and the patient usually leaves the clinic after 2 hours. To conclude, endoscopic management of lumbar extrusion through transsacral approach is a safe, successful, minimally invasive procedure to treat lumbar extrusions. Thank you very much. Well, to end with our University of Buenos Aires. Thank you.
Amazing talk by you, really amazing talk by you. We are so grateful to have you presenting this. This is a totally different world. And yeah, you can stop your presentation. You can exit your presentation now, ma'am. Please.
Yeah. Okay. I will.
Yeah, you please try, Dr. Tunch. We are waiting for you to start. And
I will try again.
Yeah, please. Dr. Marisa, a wonderful presentation by you on sacral endoscopy. You have opened our eyes to a totally different world.
In the meantime, I will ask a question to Dr. Marisa. What is the most proximal level you could achieve to navigate the epidural catheter and the scope to?
Dr. Marisa, the question is, how high have you gone? Have you gone to T12? Have you gone to D11? Have you gone to L1? From the sacrum, how high have you gone with your epidural scope? Are you with us, Dr. Marisa? Dr. Marisa has muted herself. Can she hear me? Dr. Marisa, we have a question for you.
Okay. Yes, okay.
Dr. Anand.
Yeah, my question is, how high have you achieved to reach? Like D12, L1 or L1, L2?
Usually we reach L3 level, not more than that.
Okay.
To work comfortably. You can always force the procedure, but when you get to the higher levels, you can really not work. You cannot give direction to the epidural cup with comfort, really.
All right, all right. Thank you very much. And it was a very skillful job which you demonstrated.
Thank you very much.
We are waiting for Dr. Tunch to sort out his presentation. He's being guided by our technical person right now.
Technology is our blessing and our curse.
Yes, I agree with you, Dan. We are old school and we're seeing a changing world with technology.
Yeah, totally.
But the old school is going ahead with endoscopy.
Yes. I don't know what our kids will go ahead with.
Gold become more gold now.
Yes.
Hi, Dan. Nice to see you after a long time.
Yeah.
I know, it's been quite a while.
Saturday evening, so you must be.
No, it's morning there, I suppose.
Yeah.
Yeah, it's 7 in the morning, something like that.
So it must be a coffee mug and not a beer mug.
Completely coffee, yeah.
That's what I've been having all day now.
Yeah.
We've had a marathon time.
Yeah, I was up at, I don't know, 2, 3 a.m. Watching the lectures. So
Some of the lectures have been amazing, amazing, amazing. And you're learning so much. And sharing is learning. I believe that we should, maybe try and make this a biannual event rather than an annual event. We will take a poll on that from our panelists and from our attendees. And I don't know whether we can share more information, because frankly speaking, it's been a learning curve today. It's been a learning curve. Many beautiful small points, many beautiful small nuances about various surgeries that have been explained by each one of the panelists in a very beautiful way. So it's been a absolutely exciting day as far as I'm concerned. And I'm sure any spine enthusiast will really love the spectrum that we have covered today. We have covered the spectrum of almost every possible procedure in the spine. Cervical, lumbar, thoracic, degenerative, stenosis, disc herniations, sacral epiduroscopy. What Marisa just showed us was amazing, wonderful. And, there was a rain check by Dr. Adam when he spoke about failed back surgeries. So it's been a wonderful time actually today.
Okay, thank you all. How about shift to next speaker? Till Professor Tunch.
Yeah, we are giving Dr. Tunch some time because he has to practice a screen share, and once he starts that, it will interrupt the next speaker. So we are giving him some time,
Okay.
guy, and in the meanwhile, we are spending some time because we have some 5-10 minutes.
Okay, thank you.
Each one of you. We've been seeing each other after a long time.
it seems like your command of getting the organizational stuff is getting better to also, like sending out multiple emails, backup telephone numbers, all that kind of stuff.
Dan, we're trying to, last year we didn't have so many speakers, and this year we have had 54 speakers. And maybe next year it may even cross 70 or 80 speakers, because we want to welcome young blood. We want to welcome everyone who's in spine endoscopy and give them a platform to speak on. The world is a stage, and I guess everyone has a right to be an actor on it. And with that concept in mind, we are a very open foundation. And I'm very grateful to Dr. Sameh because he has held my hand and guided me through like a brother should. So that's how we have been able to reach these pinnacles and these heights, getting about 54 people to speak in 2 days continuously without a single break. That itself has been a challenge. I understand it's been a very taxing schedule, but there was just no other way. Managing different time zones right from America to Japan, so 2 different ends of the world, and getting all the speakers on time. So I'm really grateful to all the panelists. Believe me, you all have gone out of your way to deliver a beautiful talk, each one of you. So I really have no words to express my gratitude to all of you. But like I feel that this platform is growing and hopefully it will grow better. Dr. Tunch, are you with us? Is your problem solved?
Not yet, Malcolm, because brain surgery is more easy.
Now that is a hit to every neurosurgeon in the world.
I can't. Believe me, brain surgery is more easy.
Yeah, we'll give
There's a technical problem on my computer. I don't want to make you wait. If you want, I will try to make a video of my presentation, and if you have time, you will show it tomorrow.
Yeah, no problem.
Better. I don't want to make lost time of every people.
We'll get back to you after half an hour. You try again. In the meanwhile, I'll request our next speaker, Dr. Bhupesh Patel, who is the director of Endoscopic Spine Foundation India, He's our young blood. He's our next to be chairman, announced for the year 22-23. And I invite Dr. Bhupesh, an excellent and a competent endoscopic spine surgeon trained in India by the best and trained abroad in Korea also by the best. Dr. Bhupesh Patel, the stage is yours. Please share your screen, sir.
Good evening, good morning, good afternoon, everyone. So today our topic is pathology-oriented approach in spine endoscopy. So we have a different kind of endoscopic technique. We have transforaminal, we have sacral epiduroscopic, we have interlaminar, we have UBE, and etc. etc. So how to choose the particular technique for particular pathology? So we will discuss today in detail in our this talk. To begin with, how we start our spine practice and establish ourselves as an endoscopic spine surgeon. This is a tremendous job. So once you are in the market or once you are in your town, so you have to establish yourselves as an endospine surgeon because there's lots of competition surrounding you, lots of senior, lots of colleague, lots of junior surgeon are coming out. So how you compete? So you have to have thorough knowledge of your technique, especially endoscopic spine surgery. First, any patient came to you, you have to have detailed anatomical orientation of your pathology like L4-5 disc, L4-5 stenosis or instability. You have to correlate everything with MRI, CT scan, and X-ray and patient's complaint. If there is other instability or calcification is there or not. You have to select the best possible approach for your particular patient. And more importantly, you have proper optics and instrument. If you don't have proper optics, then you may discourage with your technique and you opt some other, you try and error different technique. So your optics and instruments are up to the mark. Most important, the resistance among senior fraternity. The senior fraternity in our town they are used to with all the kind of open surgery. So you have to develop the trust among the fraternity that you are a good endoscopic spine surgeon. So even your patient goes to them, they can refer back to you that this guy can do good endoscopic surgery. And you have your high level of motivation for yourselves that you can do. Even many times you got failed initially 4-5 case or 10-100 case, you may to do the open surgery, you have to convert to the open surgery. But again, you have to climb up slowly and give your highest level of best endoscopic spine surgeon. So for me particular, how I select my patient for particular technique, I do transforaminal, I do interlaminars, means stenoscopic endoscopy, I do UBE, I do endofusion or MIS TLIF, but I choose each and every approach for my patient. For me, transforaminal and its modification. I don't only just talking about traditional transforaminal approach. I also talk about modification for migrated herniation, foraminal extraforaminal herniation. So it's best suited for me from disc L4-5 to till D12-L1. I'm not very comfortable with transforaminal endoscopy in L5-S1 disc. So I choose for L5-S1 interminor approach because here you just need to split 5 mm ligamentum flavum. You can directly enter inside the epidural space on the axilla or shoulder of S1 root, and you can easily remove the disc without damaging natural structure. UBE I reserved for lateral recess stenosis or central canal stenosis. Again, transforaminal best is suited for foraminal and extraforaminal stenosis because the herniation is just ahead of your, it's on the way to your approach. So transforaminal for foraminal extraforaminal is very good. MIS TLIF for endofusion for symptomatic instability. Cervical disc herniation, if it's central paracentral, anterior cervical is best approach because you can, here again, you can do minimal damage to the natural tissue and you can easily remove the disc and it can done under local anesthesia. For foraminal disc, posterior approach, either uniportal or biportal is best for according which is your mastery. Again, foraminal disc posterior approach, I rather choose uniportal approach because again, uniportal you have to go directly drill the facet, part of the facet and lamina, and without without making two port or without damaging any muscular tissue, you can easily remove the foraminal disc. But yes, stenosis, cervical or lumbar, posterior cervical stenosis with myelopathy, I prefer biportal endoscopy. For thoracic, below D7 to D12-11 transforaminal modification with reaming of rib head and pedicle or superior facet is very good approach. Stenosis, of course, for thoracic stenosis, I rather choose biportal endoscopy rather than uniportal endoscopy because it gives more freedom. And here you have good chance because thoracic, most of the thoracic are ossified, phlegm ossified at that time, because uniportal approach it's very difficult to separate. But if you have two hands, you can rather operative freedom mobility or operative mobility, you have more mobility. So you can, UB is more easier than uniportal endoscopy. Again, just introduction, how different approach, extraforaminal disc. Extraforaminal approach is far lateral disc. To sum up, transforaminal approach, we can deal foraminal, superior migrated, inferior migrated, paracentral, central disc. And alpha S1 disc, we can do interlaminar approach. These are the herniation we can deal with transforaminal endoscopy. So we have to, in the basic about transforaminal endoscopy, we have to tackle we need to decompress the two route, exiting route or traversing route. If disc is far lateral, foraminal or superior migrate, we have to decompress and target the exiting route. If disc is paracentral, central or inferior migrated, you have to target the traversing route. You need to decompress the traversing route. For a transforaminal endoscopy, you need to know everything about intervertebral foramen because it is the most important structure for any successful transforaminal endoscopic surgery. You must know the boundary of cambium triangles and which is the safe zone for the landing, your cannula landing and needle landing, medial pedicular line, posterior vertebral line. And the modification, if you are beginner, so inside out is better because you go inside the disc, get oriented yourself and remove the herniation according to location. You may go to epidural afterward once you land inside the disc. Outside in approach is more mature approach. Here you directly land in epidural space according to the location of herniation, and it is easy to remove the disc, but lots of bleeding and you may damage the neural tissue. So once you are very well versed with a transforaminal endoscopy, you go for outside in approach. According to location of herniation, you need to change the direction. You need to start needle entry from above downward with down migrated disc, below upward for up migrated disc. Different location of herniation, you have to choose the direction of the cannula. The most important part of transforaminal is the least invasive. Patient can discharge within 3 to 4 hours after surgery. It's done under local anesthesia. So patient is awake neuromonitoring. And now I have started doing under sensory epidural anesthesia. Here and unilateral sensory epidural anesthesia. Our anesthetist is a pain physician. So he can inject under CM, he can confirm exact the location of catheter. And exactly we just numb the part of the pathological part of the disc. Suppose we have to go, if we are doing L4-5 disc, then he land in L3-4 and direct the catheter downwards and just numb the L4-5 segment only. This is one example. You can see there is a L4-5 huge central and paracentral disc herniation. No calcification. Yes, transforaminal, if there is any calcification, so you have to modify your approach. Either you can do interlaminar or you can do UBE, because calcification is very difficult to remove with the transforaminal unless you have each and every equipment, and there is chances of nerve injury high. No instability on X-ray. Iliac crest is not coming in the way. You can see the huge disc. How you target the fragment? You have to mark on MR, preoperative MRI. You have to mark from midline to the posterior skin surface and one line just below grazing the facet to the lateral extent. And you can measure the distance, how far you need to go, preoperatively only. So you can target the fragment very well. Needle is a medial pedicular line, posterior vertebral line. I choose to prefer half and half. I just anchored my cannula inside the disc and remove the fragment from epidural space only. So one example, you can see we stained the disc fragment with indigo carmine dye. Initial days when you are not very much used to with the herniated fragment or anatomy is not that clear, you may use the indigo carmine to get more clear anatomy. Once you are very used to it, day-to-day practice, if you are doing routine surgery, then you target the disc without staining the fragment. You can see the annular tear. annular defect here. Now we just little dig out the annular tear and we remove the fragment. And you have to compare the pre-operative MRI with intraoperative fragment removal. If you compare the fragment removal during the intraoperative surgery, then you can say whether you are not missing any fragment or any missed fragment, you are inside the epidural space or incomplete surgery. So you have to compare during the surgery whether my post-operative fragment will match with the pre-operative MRI. You can see good decompression. Now extraforaminal approach. Here you go more steeper angle than traditional transforaminal approach because our herniation is more steeper than paracentral or central herniation. Here we target the exiting nerve root. We need to decompress the exiting root. Here is the axilla, the dura and exiting nerve root. The disc is somewhere lying here or in that area if it is extraforaminal. You see it again, 69-year-old male, low back pain with right leg pain. You can see there is a cyst with herniation in the foraminal area. It's not calcified, no instability. We choose an extraforaminal approach for that herniation. So this is exiting nerve root and traversing nerve root. You can see the cyst is burst out. The fresh gush of fluid stained blood. Finally, with radio frequency probe, radio frequency, we need to coagulate the cyst cavity. You can see post-op MRI. There is complete removal of cyst. Now, interlaminar approach. We have to segregate our approach. That the above two case was L4-5. So for me, transforaminal is very good. But again, I came to when it comes to L5-S1, I'm not happy with interlaminar transforaminal approach because sometimes iliac crest comes in the way. Larger L5-S1 facet, so you invariably end up in the center, more anterior. So that sometimes target is not that good. And here is 34-year-old gentleman with severe low back pain, bilateral leg pain. Right is more than left, with right partial foot drop since 2 weeks, bladder bowel involvement, now unable to walk more than 2 minutes, unable to stand more than 20 seconds. You can see the disc, huge L5-S1 disc herniation, up and down, everywhere disc is migrated. So in this case, I am not comfortable with the transforaminal approach because when you go transforaminal, you will not able to remove everything, and you may not confirm completely whether you have removed everything or not. I have removed separate 4 or 5 fragments for this particular patient. You can see just 3 to 4 mm flaval window and you can remove the disc. This is the first fragment. This is the second one. And I use for alpha S1 routine transforaminal endoscope only. This is a superior migrated fragment. This is the final picture. You can see the huge fragment under epidural analgesia. Post-op MRI of same patient is just 4 to 5 mm flaval window, and we can remove entire disc herniated fragment, which is very huge. Now biportal endoscopy. Here you can see the 64-year-old lady with severe right leg pain since 2 months, unable to walk more than 5 minutes, unable to stand more than 2 minutes, not able to sleep due to pain. So you have, again, this is not a very good symptoms, because it's not able to sleep due to pain. No, walking time is less than 5 minutes, standing time is less than 2 minutes. So you have to search pathology thoroughly. Bilateral lower limb numbness. So these are two: radicular pain plus stenotic symptom. Here you can see MRI of same patient. These two different pathology if you find. L4-5 severe lumbar canal stenosis with little degenerative scoliosis, but fairly stable. And patient has severe stenosis and alpha S1 extraforaminal disc herniation. You can see here. So how you can tackle? So we have we need to combine two different approach. Either you go a UBE para or for alpha S1, or UBE and L45 or UBE or interlaminar. So I choose different. I choose transforaminal approach for alpha S1 disc. Here it is extraforaminal disc, and you need not to go more flat trajectory. You can go vertical trajectory for extraforaminal approach. And L45 I choose UBE. This is a UBE for L45. Contralateral, ipsilateral. You can see the UBE port and transforaminal port. I do UBE and transforaminal both under epidural analgesia. So immediately post-op, you can confirm the limb movement of the patient, and whether you have not damage. Intra-op, you can also monitor the nerve injury. So what are the modification of this different kind of endoscopic approach? First, you need to transpericular approach for highly down migrated disc, suprapericular approach for moderately down migrated disc, transiliac approach for alpha S1 disc, whether when your interlaminar approach is not suitable, laminotomy, interlaminar approach. Here, when the disc down migrated or highly up migrated, you just do the only laminotomy and target the, just go lateral to the root and lateral to the dural sleeve, and you remove the disc, and paraspinal for UBE and interlaminar. So what are the carry home message or taking point concluding? Steep learning curve, consistency is more important. If you fail, you have to improvise yourself every next surgery, and always listen to your master. Learn from their experiences, which will shorten your curve. This is the most important statement. So whoever are stalwart of endoscopy, whatever they are saying. So I think I have heard Dr. Malcolm, and since morning we are listening the different kind of lecture from different fraternity and faculty. They are saying something new every time. They are saying don't do this. So they have failed 4 or 5 times and they improvise themselves. So always listen to them and take every improvement message from them. Never give up. All the best. So nowadays for me, endoscopic spine surgery is gold standard for all the kind of disc herniation, lumbar canal stenosis. So you have a chance to change, and then you make a choice which kind of approach you want to choose for your patient. Namaste.
Bhupesh, thank you. Wonderful as usual. Fast like a machine gun, crisp, excellent presentation. Really no words to say. I think you've left all of us short of breath. We're still breathing and trying to take in everything you said, but you covered everything so beautifully. Your choices, your understanding of your choices, that is exemplary. That comes when you have done enough number of cases, and that is the mark of an true endoscopist. So God bless you. Thank you. It's my privilege to be with you. And now I request Dan to start from Minnesota. Welcome, Dan. Please share your screen and start your talk. We are really waiting for you with a bated breath.
Okay, here we go. So what I thought would be important for me is to, let me reduce this.
Play, press the play button, Dan.
Yeah, I just have to get to it. There we go. All right, there we are. Was to try to help other people get over some of the learning curve stuff. And for me, you guys were instrumental in helping me get over my learning curve and really get a lot better and comfortable doing transforaminal surgery. So I must thank you all for doing that, my Indian friends. But as we all know, it's always a learning curve, and it's you learn from different sources and techniques and things of that sort. But the things that I've done recently is participated in trying to teach other people transforaminal surgery and interlaminar and those types of things. And it made me have a flashback to some of the things that that I've gone through in the past. So I think that a lot of the people that are participating in this course this weekend are pretty advanced, but some people out there are going to be younger and might hit some of these roadblocks. So I thought I'd put together some of the guidelines that would be helpful. So some of the rules are, number one, prevent bleeding, because if you can prevent it, it's a lot better than having to deal with it once that does occur. And what are the pitfalls and these roadblocks that we encounter as we're learning to prevent the case from moving forward? Because you can't just sit there and not do something. You have to keep the case moving forward. And I've learned from different people how to do that. So I wanted to try and share that. Some other things that happen, I know, with younger surgeons is they get lost. They don't know where they are in this three-dimensional sphere of the spine. And one thing to rely on is bone, because it's always constant. Some of the other things, looking out for the nerves and epidural fat, and also initial needle placement, which is another thing that was improved with my traveling to India. So this is a patient that I operated on recently, and there are some different ways that people teach needle placement, and it gets pretty confusing if, in all honesty, when I listen to some other people teach it. But basically, it's just getting a true AP and a true lateral and lining up with the caudal end plate of the disc space that you're working on. The image on the left, far left that is two different lines on the AP, and that was just based upon the angulation of trying to line up the end plate. And I found that what I did was, to confirm the appropriate level, is go to obtain a lateral with a true lateral along the end plate. And the difference was quite striking, to the point where I said, you know, these lines are not lining up. The AP and the lateral line should match pretty close. In this case, I was approximately a centimeter or so off. So I knew that the upper line was not the appropriate line. The upper line would be the one on the left. The other thing was, where do you start your needle placement? It seems like Americans tend to be quite a bit bigger than Indians and some of the Asian people, but generally at least 2 to 3 centimeters more medial from the lateral line where the AP and the lateral intersect. That's been pretty reliable for transforaminal approaches, so I don't get stuck in an inside out type of position. Let's see. Okay, some other things are avoiding exiting nerve root injury. So after I place a guide wire in the needle and start to insert my dilator, if the dilator is not advancing into the foramen, then I think that the endoscopic surgeon should just stop and either use a drill or trephine the supraarticular process to actually obtain all the space of Campen's triangle that you can obtain, because it seems that the degenerative foramen seems to have quite a bit of overgrowth of the supraarticular process and the facet arthropathy, and it ends up pushing your dilator and subsequently your sheath and then your scope farther anterior, and you end up in this inside out type of approach, which A is technically challenging at best, and two would be it's very frustrating to have to work in that setting. So it's better to just fix it and remove part of the supraarticular process and do a foraminotomy. And some people like to use trephines and other people like to drill. I'm more of a drilling type of person. I like to see what's going on, and I think it's a fairly easy technique to perform once you're used to doing it. The other thing is that it allows you to treat multiple things. You can treat foraminal stenosis, posterior lateral recess stenosis, ligamentum flavum hypertrophy, and things of that sort. As Bhupesh mentioned, you can't use the same technique to treat everything, but you can use it to treat quite a few things. This is a patient that ended up being an excellent teaching candidate, in that everything that this guy had going on seemed to be present and was approachable through the foramen. So in this case, he has left-sided L3-4 lateral recess stenosis. There's a suggestion that he's got a disc herniation along the lateral recess, and then he also has foraminal stenosis. So some of the stuff that I have encountered with teaching people is once they put the scope in, they freeze and they don't know what to do. And you know, of course, you have to remove some of these soft tissue obstacles. So the initial thing that is seen is, of course, when you put your scope in, there's just a little bit of soft tissue and that needs to get removed. And there's different types of things that somebody who's learning, and also what we automatically use to identify where we're at. And it's, of course, fluoroscopic imaging and x-rays. The fact that the sheath is angled, and we can use that to help determine our location. The bipolar electrocautery is typically curved, and we can use that as a directional tool. Also, identifying soft tissue planes is one of the most important thing to help us discern where the neurologic structures are and what needs to be removed. Bone is pretty well constant, so that we can use that. And then once we're moving forward, then we can start to remove the ligamentum flavum and the disc material and fat, other things that are obscuring our ability to see things. So when I start to perform a foraminotomy, the first thing I like to do is remove some of the tissue overlying the bone, and that seems to be fairly standard. Occasionally there is encountered a little artery or a vein that's overlying the bone, so it's better to control that before it starts to bleed anyhow. So that's one thing. Identifying the tip of the supraarticular process is probably the second, and starting to resect and grind down on the SAP from the tip moving down to the pedicle. And there's different techniques you can use, but generally I like to use the drill and the scope as kind of like a fixed unit where my right and left hand are staying in the same plane, because you don't want to bend the shaft of the drill, for one thing, but it tends to be much more fluid. And then you get to the point where you can see from lateral to medial, you've resected the lateral recess, and now you can see the ligamentum flavum along the lateral recess. You can always take an x-ray to confirm the level you're at, but this is a pretty standard view at that point. From this standpoint, then, if somebody didn't know what they're going to do, There's numerous tools we can use. Obviously, an articulating curette is extremely helpful because of its bluntness and your ability to dissect between the soft tissue planes and also between the bone and the ligamentum flavum, but also angled cutter and the bipolar and graspers and up cup style graspers are also quite helpful. In this case, I like to separate the ligamentum flavum from the bone because my goal here is to get the ligamentum flavum out. So I want to reduce the number of attachments to get that out. Some of the things I found that I observe other people do is they just start grabbing with a grasper, and that tends to be one of the not necessarily dangerous things to do, but in the wrong hands, it could be definitely not the safest thing to do because I find that people pass point, meaning that as they're grabbing for the ligamentum flavum, they not only grab what's visible and visualize, but they go past that and grab stuff on the other side. Generally speaking, you lose some style points from that, but this is fairly decent in regards to the decompression. But when I was watching let me see if I can fast forward through this. I didn't find that there was full adequate pulsatile flow on this gentleman's dura after I decompressed it. So I thought that there's probably something anterior, which we'll see in just a moment. So the next step in this is identifying where is the disc space. And this is tended to be pretty reliable if I identify the end plate above, or the cephalad end plate and the caudal end plate. So for me, I like to use a bipolar. It tends to reduce the wear and tear on my angled cutter and some of the tools that I'm using, but it also prevents bleeding and controls hemostasis during this time frame, which then allows me to identify the caudal and the cephalad end plate. And I don't have a pointer on my screen, but the bipolar tip is contacting the caudal portion. The next step is to then get into the disc space. And typically I like to use an angled cutter to cut through the side of the annulus. And of course, this is, unfortunately, I tend to run in this more than what apparently you guys, but I tend to run into more degenerative conditions where it isn't just a big, huge, loose fragment that you can pull out, which whenever I get those, I say to myself, it's just like what the Indian guys get. But instead, I like to cut the annulus from cephalad to caudal and then start to enter with my cutter tip angled approximately 45 degrees. So I'm sliding in along the end plates, because then what I'm really trying to do is get underneath the common dural tube and the traversing nerve root to get to where I need to go. And then subsequently proceeding anterior to the traversing nerve root and the common dural tube is removing some of this thickened degenerative posterior longitudinal ligament and some of the other disc material, but using the forceps and straight and angled graspers as somewhat of a dissector to dissect the tissue plane between this material and the nerve root, and then subsequently the common dural tube. I'll use cautery to some degree, but I try to avoid that in use around the nerves, but sometimes it's necessary. And in this guy's case, he had, oops, hold on one second. He had a large fragment of loose disc material that was located right underneath the dura. And that was it right there. So it's kind of surprising that sometimes the person's pathology is not only foraminal stenosis and the lateral recess stenosis, but they actually have a trifecta of problems going on with bulging disc material, a disc herniation, and things of that sort. And I feel like that type of stuff would have gotten missed probably through an open or even a tubular-based MIS approach. one of the things that unfortunately happens is bleeding. And sometimes it can be kind of a benign type of bleeding, like in this video, and other times it can really be horrible. But I've tried to get all my patients to stop all their anticoagulants at least 7 days prior to surgery. Some of the newer medications like Eliquis supposedly can be stopped, within 2 to 4 days, but I don't trust that. I think that they really should be discontinued a week prior. There is high frequency bipolar electrocardiogram on the market. It seems as though there might be a lower frequency that could be associated with more risk to nerve injury because of the heat spread. Other things I've tried to teach is that rotating the sheath that you're working in can also be used to shield the bleeding so that you can continue to move forward. I like to occasionally I'll increase my pressure incrementally by 10 millimeters hemoglobin at a time until I can attain hemostasis, and then identify the vessel or where the bleeding's coming from and then manage it. Sometimes you have to remove the scope and insert the dilator and wait a few minutes. And only once, and unfortunately that was recently, I've had to inject some hemostatic sealant to control the bleeding. And in the individual that did that, it's my fault, but I should have inquired more about whether or not that individual had stopped their anticoagulant medications a long enough period of time ahead prior to the surgery, and they hadn't. So another option is returning on another day to finish, and that shouldn't happen too often, but it's always an option. It's better to return on a different day than to continue in a setting of not being able to see what you're doing. So in conclusion, there's several keys to success, but of course, we all have a certain set of abilities, and every patient has a technical complexity that they bring to us. And identifying these types of things I guess that's part of the learning curve that we all approach, but as we get better, we can definitely tackle more problems. Other endoscopic surgeons should always be in our back pocket and be available to help, whether it's digitally or by the phone or just running something by somebody. It's always helpful to do that. And watching what other surgeons do, because we all are troubleshooters. We're kind of like mechanics and we work on different types of things, but we have all a lot of pearls to teach. And some of the stuff that I've learned from people that are just learning has been crucial and incremental, and to me progressing forward to be a better endoscopic surgeon. So thank you.
Thank you, Dan. On behalf of myself, Anand, and I think Rupesh, we three rats miss you. It was nice having you in India way back in, I think, 2018. We had a great time. We had a great time then. And the world has moved on so much after that. It's been a pleasure having you. And now I request our next speaker, Dr. PC Day. Have you joined us, sir? Has Dr. PC Day joined us? Then can we move to Dr. Carlo? Dr. Carlo, are you there with us?
Yeah, I'm right here. Thank you.
Dr. Carlo, can you please start your presentation?
Just a second, please. Do you see the presentation? Can you see the presentation? Okay.
We can see you and we can hear you very well, sir. Welcome.
Good afternoon, everybody. So it is my pleasure to be here with you today. I thank organizing committee for having me here. So in the next 50 minutes or so, I'm going to speak about transforaminal endoscopic discectomy for thoracic disc herniations. Excuse my coughing. So this lecture is not financed, obviously, by any company, and all relevant information is based on personal experience and evidence-based medicine. Let me just say briefly about myself. I come from a private hospital called Axis, which is located in Zagreb, which is capital of Croatia. We're a small private hospital. We do roughly 500 surgeries per year, and most of them are minimally invasive. In order to present surgical technique of endoscopic transforaminal discectomy, I'm going to give you first the illustrative case. So this was 25 years old female patient. She had a 2 years history of moderate mid-thoracic pain, and then more than several months of history of severe thoracic pain. Conservative treatment was unsuccessful. She had no neurological deficit, and MRI, as you will see, showed 2 disc herniations at TH6 and TH8-9 level. In here, you see the preoperative MRI scans, so sagittal and axial, showing big disc herniations, which we addressed transforaminally endoscopically. First of all, I want to say that all our patients are operated in prone position, in local anesthesia with sedation, obviously, which is same with which most of you use in your daily practice. So we use a local anesthetic, 1% lidocaine. We put the spinal needle and try to anesthetize all the anatomical structures in our way. The end of the needle is in a med-ped line in AP view, and it should be just at the entrance of the disc in a lateral view, as I've seen most of you use. So if you go further, like in this case, then be sure to be in the disc and not in the spinal canal. After we anesthetize so the fascia, the muscles, and the facet joints, we give some also anesthetic into the disc. After that, we perform discography. For discography, we use iodine contrast material, but we also use indigo carmine, which I've seen most of you also use in order to stain the disc blue. I would stress that this is maybe most important for beginners to see the difference between the disc and other soft tissue, and it's really important if you're doing reoperation endoscopic surgery. Since, in my opinion, you cannot establish working channel or your trajectory only with the spinal needle, you need to use a Tomshiri needle, which is a stronger metal instrument that we use for establishing trajectory. In order to establish correct trajectory, you need to go through the bone. So you need to go through SAP, or you need to go through the head of the rib, and that's why we use Tomshiri. The final position of Tomshiri would be similar or same as with spinal needle, which means in AP view you should be not too medial from med-ped line, and then in lateral view you should be just at the entrance of the disc. Tomshiri needle has 2 parts, so here you see the sharp part of Tomshiri needle. However, if you need to be more, for some reason, medial, you can switch to a blunt tip Tomshiri needle in order to avoid the dangerous consequences of piercing the spinal cord. After that, we put the guide wire, and then we use a series of hand reamers for actually making our trajectory. In here, you see Maxmore. This is a company that we use reamers. They have a blunt tip, and then they have the sharp part right here, starting right here. So if you're gentle and if you have a awake patient with the real-time feedback, there is no need to be stressed, because patient will alert you at the time if your instrument goes where it's not supposed to be. So even if you are a beginner and maybe have a wrong trajectory, if you advance instrument slowly, you will push the nerve, or in thoracic spine, you will push the dural sac with the spinal cord, but not pierce it, okay? We start from number 4 and then go all through number of sequentially 5, 6, and end up most of the time with number 8, or rarely we need number 9 or 10. See, but all of them are designed equally, that they have blunt tip and then the sharp part starts right here. Once we are happy with our trajectory, we introduced a working channel over the muscle dilatator, and there we go. We can put our endoscope. Now, I see some of you put endoscope or working channel into the disc, and I've heard what colleagues earlier said. I don't really, in my opinion, so we can discuss it, I don't think there is ever need to use inside-out technique, which is, I think, more aggressive and not necessary. I never use enter the disc with the endoscope or the working channel. So basically, I always use outside-in technique and go into the disc only as needed. So I want to be as less possible in the disc in order to leave the disc as much possible in place as it is, and take only those fragments that are extruding outside of the disc. In here, I also want to say that and show that even though we are in a MedPed line with the endoscope, if we know the anatomy, the bone anatomy, and the posterior structure of thoracic vertebra, we can easily access midline or even access opposite side of the disc. So sometimes I got questions asked if this is a good approach for mid positioning pathology, but my answer is definitely yes. So after we introduce the scope, this short movie is gonna just present similar like others. You will see the soft tissue first. You can coagulate it. Excuse me. Then you will see the bone. So the bone you can take with carry surrounders, or you can drill it. I have both, so you will see that in a second. You would actually want to see your pathology well. Now here is the secting tool. You see how this is a disc herniation, and above obviously is dural sec with a spinal cord. In here you see the disc level, and this is the end plate. Since this is a thoracic spine, you cannot manipulate much with the dissecting tool, and especially if the disc herniation is calcified. First, you need to make a small bed beneath the disc herniation so you can take it easily out. And that's what we do with see the electric drill. This is tip control, so I can control the angle of the drilling and prepare myself in order not to manipulate much with the dural set. After that, we take the disc out, and most of the time, if we use indigo carmine, the disc is blue. However, if we have a free fragment, or if we don't use indigo carmine, then we see this clear blue, clear white fragment of the disc. As you know, and as most of you are aware, the end of the surgery is when I see pulsations like we see here of the neurological structures. And then the second thing is I want to compare the part of the disc that I've taken out to one that I've seen on the MRI scans. So you see this is the ventral epidural space. I'm sorry, the ventral epidural space. This is the drilled bed beneath the medulla, the spinal cord, and this is the place where the disc herniation was placed. This is PLL, posterior longitudinal ligament. And basically, at this stage, I just do my hemostasis. I just do the coagulation, and I definitely finish surgery right here. I don't take this part of the disc that is still in a disc space, because I think it's not necessary if I see clearly the decompression of the dural sac and the spinal cord. Excuse me. And this is post-operative MRI, so definitely you can see that both discs are totally removed, and the beauty of this technique is that you don't have any scar tissue in the muscles of posterior elements. You see the trajectory that we've came through. There is some scar tissue, but what is important that we didn't have to drill a pedicle, we didn't have to drill or remove the rib. So basically, this is purely minimally invasive technique. Recently, my colleagues and I, we published 2 articles about this. First article was a case report that we had a long follow-up of 5 years for 2 large calcified thoracic disc herniations. And the second article was 5-year outcome after endoscopic transforaminal foraminotomy and discectomy, both for soft and calcified disc herniations. So for those who are interested, just to go briefly over it, we had 16 patients. If you address thoracic disc herniations, you know that most of them are calcified, which was also the case in our case series. These are preoperative and postoperative VAS scores in different follow-up periods. And you can see significant decrease both of VAS score, but also on ODI scores, which compared nicely to the VAS. And what is important, once that patient had a postoperative drop of ODI score and VAS, it remained low, which means that even after 12 months or 24 months, the patient got well. Both papers are publicly available, so they're free of charge for those who are interested. And obviously, we didn't have maybe enough cases because these patients are not frequent with thoracic disc herniations, needing surgery and coming to our hospital. But this is our experience. At the end, I want to make a conclusion that thoracic transfemoral endoscopic discectomy is definitely a safe approach, and it is with minimal bone removal. It significantly decreases morbidity compared to other approaches, especially anterior approaches, but also other posterolateral approaches. It is mandatory, in my opinion, to use local anesthesia with sedation, so it permits us real-time feedback from the patient. I will just tell you one example. So once during surgery, the patient was obviously awake, and in part of surgery where we tried to establish trajectory, we hammered the Tomshiri needle through the bone. And at that time, patient said that he feel kind of tingling and numbness down the waist and down both legs. So we stopped the procedure for a second, and after several minutes, this numbness and tingling went away. This was obviously a mild concussion of spinal cord that we caused with hammering of the Tomshiri needle in thoracic spine. But if I didn't have a awake patient, and if I didn't stop for a second with the surgery, maybe the patient would have neurological deficit after the surgery without me knowing it, why and how I caused it. So that's why I always use local anesthetic and just sedation. Patients are most of the time discharged home the same day or at least the other day within 24-hour interval. This was a short presentation, so thank you all for having me here, and I'm glad if you have any questions to answer them. Thank you.
Excellent presentation, Dr. Carlo, and very skillful surgeries were done in your presentation. I have 2 questions for you.
Yes.
Can you tell me approximate distance from the midline, how much lateral you went in?
Okay, so if I always measure it, so I never use approximate measures. I always use axial MRI scan and then measure my way in. But if I need to say one number, that would be roughly 6 centimeters.
Okay, that's great. And in your 16 cases paper, did you encounter any issue with the dural tear after reaming the facet?
No. So we didn't have any dural tears in thoracic spine, probably because we had a small number of patients. It did happen several times during lumbar surgery, but I have a couple of hundred surgeries in lumbar spine. We didn't have any dural tears, nor did we have a neurological deficit or infection and so on. The only thing that also might be different from having surgery in thoracic spine is we don't use pump. So in thoracic spine, we bring the tank with water, let's say at maybe 2 meters above, or maybe 1.5 meters above the patient, and we let it free flow from that level. We don't use pump in order to avoid the pressure of the spinal cord.
Okay, wonderful. I once again congratulate you for a wonderful presentation. Thank you so much.
You're welcome.
Now, can I call upon Dr. P.C. Day to present his talk? Dr. Day?
Yes, I'm here.
Yeah, so you can start sharing your screen and start your presentation.
Visible? My slide is visible, and am I audible?
Yes, both.
Okay, thank you very much. So hi to everyone. My topic will be the endoscopic not clear. I don't know what is overlapping. Something is overlapping. Just give me a moment. Okay. So endoscopic decompression in the lumbar canal stenosis is a simplified approach by the Destined technique. And so come to the anatomy and the pathogenesis of the degenerative lumbar canal stenosis that everybody knows. There is the three major problems or three major things to do the canal stenosis. That is the ligamentum clavum hypertrophy and the facet joint hypertrophy, and also the sometimes associated with the disc. So all the three things, that is the facet joint hypertrophy, and this is the mostly the three major cause for the lumbar canal stenosis. What we are doing, this is the functional spinal surgery by Destined technique. We do the unilateral laminotomy and bilateral decompression. We remove the lesion without disturbing the anatomy and stability, preserving the motion and the function. The indication for the lumbar canal stenosis surgery is, I think everybody is very clear about it. There's the predominant leg pain, neurogenic claudication with or without paresis. When conservative treatment is exhausted, predominant back pain is excluded. Not contraindicated, that indicates that the foraminal stenosis, that means these are all indication for the endoscopic decompression for the Destined technique. That is foraminal stenosis, degenerative spondylolisthesis grade 1, multidirectional rotational angulation and associated stenosis, scoliosis with stenosis, prior surgery in the same segment or the adjacent level, post-radiation stenosis, multiple level stenosis, specifically 3 level, 4 level, without any fixation, without any stabilization, because we are not disturbing the stability, and the obesity, huge morbid obesity, cauda equina like this. So what we do the laminotomy, trimming of the bone between the base of the spinous process and the facet, removal of the hypertrophic overhanging part of the facet, and excision of the hypertrophic ligamentum clavum. Along with the, if there will be disc herniation, then discectomy. We have very few instruments, around 10 to 11 instruments, and there is the 12-degree angulation between the operating instrument and the telescope, provides the constant visualization of the operating instrument tip to the surgeon throughout the procedure. So rare chance to injure the deep structures, specifically the nerve root or any neural structures. So this is the instrument that is called the localizing device. There is a two knobs. They're putting in the both the side of the spinous process, and we have this two sides of the two side bars, and that is the we put in the C arm, and then the lateral condition. That is the we in this procedure, in this device, we do not take the AP view. Only the lateral view is enough. The two side bars gives the idea about the localizing the disc space, and the two knobs giving the idea of the enteroposition or the sagittal view. So there is no need to take the AP view, only the lateral view is enough to localize. And then we are giving mark with the marker pen like this. This is the midline, and this is the proposed site of the incision, that is about 15 millimeter away from the midline, 10 to 15 millimeter away from the midline. And if you are using the thumb to palpate the spinous process, then maybe 10 millimeter from the spinous process. But the spinous process is bulbous, so if you take the center, then it is about 15 millimeter away. The incision is about 16 to 18 millimeter long, and it is the same for the stenosis, where to address the bilateral nerve root. So what we are doing, maybe sometime L4, L5 and L5S1, we are operating through the same port, just tilting a little bit of the whole set of instrument to cranial, L4, L5, then caudal, L5S1. Sometime 3 level, then one separate port for 3-4 or 4-5-5S1 used to operate from the single port, if it may be stenosis or maybe disc. And the press feed technique, there is no special device to fix the instruments. Both the hand of the surgeons are free, left hand for the suction tip and right hand for the operating instrument like disc forceps or Kerrison punch. The instrument is called mobile operating tip because it can be mobilized in all directions like cranial, caudal, midline and lateral with the help of the left hand the suction tip or right hand with the instrument of the operating instrument or both in the coordinated way. Here we can see how we are mobilizing the said instruments left, right, medial, lateral and operating tilting 25 degree to 30 degree and tilting and below the spinous process over the top, going to the opposite side and decompressing, sometimes the discectomy of the opposite side also. We are operating 4-5-5S1 from the single port. Here you can see from the single port, keeping the bony bridge intact. We are approaching from the right side here. This is the north root of the same side, L4, L5. And then this is the opposite side north root. And this is the bony bridge and this is the L5S1. So both the level can be operated from the single port. Here is the multiple level, the disc, the 5 level disc. So 1, 2, 2, 3, 3, 4, 4, 5, 5S1. This is the left side and these 3 are the right side approach. So the endospine is an elliptical instrument like this, and it can sit in the elliptical way like this in the anatomy and fitting to the anatomy, not like other instruments. This is the advantage of the endospine system. So here is an example of the patient. This is the LCS with the L4, L5 disc herniation, and this is the axial view. This is the bilateral involvement, bilateral radiculopathy, and this is the L4, L5 stenosis with the disc. And here is a short video. You can enjoy this video. So this is the left approach, and this is the cranial, caudal, midline, and lateral. So cranial is the left hand of the ears. I'm removing a little bit of the cranial lamina here so that the ligamentum flavum is detached. This is L4, L5. So this is the L4 lamina and L5 lamina is here. Spinous process is there midline and laterally this is the facet. I'm using the 3 millimeter Kerrison punch. This is 45 degree to remove the bone and 90 degree for the soft tissue. So only 2 Kerrison punch comes in the set. This is 3 millimeter disc forceps. I'm removing the soft tissue from the inferior lamina, that is L5 lamina here. And my pet is protecting the dura. And now this is the inferior lamina. As everybody knows, this no need to remove the much of the bone from the inferior lamina. It is attached to the in the border, the ligamentum flavum or yellow ligament. So only trimming of the bone is enough to detach the ligamentum flavum. I'm doing a flap like this. Sometimes we are using the 90 degree Kerrison punch to cut the pieces like a piecemeal. Here it is a flap. So this is left approach, L4, L5. And this is the midline. The same 45 degree Kerrison punch I am using to remove the ligamentum flavum. This is to shrink the soft tissue at the midline, and this is the overhanging facet at lateral aspect. Same 45-degree Carrison punch. This is the lateral aspect at the shoulder of the nerve root. The nerve root is now visible clearly. The cranial, I have given cranial one petty and caudary another petty, so that the nerve root will be pushed a little bit with the help of the nerve root retractor, get a good space laterally to approach the disc, and this is the discectomy. Now the disc perceived is rotated. The mouth is towards the lateral aspect. If there will be any free fragment in the lateral aspect, then irrigation with the normal saline with the refine. If there will be any free fragment, that will also come out. And then remove the cranial petty. And this is the caudal petty. I just kept it there to reduce the bleeding or stoppage of any. And then this is the petty I have given in the cranially at the midline, and then slowly going to the opposite side by removing the ligamentum flavum and also overhanging spinous process. So a little bit of the enter aspect of the spinous process, and then slowly moving caudally, and these are all thickened ligamentum flavum along with a chunk of bone from the infra aspect of the inferior lamina. Then we are going to the opposite side by undercutting of the bone, and this is the opposite side nerve root. My petty is protecting the dura, the dural sac, and this is the nerve root, and this is the disc. So this is the opposite side disc. It is a left approach. So this is a right side disc. This is a nerve root of the opposite side. This is a right side nerve root. And I'm putting a petty to protect the nerve root, that is caudally, and this is the cranial petty. So this is the disc of the opposite side. But it is very, very rare you will get the disc of both sides. So discectomy from the opposite side, complete decompression of the nerve up to the foramen, and adequate decompression at the central level. Bilateral nerve root, this is the opposite side nerve root, and this is the same side nerve root, decompressed up to the foramen. So this is the discectomy from both sides, and also the decompression of the nerve root of the both sides. So primary principle of this surgery is the same for all upon microscopic, microendoscopic or endoscopic technique. But in endoscopic technique, sufficient work done within the spinal canal and its nerve structures under excellent visual conditions. Technology evolving and indication are expanding and growing. Possible in obese, osteoporosis, multiple level, complication like dural tear, neural injury and infections are less. Complication following the dural tear less, as no dead space after the removal of the tube. Once you remove the tube, the soft tissue fall into the space. CSF leakage would be less. Rare chances of the pseudomeningocele, most of the time it heals. No fixation is required even in multiple level because we are not disturbing the anatomy, and we are just trimming the bone and removing the ligamentum flavum, which is hypertrophic, and also the trimming of the facet, which is a hypertrophic part of the facet. So no fear of the adjacent level pathology after the fixation. No more a cosmetic surgery, but indispensable. Senior most spine surgeon of young budding surgeon all prefers mesh. So people demands mesh. Now another patient of 65 years male, no medical comorbidity, general surgeon, presented with the gradual progressive bilateral neurologic claudication for 3 years. Walking distance was less than 200 meters. Standing time was less than 5 minutes. Rest relieved the pain. No bladder bowel involvement. Activity level daily activities affected because he was a surgeon by profession. On examination, diffuse tenderness of the spine, spinal range of the movement is normal, right? Sign of the nerve tension was negative, no neurological deficit, distal pulsation were normal. So this was his X-ray, and the MRI shows there's a multiple level stenosis, 3, 4, 4, 5, 5 is one. We plan to decompress all the 3 levels with the help of this endospine technique. So L4, L5 was from single port, and L3, L4 another port, 2 port, and the decompression done in 2009, and 2016 we did the MRI, and then also CT scan. So this is the 3, 4, this is 4, 5, this is 5 is 1. The single approach, all the 3 level, and unilateral approach, bilateral decompression without disturbing the midline structures. This is 3, 4, 4, 5, 5 is 1. And in 2020, we did the re-evaluation of the patient because of the knee pain. He came for the knee pain. So we re-evaluated the X-ray, MRI, and this is the status of the MRI after about, say, 11 years. Now this is the 3, 4, this is the 4, 5, and this is the 5 is 1. 3, 4, 4, 5, 5 is 1. In 2020. So this is 11 years follow-up. So he is now 77 years, professionally still active and busy, and he is doing his profession as a surgeon, mild intermittent back pain. He is doing regular exercise, going morning walk about 4 to 5 kilometers. Claudication pain sometime on long period of standing and walking, going for morning walk for 3 to 4 kilometers. Very happy. Now another patient, he undergone twice surgery, first in L4, L5, and then second time surgery 3, 4, 4, 5 fixation. And the second surgery, discharge summary shows there was the dural tear, nerve root injury. He was walking with the foot drop, bilateral foot drop, with the help of the walker. Very difficult, severe pain, cauda equina, and the burning sensation around the perineum. He was so difficult to survive until life. His life was almost pity. He asked for the surgery. He begged for the surgery. When he came to me in 2016, this is the situation. 2 level above, this is 2, 3 level that was fixed, that is 3, 4, 4, 5, and 5 is 1. Now L1, L2, and L2, L3, and L5 is 1. That was the stenosis. L1, L2, L2, L3, and L5 is 1. L1, L2, L2, L3, and L5 is 1. All the 3 level, we planned for this surgery. He was almost crying for the surgery, begged for the surgery. And as there was a previous twice surgery done, and there was a dural tear, and there was a nerve root injury, he was not able to walk, severe pain, burning sensation, cauda equina. I was a bit reluctant to operate, but he was crying for this surgery. He's a surgeon and retired CDMO from the state government of Odisha. And this is the 3 level we marked before surgery. We approached from the left side, and this was the fixed screw and the rod. So almost my localizing device approaching or hitting almost to the rod. But anyway, we managed to put or docking the instruments. It was hitting to the rods, but we can manage little bit maybe caudally. So tilted little bit caudally, and did all the 3 level surgery. Next day morning, he was able to stand and walk. The totally relieved from the pain. And he advised also his wife to get operated. She was also suffering from all the 3 levels stenosis. Instrument damage and the recurrence use of the instruments, recurrent use, all these things is very, very rare in Destined technique. I faced only once. There was in 14 or 15 years experience. I was trying to twist my this disc forceps that was broken in the disc space. Luckily, with the help of the C-arm, we located it, then cut it and removed. But it is very, very rare. Not in like other set of instrument. It is a strong, stout, robust structure instruments. Very, very rare breaks. Once purchased, it go for the 15 to 20 years. The another patient is about 70 years. We operated him just exactly September 2019. This is a multiple level stenosis 2, 3, 3, 4, 4, 5 S1. Also, there was a listhesis at L4, L5 at grade 1. but we operated L4, L5 listhesis grade 1 also, any grade 1 listhesis without fixation. We never bother about that flexion extension, then how much will be the expansion, maybe 3 millimeter, 4 millimeter, exaggerated, unstable vertebral column, all these things we never bother. We just decompress, we leave the nature, and I think most of the time we success. And that was our motto, that if there is a grade 1 listhesis, we do only the decompression, even if associated with the multiple level. This is a multiple level stenosis, 2, 3, 3, 4, 4, 5, 5 base 1. There was 4, 5 listhesis, 4 level stenosis, but we decompressed, and after 2 years is doing well without any problem. These are the all studies and the published paper on the decompression only without fixation of the spondylolisthesis gives the almost the same result. This is 71.4% and 72.9%. There is not much difference of the fixation and no fixation of the grade 1 spondylolisthesis. If you are doing only decompression versus the fusion for grade 1 degenerative spondylolisthesis, so all are the papers to support our thoughts. To summarize the endospine, 16 to 18 millimeter incision, minimal blood loss, magnified and well illuminated view, 25 minutes to 30 minutes for a level, multiple level maybe as per the need, maybe say 2 level 1 hour and 4 level 1.5 hour to 2 hours, mobile operating tube, so enables to illuminate and explore the hidden recesses, less collateral and muscle damage, less damage to the neurovascular supply to the mostly the minimal post-operative pain, rapid resumption of the physical activity, no stitch. Patients are mobilized just after the recovery from the anesthesia, maybe 3 to 4 hours, and can take bath with impermeable dressing, discharge on the same or the next day morning. Multiple level disc and stenosis could easily and comfortably dealt with the destined to endospine system and the technique. Thank you. Jai Jagannath.
Dr. Sharma, are you there?
I will be happy if there will be.
Yeah, hello.
I'll be happy if there will be any question.
So you Dr. Dev, we will take the questions in process as they come. We can proceed with Dr. Sharma's presentation.
Okay. So thank you for having me here. I hope you can see the slides.
Yes, we can. Please go ahead.
So thanks for giving me this opportunity. I will be talking about our experience and learning curve when it comes to interlaminar endoscopy. So this is for the beginners. This is for the guys who want to start. This is where I have targeted the talk. So those who are expert, they can sleep or can have a cup of coffee. But those who want to go starting in the learning phase, I think hopefully this talk will give you something. So we all know that technology is evolving and the things are getting smarter and smaller. Similarly, the spine is also evolving every day. And this is how we have evolved from an open surgery to tubular to what we are doing in endoscopy today. So this has been our learning curve. We, unlike most of the guys who tell that you start with the transfemoral because it's easy to do, we took up interlaminar first. And that was there was a reason behind it. Because we were very good with open and tubular and we had a vast experience with it. So that's why we preferred the interlaminar first. So the reason for choosing interlaminar is you have a familiar anatomy. If you have been trained in an open surgery or a tubular surgery or any other surgery before, you know the anatomy. It is a much versatile approach. You can really deal almost everything when it comes to interlaminar endoscopy. So this is how to make it. So you use the interlaminar window, which is a natural corridor to be exploited, and you follow the same steps which you follow with the open or a tubular surgery. Once you go, you find some amount of soft tissue. Either you, even when you are doing tubular, you take out the soft tissue. This is the the endoscopic view. This is the medial side, this is the cranial, this is the caudal and the lateral. Once you have taken out the soft tissue, you get the ligamentum flavum, which is the next anatomical layer. And then, as you do for any other surgery, you remove the ligamentum flavum. And the advantage of endoscopy is you can really dilate it. So the advantage is you, even with removing a very small amount of flavum, you can really work your way out. So you cut your flavum from medial to lateral, as you can see here. So this is exactly what you do if you're familiar with any other approach. And then the anatomy is again repeated. You see some covering of the epidural layers, and you remove it. And then you identify your dura. That is the next step. And like any other surgery, next step is to identify the nerve root. So you go ahead and you identify the nerve root. And that is how anatomical the interlaminar approach is. Now, depending upon the pathology, you will tackle what you want to tackle. For example, this is a 20 female with a left S1 radiculopathy. You know the disc is more on one side, on the left side. So you go ahead, you plan it, you identify the nerve root. All you have to do is to just slightly migrate the nerve root. You identify your disc, you do your discectomy, you remove the fragment which is causing the compression on the nerve root, and you make sure that your nerve root is completely free. So this is what you can see. We have just gone, and the extruded fragment we are just removing. And once you have taken out the extruded fragment, this is what you can see, just the disc fragment coming out. And then you just make sure that your nerve root is free. And that is exactly what you do when you are doing any of the surgery. So this is the nerve root at the end of the discectomy. And this is another case. Unlike the previous case, this patient has bilateral radiculopathy. And you can see the disc is more central now. So unlike the previous case, you have to go more close to the dura, because that is where that disc compression is coming. So here we choose a axillary route. And so we went between the dura and the nerve root, and we did the discectomy. So you can see the disc coming out. So that is, these are the same principles you almost follow when you are doing a tubular discectomy, or even with an open discectomy. More so if you are in tubular, you apply almost the same thing, and you use the approach which is most suitable. And this is at the end of the discectomy. You can see the dura and the root, both of them are completely free. Now, so this is another scenario. This is a big migrated disc which was causing the foot drop on the left side. So you can see the patient, she has a foot drop with significant bilateral radiculopathy, more on the left side. So again, you can go interlaminar. In this particular case, there is a compression behind the disc is behind the dura. It is superior migrated, and even it is compressing on the nerve root. So this is very important. You start with what you get. Even the small amount of disc which you remove initially will help you get more space, because you work with a very, very small space when you using endoscope. So first we approached it through the axillary approach, because we thought that was the easiest thing to do. And we removed whatever disc we could get from the axillary approach. And once we have removed some amount of disc, we knew that the nerve root will be bit free now, because it has more space. We're still working and trying to do some the discectomy through the axillary approach, and trying to decompress the disc which is just in front of the dura. And then we went to the shoulder. You can see the nerve root, and this is the shoulder disc. I'm using the probe just to identify the disc. And because by this time I have some mobility of my dura, so I can manipulate it. And then you can see the direction of my bevel. It is superior directed, because I'm now targeting the extruded fragment, which was cranially migrated. And so we went ahead, we identified the disc, and this is the disc fragment, as you can see, which is coming from the shoulder of the root, which is out here. and one disc fragment is just removed, another disc fragment is just coming up, and you can see the axillary disc has already been removed, and this is one big fragment which we just took out. So you go step by step. You don't want to straight away grab a big fragment and come out. You start with the smallest fragment which you can take out, and then gradually mobilize the root, and then aim the big fragments. So that is how the interlaminar approach is. It really allows you to do things in a way which you have already been trained. So this is a big disc fragment, as you can see, it just came out, the extruded fragment, and we're just trying to grab it. So as you know, some of the fragments are sometimes too big to be grabbed. Either you can take them piecemeal, or what you can do is you can, if it is too big to grab, you can grab it and take the whole scope out. That is, so this particular fragment was really covering the whole scope, as you can see here. So we just remove the scope so that we can really take the fragment out. And this is the outside video of what you were just looking at. So this is where we just take out the whole scope to remove that fragment, and so this is where it comes out. So even biggest of the fragment can be tackled depending upon how you want to do it. And this is at the end of the discectomy. You make sure that your dura is free, your nerve root is free, like you do with any other approach, whether it's an open approach or a tubular approach. And that is how we felt that interlaminar is a much easier approach if you have been trained previously with a tubular or a open approach. And this is the removed disc fragment from that case, and this is the post-op MRI showing that complete discectomy, and in both the views. And this is the patient's post-operatively, and this is the beauty of the surgery. Even on the same day, you can see not only that symptoms are gone, even you can see the foot drop is quite better. And by the time we discharged her, she was almost from 1, she was almost 4 plus. So, but it does have its unique challenges especially when you're starting with the endoscopy approach. Now, when you are doing an open or a tubular surgery, you are in a microscopic view. Now, from there, you have to migrate to a screen view, and it is a bit of a adjustment you need to do. Now, all the surgery that you do, either open or tubular, or when you're using matrix tube, it is like an assisted surgery. You have assistant which helps you do the surgery. But when it comes to endoscopy, you see this assistant is which is nearest to me, and he is not even looking at the screen. The guy who is looking at the screen is almost with his hands tied. So ultimately, you are the assistant and you are the surgeon. Again, this is a big difference which you need to understand, and you need to improvise and adapt to it. Another is the system itself. If you're using a tubular to do a minimal invasive surgery, it's a quite fixed system. But if you look at the system endoscope, it's a very, very mobile system, and you have to use both your one hand just to stabilize it while you work with the other hand. And even this does involve something getting used to the mobility of the system per se. The other challenges which you feel is the hemostasis. Again, the bleeding is a big worry, because sometimes or you won't see anything, it bleeds. You cannot continue with the surgery. To use the RF probe to control that bleeding, again, requires some amount of getting used to if you're converting yourself from an open or a tubular-based surgeon. And just to get the bleeder and to exactly coagulate it, and how to mobilize the RF probe. Again, that has some challenges, but it is not a big thing. Once you get used to it, you will be. But initially, it could be a challenging thing. Again, the another is nerve root neural retraction. When you are working in an open system or through a tubular system, you have assistant who will retract your nerve root. But here, you use the bevel of your tube to do it. And again, you need to understand what is the mobility of your nerve root, how much you can push it, how to do it safely. So you can see here what we are doing. We are just mobilizing the dura so that we can work on the disc safely. So dura is completely out of the picture so that you can do a safe discectomy, a disc work. So, but this again is bit of a challenge when you are migrating from a tubular system. And again, this is the end of the discectomy. You can decompression. You can see the dura is completely free. But this again has to be learned, adapted when you are coming from a tubular background. Now, what are the limitations? So their interlaminar does have its limitation. For example, if you are a beginner, and you want to do something like this, a centrally migrated L2-3, if an expert, maybe you can do it. There's no doubt people do it, but it could be a bit challenging because there's central compression. Your L2-3, the interlaminar window is pretty small. So it's not that you have to do all the cases to the same technology. You can use a different technology altogether. We did a endoscopic surgery here, but what we did, you can see what we did is instead of going interlaminar, we went through a transfemoral route. So if you think in the initial days of your learning curve, it is too much for you, you choose things as it suits you. It doesn't mean you have to do each and every case through a same technique or same technology. So this is the end of the discectomy. This is the post-operative MRI, as you can see. Similarly, this was another case. There was a superior migrated disc with a huge osteophyte. The osteophyte is almost covering the disc. So again, we thought in our book, the interlaminar, for my experience, was bit on the upper side. Maybe some of you can really do it, but we felt it is better to use a different approach. Again, we went through a transfemoral approach, and we could target that osteophyte. We could burr it because the and then we were able to do the discectomy. And again, what we did is we used the technology. We used the navigation. As you can see here, this is the navigation, and we could navigate our endoscopy burr the osteophyte all around the disc and do the discectomy in a simpler way. So in your beginning of your career, you have to adapt to your level, to your comfort level, and then do the surgery. It doesn't mean if you want to do interlaminar, you have to do all the cases in interlaminar. You can choose whatever suits you. So the comfort range and the ability to do the job is very, very individual. This is what works in my hand, and that is what you have to remember. So and then it comes to, is it worth it? We have huge experience with tubular. We have done thousands of cases. So was it worth it converting to a endoscope? I believe it is worth it. If you see this patient, the one I just showed, she walks in with a foot drop and pain, and the same day you see her walking out, walking comfortably, painless, and that is the beauty of using the endoscope. Again, this was our own case. We had done 8 years back that open discectomy. You can see the previous scar, and the previous scar from he had a 2-level disc prolapse. And when he came this time, we could do both the levels with this small incision instead of this big incision which we gave her when we last operated through the open approach. And that what drives me to convert from a tubular or an open approach to an endoscopic approach. So many people have good aim in life, but for some reason they never pull the trigger. So it is very important to pull the trigger. Go and choose and try and see if it works in your hand. If it works in my hand, I'm sure endoscopy will work in your hand as well. So thank you for giving me this opportunity, for letting us share our learning curve and experience with endoscopic interlaminar discectomy. Thank you so much.
Thank you very much, Dr. Ayush Sharma. It's a pleasure to have been listening to you. I think we will now move towards our last speaker, Dr. Tariq Yazir. Are you there with us, sir, Dr. Tariq? Dr. Tariq, can you please unmute yourself? Hello, Dr. Tariq.
Do you hear me?
Yes, I can hear you, sir. Can you please start your presentation?
Do you see the
Yes, we can
picture?
see your screen, sir. Please start your talk.
Okay. I think it's okay.
Yes, it's working. Thank you.
Many thanks to you, Malcolm, dear chairman. It's a big honor for me to have a chance to talk to such a high-level presentations among them. And I would like to share my opinions. As you know, I have been performing more than 30 years open surgery, but endoscope changed a lot in my mind. And I would like to, this is luckily very small amount of society suffering from this problem. Adaptation is something else. And the endoscope is a wonderful solution for this kind of people. These kind of people has a disadvantage like this, center of mass moving very different pattern, in a very different pattern. And again, sinusoidal in the axial plane, in the sagittal plane. If we do fusion here, if we do decompression and fusion, of course, we will change her life, the patient's life, too much. And another example I would like to show you, such a polio scoliosis cases. Long time ago, 20 years or 30 years ago, we have done such a surgery too much amount. This girl was very mobile, but the cardiopulmonary deficit was progressive and very negative. And I have done his pelvis balance, and she was unhappy very normally. His mobility was lower. I wish we could do an endoscopic solution for this kind of people, but unfortunately not now, maybe in future. This is a dream, but maybe one day we will do such a good surgeries better than before. And I would like to share another case now. He's 78 years old male, complains low back pain, bilateral legs pain, bilateral heel of walking, difficulty in standing up, swinging in the head, coxarthrosis, polyneuropathic problems. And during the examination, his findings, spastic gait, and he was walking a heel of position bilaterally, his gait unbalanced, very painful and difficult, radiculopathic signs of lumbar stenosis, cervical stenosis, and severe stenosis, L3, 4, 4, 5. And we planned UB. To have a chance to plan something like this is a big opportunity for us, of course. And I would like to thank my supervisors. One of them is Hayati Aybin, and the other one is Abdullah Mertar. And we planned L3, 4 and L4, 5 levels with one attempt. The way he walked changed for the better. For better, his clinical problems decreased significantly. This is his cervical picture. You see the severe compression, coxarthrosis, and L4-5 compression. And this is preoperative and postoperative after UB, 4-5, different 1 millimeter far from the before. And this is L3-4 decompressions. And this is some I don't want to waste your time, but this is radio frequency cleaning the cranial lamina. Here you can see closer. These are really unbelievable surgery. If you compare with the open surgery, these are very gentle, very nice surgery. And this is the contralateral facet osteotomy, this part, removing it. And here we have, after decompression, more or less, and the result 2 years later from the surgery, he is walking like this. Again, he has spastic paralysis, but without assistance, he is able to walk independently. Endoscopic surgery, really amazing, but we mustn't compare open surgery and the endoscopic surgery. We mustn't only just compare. And the indication is much more important than the performed surgery. For this gentleman, he has comorbidities. If he do open surgery, of course, it will be post-operative period will be very difficult for him. But with endoscopic surgery, this is quite nice, very quick, and we didn't disturb any vital signs of him, and it's very nice result. And severe pain in the waist and legs disappeared, and the heels also took part in walking. Another case, in such a case, for example, you see the sacrum, vertical sacrum. This is compensation, shows us the physiology compensation, and this is flat back. In open surgery, we have to do osteotomies, but endoscope really quite interesting. With endoscope, we can solve this compression problem very nicely without disturbing any body compensation mechanism, and we may get a very nice decompressions. Still, please pay attention, still there is flat back, and this is vertical sacrum. But after two levels decompensations, we observed there are some correction in the lumbar lordosis, not good enough, but there are some decompression. The compensation decreased, and without pain, he is doing very well. So really, I would like to thank to the minimal invasive societies, and we learned from very good mentors, and we had a very good results, patients, and as a surgeon, I'm really very happy. I would like to extend my cordial thanks to all of you. Thank you.
Dr. Tariq Ayazar, thank you so much. May I please ask you to stop sharing your screen?
Okay, stop sharing, yes.
Before we stop for today, let me please invite our chairman. Are you there with us, Dr. Sameh? A few words from your side, please. Sir, you're muted, sir. Can you please unmute yourself? Dr. Sameh, can you please unmute yourself?
Okay. Is my sound clear?
Yes, yes, sir. Welcome, sir.
Okay. This is how the greatest real Congress is. Thank you, dear friends. It was a great pleasure for me to have all of you with us today, to share your experience and teaching all of us more and more about this important subspecialty, which has the upper hand today and in the future in management of spine patients. And as my dear friend Malcolm said, it's a great challenge for all of us to prepare such Congress. 54 faculty from 27 countries. It's like you are gathering the whole world in one room. For too long, 6 months of hard work done by my dear friend Malcolm and me to put such eminent speakers, masters of the world and this subspecialty together. A lot of preparing, communicating, and arrangements to get you the best masters of the world in endoscopic spine surgery. A lot of work and work. We got a great results of teamwork for this first day and waiting for you tomorrow for more learn and learn. Great honor for all of us that the first day of our Congress goes more than any expectation. By the way, we got about 1,100 registrations for today and still increasing. We hope we have more tomorrow. When I have received the final schedule of this Congress, I have discovered that I will be the only one who will get up earlier than all speakers. But it's a great pleasure for me to do. This event have been live also on a lot of channels on Facebook and YouTube. I'd like to thank also our partners who helped us today, especially OS2V. Special thanks to my dear friends, Malcolm and Anan. Other special thanks to our IT team. It was a great effort done by you in organization. Thank you. And we will arrange from now for the next Congress that we wish to be in person and wish all of us will get the chance to join us next year. Thank you all. See you tomorrow the same time as we have started today. Don't forget to fill the Google form about today. Link is available on chat and on Aaron's Academy group too. Thank you. Dear Malcolm, do you have few words to say?
Thank you, Dr. Sameh. I take this pleasure to end today's session. See you all tomorrow. It's a big day, Sunday, for more endoscopic fun. Thank you. Thank you once again.
Thank you.
Thank you and bye-bye.
Thanks. Good night. Good night.